In a world where health finds potential, diseases become barriers to growth. Weaving dreams of a world without sickness and full of well-being, the Integrated Health and Well-being Council was formed. At its core, the Council stands for the high five of health. Good air, good food, good water, good living, and good health care for everyone. Aligned with the United Nations Sustainable Development Goals, the Council firmly works towards making sure health reaches every corner of the world. IHW Council has built prestigious forums for holistic health discourse, like India Health and Wellness Summit and Awards, CSR Health Impact Awards, CME Excellence Movement, Ayushman Bharat Conclave, Jal Shakti Conclave, Digital Health Summit, Patient First Summit, the Good Air Movement and Summit, Rapid Global Cancer Alliance, and the She Alliance for Spirituality in Health and the Environment. These initiatives have received wholehearted support from policymakers, industry captains, community leaders, health experts, celebrities, and influencers. Respected brands and advocates have also joined the council, becoming allies in the mission for a healthier world.
I think this wellness is an important initiative. I will definitely be interested to know the conclusions of deliberations. I will definitely take this issue and your suggestions forward to the logical conclusion.
हेल्थ सर्विसेज कैसी होनी चाहिए, ये तो महत्वपूर्ण विषय है ही, पर उसके पहले हमको हॉस्पिटल या डॉक्टर के पास जाने की जरूरत न पड़े, इसके लिए हमारे एयर पोल्यूशन और वाटर पोल्यूशन को हम कैसे सुधारें, इस बात पर जोर देने की आवश्यकता है। कहते हैं क्षिति जल वायु गगन सभी पंच तत्व निर्मित यह अदम शरीर, ये पंच तत्वों से निर्मित यह शरीर पूरा पंच तत्व में ही मिल जाता है। हमें उन पंच तत्व का, जिससे इस शरीर की रचना हुई है, आकाश, पृथ्वी, अग्नि, वायु, जल, इन सबका ख्याल ही नहीं रखना, बल्कि पंच तत्वों का रक्षा करना हमारा पहला कर्तव्य हो जाता है।
In the digital world, the council reaches millions with credible source of knowledge, empowering them to protect their health and prevent diseases. Through its various initiatives, harnessing the power of social media, the council impacts over 100 million lives annually. Join IHW Council in creating a world where limitless potential
एक उनसे एक्सला ऑर्डर बात उनके पास
healthier world for
एक ऑडियो उनके पास दिलवा के बता तो दो से बता तो रहे नहीं, अभी बैठे हो उन पे, अभी इसलिए नहीं बताया ना, ऑडियो वाली बोलो, एक एक्स्ट्रा वायर है ऑडियो वाली नहीं, इस पे लैपटॉप वाली
That's truly commendable.
लैपटॉप वाली नहीं, एक्सला दे दो,
We would also like to give this opportunity and our partners, our supporters that made this summit possible. We extend our sincere appreciation to our sessions partners, Sanofi and National Center, our supporting partners, and your our research partners, our Your continued support is vital to strengthening dialogue, research, and support initiatives in rare diseases. With this shared commitment towards improving diagnosis, access to vote for rare disease patients, we now move on to the formal inauguration of Rare Disease Action Summit. Each step with our like the Spolian lamp, symbolizing knowledge, hope, and dispelling of darkness. Today it also represents our collective commitment to bringing visibility, compassion, and action to rare disease community. May I now request our esteemed dignitaries in the opening plenary to kindly join us on the stage for the lighting of the lamp and request Mr. Kamal Narayan Over, founder and CEO, IHW Council, to please accompany our esteemed dignitaries on stage. Please welcome on stage with a round of applause our chief guest, Shri Ram Das Advocate, the Honorable Union Minister of State for Social Justice and Empowerment, Government of India. Please welcome on stage Dr. Singh Charan, Additional Director General, Ministry of Health and Family Welfare. India. First on stage, Mr. Deepak Arora, Managing Director, India, and Dr. Sandeep Arora, Medical Director, AstraZeneca.
ऑडियो चेक करो भैया, मुझे ही नाम नहीं समझ आ रहा कौन सा है। अरे यार कुछ नहीं है।
Researchers, patient advocates, industry leaders, members of the scientific community, and most importantly, the courageous family members of those patients and patients who have also joined us today here and will be joining online to watch the proceedings of this summit today. Good morning and a very warm welcome to all of you for मोदी जी की तरफ से चलाए गए बहुत सारे अभियान हों और चाहे सतत प्रयास हो कि कैसे दवाएं लोगों के बीच तक पहुंच सकें, चाहे वो जन आरोग्य चाहे वो जन औषधि योजना हो या जो आपने देखा लास्ट बजट में भी आप वहाँ पर थे, निर्मला जी ने फिर से एक बार कई सारी कैंसर और जो क्रिटिकल केयर
This summit is not only action summit, this summit is also the action summit. And the action is not important, the action is also important. There are many diseases, and many doctors are helping many people. आप लोग जानते हैं कि बहुत सारे अस्पताल में बहुत सारे डॉक्टर करोड़ों लोगों को बचा रहे हैं। कोविड के टाइम पर लाखों लोग छोड़कर चले गए, लेकिन करोड़ों लोगों की जान बचाने का काम डॉक्टर ने किया। तो डॉक्टर तो करोड़ों लोगों की जान बचा रहे हैं, लेकिन हमारे संसद में अपोजिशन वाले रोज हंगामा मचा रहे हैं। तो हंगामा भी होना चाहिए, लेकिन लोगों को मदद करने की आवश्यकता है। तो आज IHW काउंसिल का मैं धन्यवाद करता हूँ, जिन्होंने रेयर डिसीज एक्शन समिट 2026 जैसे महत्वपूर्ण राष्ट्रीय मंच का आयोजन किया है। यह मंच देश करता है।
आज के इस मंच पर उपस्थित सभी अतिथियों का मैं विशेष रूप से भारत सरकार की तरफ से, मेरी सामाजिक न्याय और अधिकारिता मंत्रालय की तरफ से मैं आप सभी का स्वागत और अभिनंदन करता हूं। मैं माननीय सांसद एवं इंडियन मेडिकल पार्लियामेंट्रियंस फोरम के अध्यक्ष अभी आए ना इधर, डॉक्टर अनिल बोंडे जी हमारे महाराष्ट्र से आते हैं, वो राज्यसभा के मेंबर भी है। स्वास्थ्य एवं परिवार कल्याण मंत्रालय के एडीजी डॉक्टर भगवान सिंह चरण जी, IHW काउंसिल के CEO एवं संस्थापक कमल नारायण जी, इनका नाम ही कमल है तो इसीलिए कमल पूरे देश भर में अपने को दिख रहा है, और नरेंद्र मोदी जी के नेतृत्व में कमल पूरे देश भर में बहुत अच्छा काम कर रहा है। तो ये कमल नारायण जी हमारे अच्छे मित्र भी हैं और हमेशा साल में 2-3 प्रोग्राम ऑर्गेनाइज करते हैं, सभी लोगों को इकट्ठा करते हैं और लाखों करोड़ों लोगों की मदद करने के लिए यहाँ चर्चा होती है। सोनीफी इंडिया के श्री दीपक अरोरा जी, एस्ट्राजेनेका इंडिया के डॉक्टर संदीप अरोरा जी, ICMR की वरिष्ठ वैज्ञानिक डॉक्टर माधुलिका काबरा जी और एम्स की प्रतिष्ठित न्यूरोलॉजिस्ट प्रोफेसर डॉक्टर शेफाली गुलाटी जी सहित सभी विशेषज्ञों और प्रतिनिधियों का हार्दिक स्वागत करता हूं। दुर्लभ रोगों का विषय केवल चिकित्सा का नहीं बल्कि सामाजिक न्याय, समान अवसर और मानवीय संवेदना का विषय भी है। हमारी सरकार का स्पष्ट मानना है कि समाज के किसी भी वर्ग को स्वास्थ्य सेवाओं से वंचित नहीं रहना चाहिए, उनके लिए पूरी मदद करनी चाहिए। अनेक NGO के माध्यम से, अनेक संस्थाओं के माध्यम से अनेक लोगों को मदद की जाती है और बहुत बार ऐसा होता है कि जो झुग्गी झोपड़ी में रहने वाले लोग हैं उनको अगर अस्पताल में एडमिट होना है तो उनके पास पैसा नहीं होता है, लेकिन सरकार ने भी अनेक स्कीम तैयार की है। प्रधानमंत्री श्री नरेंद्र मोदी जी के नेतृत्व में भारत के स्वास्थ्य क्षेत्र में अनेक ऐतिहासिक पहल की है। राष्ट्रीय दुर्बल रोग नीति, नेशनल पॉलिसी फॉर रेयर डिसीज, आयुष्मान भारत हर साल में 5 लाख रुपए देने का ये योजना है और अपने ट्रीटमेंट के लिए गरीब लोगों को इसकी मदद की जाती है। स्वास्थ्य और संरचना का विस्तार, डायग्नोस्टिक्स और अनुसंधान को बढ़ावा, इन सभी बलों का उद्देश्य यही है कि देश के हर नागरिक को बेहतर और सुलभ स्वास्थ्य सेवाएं प्राप्त हो। आज जब भारत विकसित भारत 2047 के लक्ष्य की ओर तेजी से आगे बढ़ रहा है, आज दुनिया में भारत का नाम बहुत ही बड़ा है। AI समिट आपने देखा है, कृत्रिम बुद्धिमत्ता जो होती है, मानव के पास तो बुद्धिमत्ता ही है, लेकिन मानव ने तैयार किया हुई कृत्रिम बुद्धिमत्ता जो है, कृत्रिम बुद्धिमत्ता से भी अपना विकास को गति मिलती है। इसीलिए नरेंद्र मोदी जी का लक्ष्य है कि 2047 तक जब भारत की आज़ादी का 100 साल हम पूरा करेंगे तब अपना देश बहुत ऊंचाई तक पहुंचा होगा। तो विकसित भारत 2047 के लक्ष्य की ओर तेजी से अपना देश आगे बढ़ रहा है और अपने देश की इकोनॉमी नंबर 4 पर आई है। दुनिया में सैकड़ों देश है, लेकिन इंडियन इकोनॉमी इज नंबर 4 नाउ, एंड आफ्टर 1 year, 1.5 years, we will go number 3. Now America is number 1, China is number 2, Germany is number 3, and India is number 4 now in the economy. तो इकोनॉमी में हम बहुत अच्छी प्रगति कर रहे हैं और तब ये आवश्यक है कि हमारी स्वास्थ्य प्रणाली समावेशी, सुलभ और नवाचार आधारित हो। दुर्लभ रोगों के क्षेत्र में हमें प्रारंभिक निदान, अनुसंधान, जेनेटिक परीक्षण और उपचार की उपलब्धता को और मजबूत करना होगा। इस दिशा में सरकार, चिकित्सा संस्थान, उद्योग जगत और मरीज संगठनों के बीच साझेदारी और सहयोग अत्यंत महत्वपूर्ण है। मुझे विश्वास है कि समिट में होने वाली चर्चाएं और सुझाव भारत में दुर्बल रोगों के लिए एक मजबूत और संवेदनशील स्वास्थ्य ढांचा तैयार करने में महत्वपूर्ण योगदान देंगे। मैं एक बार फिर इस महत्वपूर्ण पहल के लिए आयोजकों को बधाई देता हूं, कमल नारायण को बधाई देता हूं और आशा करता हूं कि यह मंच संवाद से आगे बढ़कर ठोस कार्य योजना और सकारात्मक बदलाव का मार्ग प्रशस्त करेगा, ऐसा मुझे पूरा विश्वास है। और जो समिट में चर्चा होगी, उस चर्चा के बाद जो भी आपके रेजोल्यूशन पास होंगे वो आप हमारे पास भेज सकते हैं। हमारी हेल्थ मिनिस्ट्री जो है, हेल्थ मिनिस्ट्री इस पर जो भी आपको मदद चाहिए वो मदद करने के लिए ज़रूर तैयार है। और लोगों को जिंदगी आदमी की बढ़ानी चाहिए। हर आदमी ने मेडिटेशन भी करना चाहिए। दवा लेने के बगैर अगर मेडिटेशन हम करते हैं, आप लोग जानते हैं कि मेडिटेशन की जो आर्ट है, ये आर्ट इंडियन आर्ट है। 2500 साल पहले सिद्धार्थ गौतम बुद्ध जी जो अपने देश में पैदा हुए और वहाँ जो हमारे बुद्धिस्ट मंक थे वो मेडिटेशन करते थे, दवा कोई ज़रूरी नहीं होती थी। इसीलिए मेडिटेशन भी करना चाहिए, योगा करना चाहिए, एक्सरसाइज करना चाहिए। और एक्सरसाइज भी कितना करना चाहिए उस पर भी अपने को सोचना है, क्योंकि मैंने देखा है कि बहुत सारे लोग रोज़ चलने के लिए जाते हैं, लेकिन बहुत सारे लोगों को चलते चलते अटैक आता है, बहुत सारे लोगों को खेलते खेलते अटैक आता है, बहुत सारे नौजवान लोग हैं उसको भी 20-25 साल के लोगों को भी अटैक आता है, हार्ट अटैक आता है। तो उस पर भी हमें गंभीरता से सोचना है कि ऐसा क्यों होता है, अचानक होता है। पहले हमारे गांव में ऐसा बोलते थे कि जब अटैक होने के बाद जब कोई आदमी मरता था तो वो किसी ने उसको मारा है, ऐसा लोग समझते थे। लेकिन आज लोग समझ रहे हैं कि जो हार्ट में कुछ गड़बड़ होती है और इसीलिए अटैक अचानक आता है। तो ठीक बात है, इस पर भी हम सब लोगों को सोचना है। कैंसर की बीमारी बहुत ज़्यादा बढ़ती जा रही है, महिलाओं में भी ज़्यादा वो डिसीज दिखाई देता है, उस पर भी काफ़ी इलाज चल रहा है। पहली बार अगर मालूम होता है तो पहले बार दूसरे बार मालूम होता है तो वो आदमी ठीक होता है, लेकिन लास्ट स्टेज में अगर ऐसा कुछ होता है तो कैंसर का मरीज नहीं बचता है। तो इसीलिए हमें उनको भी मदद करने की आवश्यकता है। तो मैं ज़्यादा वक्त नहीं लेना चाहता हूँ, मुझे पार्लियामेंट भी जाना है। तो फिर एक बार हम आप सब लोग यहाँ अलग अलग राज्यों से, दिल्ली से, मध्य प्रदेश से, अनेक राज्यों से इधर आए हैं, सबका मैं आभार करता हूँ। और भारत सरकार की तरफ से जो भी आपको मदद चाहिए ज़रूर वो मदद हम करेंगे, ऐसा विश्वास देते हुए मैं फिर एक बार इस कॉन्फ्रेंस के लिए हार्दिक हार्दिक बधाई देता हूँ। नमस्कार, प्रणाम, जय भीम, जय भारत। हाँ, चलो।
धन्यवाद मंत्री जी, आपने इतने इनकरेजिंग शब्दों के साथ हमें ये आश्वासन दिया कि भारत सरकार से किसी भी तरीके की मदद। मैं ये चाहूँगा कि मंत्री जी अभी 2 दिन पहले ही फिर से अनअपोज्ड राज्यसभा के मेंबर बनकर महाराष्ट्र से आए हैं और उनका जो है सानिध्य अगले 5 सालों तक हमारे लिए बना रहेगा। तो एक बिग राउंड ऑफ अप्लॉज। 6 सालों तक, सॉरी 6 सालों तक जो है उनका सानिध्य बना रहेगा। और अगले 6 सालों में मंत्री जी, वी विल सर्टेनली कीप कमिंग बैक टू यू टू टेक अप दीज सेवरल इश्यूज इंक्लूडिंग रेयर डिजीज।
Thank you, sir, for your encouragement and for the support towards the cause of rare disease. I request Kamal Umar Narayan to please present memento to our chief guest. The Honourable Minister has an important meeting in Parliament. Will be taking his leave. Please give a huge round of applause. I request everybody to remain seated and to please clear the aisles so that the Honourable Minister can exit unimpeded. I request everybody to remain seated. We will continue with our program, and I would like to introduce Mr. Deepak Arora, Managing Director, Sanofi. He leads with a strong focus on advancing innovative healthcare solutions and improving patient access to treatments. With extensive leadership experience in the pharmaceutical industry, he is committed to strengthening partnerships that drive better health outcomes. I request Mr. Deepak Arora, Managing Director, Sanofi, to please give the inaugural address. Please give him a huge round of applause.
A very good morning to everyone. I think first of all, Kamal, I want to express that I'm so happy to be back to IHW. It's been a break of around 5 years. And when I got the invitation from Samiksha, I could not stop my emotions saying, let's revive back the great work you and the team has been doing. And I've been following you, whether it was Dubai or it was South Africa, in terms of the great work which you've been doing. And advocacy is all about bringing people together. So thank you again, and great appreciation. To the Honourable Minister, who I think already has taken a lot of perspective from what I would have shared, so I will not repeat. But I think I'm also very happy to share the stage along with our Honourable Minister and mentor for many COEs, Charan sir. If you look at NPRD, it's just not the name. I think the COEs which have been formed across different states and what they are running today, I think a lot credit goes to your leadership and mentorship, sir. It wouldn't have been possible with your guidance and support, which patients, advocates, as well as PAGs are really enjoying the work which has been done. And I think from implementation to execution, I think a lot of credit goes to you all. Driving action for rare disease, I think that's what the summit is all about today. Again, a warm welcome to all the distinguished guests, Honourable Minister, health professionals, advocates, friends, colleagues. I think it's about not rare for care. I think it's about bringing the orphan designation to health priority. That's what we are all here together to really carve out a plan to look into what we can do to bring this into the national health priority. And a lot has been done by our Honourable Prime Minister. The Pharma Bioshakti, which has been already been put into the union budget, is also really showing a way in terms of what we can do together. Private-public partnership, I think that's an agenda we should be all not shying off, rather than coming together to look into whatever support can be given, because we cannot do it alone, right? To make rare disease a national health priority, I think 3 key important areas which I want to really highlight upon. One is early diagnosis. That will be the key. We know that 7,000, close to around 7,000 diseases are around. But important piece is from screening to diagnosis, diagnosis to treatment, treatment to adherence, the care. The patient loop has to be closed. And that's why I think a lot of work goes around, along with the experts, healthcare professionals, AI enablement platforms, and many of you. And the most important work is done by the patient, caregivers, and the PAGs. Treatment access, I think it's not only treatment access, I will say unequitable access for diagnosis to treatment. And there's a lot of work is being done across. One of the proud moment for me is to share that the Disha program, which was initiated in terms of bringing DBS kits to support these patients to reduce down the time from screening to diagnosis and diagnosis to treatment, was a way forward. And we are trying to represent as well as strengthen it as through the AI-enabled platforms. Example is Excel Rare. Last but not the least, I think when we talk about screening diagnosis, we cannot leave patients alone there. And that's where we need to think about what are from traditional access strategies to moving into non-traditionals, non-conventional strategies to really look into unequitable access for the patients, supporting NPRD mission and making sure that we bring in either charitable organizations, funds coming in from international support, and also looking into what we can do to help these patients for continuing the medications. Support systems will be very important. I think building the center of excellence on capacity and capability building, looking into the perspective of what data we have, and I think a lot has been done with Dr. Kabra has been the road, path giver for all of us in terms of working very closely with ICMR to look into registries, get that data, because real world evidence will always provide us the voice in terms of work done, impact made. Talking a little bit about Sanofi, I think we also following very closely to the 100-year celebration of the India's independence. We are close to around 7 decades in this country and becoming stronger along with the public partnership. We have a Hyderabad hub now, which is close to around 3,000 people, looking into how we bring R&D, early R&D, AI enabled care in terms of starting from India and giving it to capacity and capability building to across the world. Last but not the least, with our rare disease journey, if you look at starting from 1991, the first patient on humanitarian grounds, and now we are on 300 patients getting care along with the support across cross-functional team. I won't go into detail, but I think the work which has been done by Sanofi from 1991, and we're becoming more stronger, and this is all because of the guidance, assurance we get across the pillars with the public-private partnership, as well as the support which you get from the COEs and the ministries. Last but not the least, I think would like to share that there are several programs, and this cannot be completed with if you don't have the assurance and the mentorship coming in from the COEs. A robust R&D pipeline, advanced genomic medicine program, and last but not the least, the partnership. It's time now for action. I think there's a lot which can be done alone, but there's a lot which can be done together. And we should transform rare disease, again, I will say, from orphan designation to a national priority, and we're already there. So let's make it happen today. And I think, as the Honorable Minister said, we can bring back the kind of a white paper from here or consensus to get support as we move forward. So again, thank you so much, Kamal, for inviting me, and looking forward for a very, very interactive session today. Thank you.
Thank you, Deepak ji, for the address. And let's hope we do have a lot of collaboration and suggestions that can be worked upon. I would like to introduce Dr. Sandeep Arora, Country Medical Director, AstraZeneca India. He leads the medical affairs strategy at AstraZeneca India, driving scientific excellence and evidence-based healthcare initiatives. He plays a key role in advancing collaborations and strengthen research, innovation, and patient-centric care across therapeutic areas. I request Dr. Sandeep Arora, Country Medical Director, AstraZeneca India, to please give the industry address. Please give him a huge round of applause.
Good morning, everyone. Respect to our Honorable Minister, Shri Ramdas Athavale ji, who has been our pivot in addressing an important topic related to rare disease. Dr. B.S. Charan, who has been instrumental in setting up what we see today in India for rare diseases. I see Dr. Madhulika Kabra in the house, and she has been one of our guiding light, in what we do today in rare disease. The entire advocacy, the entire treatment paradigm you see across different diseases has been one of the mentors, guides, in this area. Also, friends and dear colleagues, thank you so much for being here. Thank you, Kamal. This is our, we met in Mumbai for a cancer care summit, which was in oncology, and which is another major unmet need in India. And now in rare disease, in fact, in India, we do not call it as rare disease because the rare is very common here, given the size of population we have. So I represent the medical and the scientific function from AstraZeneca. But before I get into AstraZeneca, I just want to talk briefly about rare disease. And I have been associated with this therapy area for last 5 or 6 years with my association in different companies. In fact, one of the key things which Deepak mentioned, and I kind of echo, because I'll not go into the data and stats around the diseases in India and so on and so forth, but few things. One, on the diagnosis piece. You know, the diagnosis is important in rare disease, but we have to really get into the root cause where the challenge lies. The challenge doesn't lie only in the COE. The challenge lies in the periphery. So how do we create the referral hub with COE as the main, center, and then come together, collaborate, work together in the area of diagnosing more and more rare disease patients, so that these patients are ultimately getting the right treatment, and that too at an early age or early stage, where the disease is still manageable. Otherwise, we all know that once the disease gets into a different set of motion, the things are completely irreversible in certain, diseases. So that's one. Second is on the access. Now, access, we all know that NPRD has around 50 lakhs as a one-time cost for the patient. But many of the diseases actually don't, in the rare disease area, I'm talking specifically, where most of the treatment options are available in the country, they don't really fall under 50 lakhs bracket. They are much higher. The cost of the treatment is much higher. So if I'm a practicing physician, I'll be in a double mind whether I should be starting the treatment, and if I start the treatment, whether I should stop and when should I stop. Because if I see the clinical benefit, I'll be very hesitant to stop the treatment, because that's the only treatment option available for that rare disease child. So that's one of the area, which is on duration of therapy. So it is just not, beginning the therapy, but also continuation of therapy becomes an important pillar. The third piece is related to inclusion of more and more rare disease. Now, we have around 60 to 70 60 to 70 roughly, an estimate in the NPRD policy right now. But globally, if we look at, and even in India, 90 to 95% of rare disease are not there, right? So we need to have more inclusive rare disease policy where we can include more and more rare disease. Because what we see globally, and I represent a pharma company here, we are researching in areas where the diseases are still not there included in the country. So we need to include diseases where the treatment options are available and the patients can be benefited with the right set of treatment to be included, in the policy. So that's roughly around the rare disease. Now coming back to what I represent, which is AstraZeneca, we have a legacy of 45 years in the country. We are present in multiple areas, including rare disease, starting with cancer care, cardiovascular, renal, metabolic, respiratory, immunology, and of course, rare disease. We are one of the largest companies having a very good, rich R&D pipeline related to rare disease. We have roughly around 90 to 95 global clinical trials running in India, enrolling thousands of patients across multiple sites in the country. And I'm very ecstatic that in the recent 2026 budget, Honorable Finance Minister, Ms. Nirmala Sitharaman, has announced this program called BioShakti, which is Biopharma Shakti, which is a 10,000 crore budget outlay for enriching the clinical research and innovation in the country. And this is what we need in our country for our patients. What I call as is cost-effective innovation. And when I say cost-effective innovation, it means right from the discovery to conducting the clinical trials so that the patients are benefited, in our part of the world. So I just conclude with saying thank you to the organizers, IHW here, to all the participants who have come, and we really look forward for an enriching discussion in the sessions which we see, and really get some meaningful action, because this whole summit is around action summit. So we need to have some action points, and maybe like a white paper which Mr. Deepak mentioned. I think that's a good idea to give it to the government, to give it to the policymakers, and how we can get a better collaboration, public and private, to help ultimately achieve one common goal, which is for the patient care. So thank you very much.
Thank you for the address. Definitely a greater outlay announced in the budget will boost research and development in healthcare in our country. I would like to introduce Dr. Bhagwan Singh Charan. He is ADG, Ministry of Health and Family Welfare, Government of India. He plays a key role in shaping national public health strategies and strengthening healthcare delivery systems in India. With extensive experience in health policy and program implementation, he contributes to advancing equitable and inclusive healthcare initiatives. I request Dr. Bhagwan Singh Charan to please address the audience. Please give him a huge round of applause.
Thank you. Respected dignitaries on the dais, Kamal Naran ji, Sandeep Arora ji, Deepak Arora ji, respected Madhurika Kabra ma'am, our industrial stakeholders, IHW Council team and dear colleagues, a very good morning. I am Dr. B.S. Charan. I am ADG in Ministry of Health and Family Welfare, and I am one of the team member who plan and implement component of the NPRD 2021, and I believe we all are working as a team, so I am one of the member of that team. So most of us, we know now the word orphan is, we can say, obsolete in India, at least after NPRD 2021. There is something official document is there to take care of the rare disease patient, and there are some people, not some people, we now as a team there to take care of the rare disease patients. So begin with, it's 2027 when one official document of National Policy for Treatment of Rare Disease, which was exclusively to look after the treatment part of the rare disease patient, but it was not holistic. Then again, it was in 2021, it was revised, and comprehensively now we have incorporated all the components. What Sandeep Arora ji has highlighted some of the points, that now in NPRD, we are having Center of Excellences. There is some provision from Government of India to establish the lab and infrastructure there. So, and we are expanding the number of Center of Excellence. As of now, there are 15 Center of Excellences, and our priority is that there must be at least, there should be, it's not mandated anywhere, there should be at least one Center of Excellence in larger state and one or two in the northeastern region where there is a small state. So now, fortunately, in the northeast state, we are having two Center of Excellence, RIMS Imphal and Assam Medical College, Dibrugarh. And in other areas, initially 8 COEs were notified, but eventually we increased the number, and now total we are having 15. So in coming years, there will be more number of Center of Excellences. But again, the question of accessibility, so I can assure you that now our priority is that now we are moving from Center of Excellence to the regional level, and we will create the hub and spoke model. Through that, it will be possible at the district level for the year financial year 26-27, at least our medical professional will be aware what is NPRD, what is rare disease, what we should do if we come across any suspicious or provisionally diagnosed patient of the rare disease. So that's our priority for the next financial year. And I can assure you, it's our priority area. Along with expansion of the COE, there will be the spoke, and we will have the collaboration and referral mechanism till district. I'm not committing on the below district level, CHC, PHC or village level. I think that will take another 1 year. But this year, at least to the district, we will reach. So that will solve some issue of the accessibility, and also parallelly we are working for the preventive part like newborn screening that will facilitate also. So these are some of the update. I hope the rest of the point you might be aware of that. Coming to the inclusion of rare diseases, I think Sandeep ji has highlighted this point. There is a Central Technical Committee for Rare Disease, CTCRD, and in CTCRD, we have some mechanism that based on that criteria, all the experts are there. Mainly these are the geneticists from the COE only, and based on this checklist, we have, make the criteria whether we have to include the disease under the NPRD or not, because, merely inclusion will not make the difference in the lives of the patients. The purpose is that if you are including in the NPRD, if we are having the provision of 50 lakh rupees per patient, if we are having the diagnostic facility as COE, but there must be, some sort of definitive treatment should be there. Otherwise, making the list, we don't want to increase the number, merely number, it's not our criteria. Our criteria is that, our aim is that, once it is included, we are working on that, we are finding the solutions, though there are challenges, but we should consistently, focus on that, and there should be benefit to the patient. So as of now, 63 disease or disease group have been notified under NPRD, and the list will keep on going. It was earlier when NPRD was launched, it's merely 41, so 41 to now 63, and in the coming years, certainly number will increase. So, and when policy was notified, it was the financial assistance of 20 lakh rupees, now it's 50 lakh rupees. So that again, a substantial increase. So coming to next point, for group 1, 2 and 3, we have divided the diseases. 1 and 2, we are pretty, much comfortable with, treatment part. But group 3 is still a challenge. We do accept that. Cost, yeah, there is, former friends are here. We once tried that court-directed committee on a scale of economy for central procurement, but somehow it couldn't be happen. And, now we are opting some different mechanism. But I request again that you should keep in mind that some sort of, assurance of sustainability should come from you also. Government is now, keeping this cap of 50 lakh rupees, which I think with other competing health care priorities is a satisfactory amount. It's not a very small amount. Maybe it's not very big, but so there should be some proactive steps from your side also. And we are thinking of some other, procurement mechanism, but it will be through the COE only. So that's a issue. Next to sustainability is, when we are saying that there is a capping of 50 lakh rupees, then we have to find out some other revenues. So now, fortunately, we have the Minister of Social Justice here. So the Ministry of Social Justice is one of the important stakeholders in context of the rare disease. In addition to that, we are trying that we should have the word with the state governments, because health being a state subject. And for the CSR, there is one dedicated committee. And now we are hopeful that when we reach to the, a larger group, maybe PSUs, maybe private industries for CSR, then there will be, some sort of help, and we are very hopeful. That committee is constituted under the chairmanship of our member health also only, and so I think I will. I once again thank IHW Council. Please have the discussion of all the stakeholders, and whatever be the suggestion and solution for us, we will happy to have the word with you and try our best to incorporate in on NPRD in all in patient well-being. So one thing I can assure you that we are approachable. Whatever be your suggestion, it should be in the patient interest only, and we will be happy to help, and we will be happy to work as a team. Thank you very much.
Thank you, sir, for your address, and we are grateful to the government's efforts, and let's hope we will be able to expand the number of diseases being covered in the criteria as well. I would now request Mr. Kamal Narayan Omar to please present mementos to our speakers. We are grateful to them for coming here and sharing their vision with the audience. I request you to please present a memento to Dr. Bhagwan Singh Charan, ADG, Ministry of Health and Family Welfare, Government of India. A memento for Mr. Deepak Arora, Managing Director, Sanofi. And a memento for Dr. Sandeep Arora, Country Medical Director, AstraZeneca India. I request all of you to please gather for a group photograph. I request all our dignitaries on stage to please gather for a group photograph. Please give them a huge round of applause. We would like to thank all our dignitaries of the opening plenary. Thank you all for your presence here. I request you to please take your seats off the stage. And once again, thank you to our esteemed dignitaries for setting the tone of today's summit and for reminding us that addressing rare diseases requires collective responsibility, innovation, and compassion. Now, with that powerful beginning, we move on to our first knowledge session of the day, focusing on one of the most critical challenges in the rare disease ecosystem, which is sustainable funding for rare diseases. While scientific innovation continues to advance rapidly, access to treatment often depends on financial accessibility and sustainable support systems. This session aims to facilitate meaningful dialogue among corporate leaders, policymakers, healthcare providers, and patient advocacy groups on how CSR initiatives, government schemes, and innovative funding mechanisms can work together to enable timely treatment access for curable rare diseases. Joining us for this important discussion are our distinguished speakers. Ladies and gentlemen, please give them a round of applause and welcome our speakers on stage. Please welcome Ms. Sri Lakshmi Nalam, co-founder and trustee, Patient Advocacy, Cure SMA Foundation India. Please give her a round of applause and welcome her on stage. Please welcome Professor Dr. Sanman Singh, former Director and CEO, AIIMS Bhopal, and Founder and Director, Accord. Please welcome Dr. Monica Pahuja, Scientist E, ICMR, and please welcome our moderator, Dr. Ankit Pandhari, former Business Unit Head, Rare Diseases, Takeda. Please give our speakers a huge round of applause. And I'll hand it over to our moderator to take the discussion forward.
Good morning, everyone. What a great morning today. We all know that rare disease in India is in a very, very interesting times. There are so many stakeholders who are really working very hard to see that our rare disease patients get what they truly deserve. It was so encouraging to hear Honorable Minister speak, Dr. Charan speak, and there were great insights that gives us hope, courage, and conviction that our country is on the right path for really our patients who wish to access not only the diagnostics, but the true treatment, comprehensive treatment for them to live a near normal life. This topic, as we all know that for the last several years after the release of National Policy on Rare Diseases, government earmarked 50 lakh rupees for once-in-a-lifetime assistance for our patients. That has sparked lots of debate, positively, and also in anticipation of better care. It has helped many patients so far, and there are so many others who are looking as all the stakeholders in lots of anticipation and hope that it will further improve. However, the current nature of funding is once in a lifetime. We all know, Kamal spoke about it in the inaugural session, about 7,000 rare diseases. 400 plus have some kind of record in the country. About 60 plus are in NPRD. So all of them are very, very different diseases. A question which plagues everyone's mind is, How do you treat them differentially? How do you ensure that this funding and access to treatment is not only once in a lifetime, but sustainable? We do all understand it's a very complex maze. In a resource-constrained country, where there are conflicting priorities, to shell out huge sums of money for one health priority could be extremely challenging. And that's exactly what we are here to discuss, that what are the alternate ways of financing the rare diseases, how the alternate channels such as corporate social responsibility funding from not only private sector but public sector, and any alternate ways such as crowdfunding can be of some use, some help to make our patient access the treatment. And to join this conversation on sustainable funding, I am joined by a distinguished panel. I'm so delighted to have these experts, panelists here who can really provide a lot of prudence, wisdom, and guidance and carry forward this conversation. I would welcome Ms. Sri Lakshmi Nalam, co-founder and trustee, Patient Cure SMA Foundation of India. She has been at the forefront of patient advocacy and support for the patients of SMA. I have been following this work from a distance. I am very, very happy to have her here as in the panel, and I'm sure she will throw lots of light on how a patient organization can support in this endeavor of improvement of sustainable funding. We do also have with us Professor Dr. Sarman Singh. He has held many prestigious leadership positions in the public healthcare sector. Recently, as former director and CEO, AIMS Hospital, Bhopal. He is also the founder and director of Advanced Center for Chronic and Rare Diseases. He brings decades of experience in public health at very, very senior positions, and his point and deep insights from the public health point of view is going to be of immense help to us in this session today. We're also joined by Dr. Monica Pahoja, Scientist E at ICMR. We all know that evidence generation, data, research, science has to play a tremendous role. How our scientists provide adequate data, right evidences for our policymaker to frame right data-based decision is where she will talk a lot about these aspects, and also how that this academic and research portion can also elevate the funding in a more scientific basis. So very happy to have esteemed panelists over here. As we say, we're all here, all the stakeholders are here to see the great lives of our patient, and hence, I would like to start my discussion with the patient organization, Sri Lakshmi Nalamji. There's a question for you. The question is, from the perspective of the patient advocacy organization, you are closest to the patient. We all can empathize with the pain, but the pain which you live through the patient, the families, is only known to you. And there are so many barriers and bottlenecks in the patient journey. We all are, kind of aware of it. The diagnostic odyssey someone spoke about in the morning. So many treatment gaps, so many pain points in the patient journey. But purely from the funding point of view, if you can elaborate for our audience over here, that which are the biggest financial barriers the family of a rare disease patient, go through, and what all happens in this patient journey, if you can please throw some light on this. Oh, can you have mic, please? Mic, please. By the time we have mic, there are several patient organizations in the country. As I said, 60 plus diseases in the country, in the NPRD itself, 400 and more recorded for in the India. Still, we do not see as many patient organizations. There are organizations who are doing the work at the broader umbrella of rare diseases, and then there are disease-specific patient organizations. We have seen the evolution of this patient organization. And yeah, so let's hear from you. Please, go ahead.
Good morning, all the distinguished guests. I would like to first thank IHW Council for giving us the opportunity to be part of this very important session. Thank you very much. And as of today, with the increased population and advanced diagnostic techniques and growing awareness, rare diseases are not as rare as they once used to be. So we are seeing that the people across the country, lakhs of people across the country are being affected by number of rare diseases, but still the amount of support we get for them is still very fragmented and very little. So from the government's point of view, we see that the government has come up with a very important initiative, that is the National Policy for Rare Diseases, which helps to provide support for financial assistance and other support. But still there is a long gap between the need and the funding that is being provided. If you see the patient advocacy organizations, the patient advocacy organizations are working very closely with the patients and their families, and they are continuously working to work for the, they're continuously working towards increasing the awareness about the disease to the patients and their families, and working for better management of the disease. So in doing this, they try to create the awareness where they learn a lot, and in this process, we see that the patients are suffering a lot not only in the medical aspects of the disease, but also they have overwhelming challenges financially and systemic challenges. As a mother of SMA child myself, and a patient advocate who's dealing with the many families with very close quarters, I have seen that there are number of challenges these people come across with, and we understand that the most important reality is, even though with little government support, one single state cannot solve the whole problem of the funding. So if you see what are the problems that we are facing here, the rare diseases are generally long-term problems, they are chronic in nature, and so they need a long-term support. Now, in case of these children, they are continuously requiring a lot of finances in the form of continuous support for them, continuous hospitalization, regular medical and assistive devices and all, to have a very basic lifestyle, and this puts a lot of pressure on the parents, and all this is happening without any support from the government or any insurance sector. They are paying all the money themselves. So this brings out the hard reality that it is extremely non-sustainable for the parents to go through all these things. So according to us, we feel that there should be a collaboration of more than one stakeholder to support the long-term financial problems and other support, such as access to the treatment and all, so that they can have a better management of the disease.
Thank you so much. They are deep insights over here. Sometimes we do see the funding problem from the point of view of access to treatment. Rightfully so, because there's a significant amount of funding which goes in availing those drugs. But apart from this, there are many other issues which ma'am highlighted very appropriately. The day-to-day need, so many other med devices, so many other day-to-day expenditures which a patient family has to go through. We have been hearing a lot about crowdfunding, alternate method of funding. And there was a crowdfunding platform initiated by Government of India. And when I was preparing for this panel, I went through to refresh my memory of those numbers. What I found was the number over there in terms of donation was still hovering around 4 lakh rupees. Very, very less compared to what the government would have in the past. So that brings us to the next question. Where are we in terms of this alternate source of fundings? CSR especially, and again my question to you, Sri Lakshmi ji, because I see you guys do a lot of work in arranging for the funds for individual patients, navigating this complex journey, also going with so many other corporates and a non-corporate organization. In your experience, if you can speak about, what kind of challenges do you face over there? What kind of attraction is being generated on this alternate source of funding? And how do you see this unfolding? Is it temporary bridging, or do you see it will really become huge, funding channel for rare diseases in the near future?
Rare diseases, as I said, require a lot of awareness. Cure SMA India, we work with a lot of key stakeholders, and while working with the corporates, we understand that their awareness about rare diseases is very, very limited. They do not understand anything, and any name, suppose SMA, they do not know anything about SMA. So the first challenge we come across is to create the awareness about the rare diseases for them to understand and be empathetic towards them. For any of them to support even the rare disease programs, they need to understand the severity of the disease. So the first approach is to create the awareness. As an organization, we are approaching a number of corporates, and we have done a lot of awareness programs and engagement activities with the tech giants like Microsoft India, Google, Cinity, and all. So in the awareness programs, our children who are SMA warriors themselves, the most effective part of the session is generally when the parents and the SMA warriors themselves share their journey, and then they understand how difficult their journey is. They show their empathy, and they try to understand how they can help these children through CSR initiatives and all. We also have a lot of programs like Wheel and Walk the Talk with the SMA warriors, where it's an interactive program, and in the wheelchair the children are walking along with the Microsoft employees, and they discuss and they interact with them. We also have certain art programs, and we had for the last 2 consecutive years cycling programs, cycling awareness programs with the management of the Microsoft. So all these things helped us to bring the visibility and create that empathy within the employees, and for them to understand to do what. And we also, the translation from the awareness to action is not soon. It does take time. So we need to build upon the awareness and partnerships, and also align on the CSR priorities. And only then we can expect any donations and all. So we were fortunate with the company called Cinity, now which is a part of Capgemini. They understood the various problems, challenges of the SMA warriors, and they came ahead to support our children with various assistive and medical equipment, and because of which the children have really gained a lot, and they are having a better quality of life, as they have some respiratory support devices, medical devices, and wheelchairs which help them to give their independence. So these programs help us to, we also use these programs to create the awareness about the prevention of the diseases. We are just not asking them to understand about the disorder, but we are also giving something back. We are asking, because corporates have a lot of young crowd, and they are also prone to, their children are also more prone to rare diseases. So we give them the awareness about how the rare diseases will affect them. In our case, it's only SMA, we are limited to SMA. So we tell them how the mechanism takes place, how it can be prevented, and all those things, so that they can help to reduce the risk in the future generations. We also have some community program called Run for SMA in Hyderabad. We initiated in 2023. This is a community program where people from all walks of life come together, along with the corporates, policymakers, industry people, and all the people come together and they run for the SMA children. This program is creating a lot of awareness among the general public, and we see that SMA is becoming a little more commonly heard word, not as much as the others, but at least the people are able to identify, yes, that is a genetic rare disease. We also use this opportunity to create the awareness for prevention among the masses also, and we have a genetic genetic lab diagnostic center where they help in diagnosing genetic carriers. So in this way, we are working with various corporates, and but even after working with all these corporates and all, what we feel is this process is not very sustainable or long term, as it is very episodic and very isolated. It does help, but it cannot take on the whole responsibility. So we feel the major critical gap in the treatment of rare diseases is that we do not have any insurance coverage. This is the biggest problem because the parents have to bear all the expenses themselves, and in these cases the hospitalizations are also more because of the weak bodies they have. So we request that the insurance sector also be made a part of the rare disease care, and meaningful insurance programs should be given, policies should be available for the rare disease parents, where they can contribute and take these policies, and it will help in the long-term long-term financial support to the parents of the rare disease programs. So ultimately, I would like to say that we should move from one-time funding solutions to more sustainable long-term solutions, where the parents and the children get support for a longer time. And before ending, I would also like to say one more thing. The patient advocacy organizations are working very closely to with the patients and their families, and they have a very in-depth knowledge of the difficulties and various challenges they are facing. So these organizations should be made a part of the policy-making decisions so that people get a better idea of the challenges that are being faced, and they can find a solution more appropriately for them. Thank you.
Thank you. So clearly, what we gather in terms of insight from these points are that though it remains a critical area for alternate sources of funding, but still highly episodic and as good as the person who is seeking the support. So I will just synthesize in two ways. There's one approach of bottoms up, each patient organization navigating this complex journey of securing alternate sources of funding through CSR, versus a top-down approach where government can provide a very clear direction and guidance to the companies to provide and contribute toward this cause. I do understand from what Dr. Charan said in the morning that there's already a subcommittee which is looking after this, and hopefully in times to come we'll have far more structured, more direct guidance on how do we really leverage CSR funding for rare diseases. We also heard two critical asks from PACS. One is the insurance companies must be covering the rare diseases. Secondly, PAC, because of their deep knowledge of the patient journey, should have a seat on the policy framing. With this, I move to the next aspect of this conversation. I'll just pick from insurance coverage. We do understand that apart from private insurance coverage, there's also lots of government health schemes. There are lots of government health programs. And the question which people have in their mind is this NPRD going to work in isolation as a funding entity and vehicle, or is there a merit in integrating NPRD with other health schemes? For example, Ayushman Bharat, for example, National Health Mission. So we do have, Dr. Sarman Singh, who has had tremendous experience in public sector. Sir, my question to you is, from the standpoint of view of the public health institutions, do you see that NPRD can better integrate with other health schemes of the country? And if at all this were to happen, what are the systemic changes which are required to accomplish it?
Thank you. I am really thankful that IHW organized this meeting. I would start with, because I can see Dr. Malik in front of me, the first cost bearer in this country was Dr. Visima from AIMS, and Dr. Madhulika. And so she took it forward, and we worked almost 3 decades together at AIMS Delhi. The biggest problem, I will take a few minutes to continue what she said and then I will come
Sure.
to the national policy. I think the biggest issue is we should not forget that two speakers from the industry partners we were having in the morning, and one from the government of India representative, and probably Dr. Charan is gone, but two are here around. I can see them. I think the biggest challenge, as she also mentioned for SME only, but for all the rare diseases, we know that there are, if you see the world literature, there are more than definitely 6,000 to 7,600 diseases. They are reported worldwide, they are listed. But in India, Dr. Charan also endorsed this, that only 63 are listed. And there are multiple perspectives, they can be. But I think the first thing is that awareness, and awareness comes from the doctors first. Most of the doctors, if you see, they are not aware, so the diagnosis is very important. Probably we are talking of the financial issues, 50 lakhs or something, or the insurance, but the cost which the parents, they go in before the child is diagnosed that he is having this kind of disease, that is humongous. That is, and not only, in cost, but also time. And many times in our society, because we know that, many of the parents, they will think, कुछ नहीं होता है, कितने डॉक्टरों को दिखा लिया, कुछ पता नहीं चल रहा. And then, most of these, I think Dr. Madhulika, when she speaks, she will vouch for this, that many of the parents, they will stop going to. So that is, and many of the children, they die, or the whatsoever, the unfortunate thing they happens. So that is the first thing. And then, of course, I must say that Government of India, Dr. I.C. Verma and Dr. Madhulika and other stakeholders, they started, and the policy was formed in 2017. And now, of course, multiple revisions, and these people, they did lot of, inside work, lot of, inputs they gave, and then finally it was, it is now we are having, the policy is in place for last 5 years. And as Dr. Charan was saying that, earlier there were 42 diseases, now 63 diseases which are listed. We know that there are many other diseases in India too, but why, probably Dr. Madhulika will be the best person, why these so many other diseases, they are not yet listed, which are worldwide. There are, hundreds of diseases which are listed. Most of these diseases listed, they are from the Caucasian population. That does not mean, if we don't know, that means it is not happening. So many of the diseases probably we are not able to diagnose. That is the reason. And if they are not diagnosed, obviously we can't put them on the list. But, I was seeing that most of the countries, including our neighbors, the China, Singapore, all these countries, they are having list of the rare diseases in their list. And they also have definition that how much, what prevalence rate should be there. India, unfortunately, even though we are, third or fourth, whatsoever economy we are not having any, official documentation, even in the policy, that what percentage, what prevalence rate we will call that disease is a rare disease. So this is, I think the most important thing. So policy, Dr. Madhulika will take note of that, that at least we should have whatsoever diseases, 63 diseases we should have. Even for these diseases, we don't have that, 1 in 10,000 or 2 in 10,000 or 1 in 2 lakhs. How many or how much of the number we should call as a definition for the country? What is the definition of the country? I think this is very important. The policy is definitely, they are working on it. I am sure that, the inputs from the technical know-how and the academicians like Madhulika, Dr. Sefali, I can see Dr. Bhavana is also coming. So I am very happy that these three, senior professors, they have been doing a lot of work. But again, then question comes the diagnostics. So diagnostics, I have taken a great challenge to establish this center. And but many of the doctors or those who want to invest in the private sector, they don't venture on the rare diseases. So this is because this is a very not a easy money making clinical setup. So this is also a great challenge because the other there are multiple disciplines, because it is not so much rewarding to the treating physician or a person who is establishing the setup. So for both, this is not one. And also because not many pharmaceutical companies, they have so much of turnover. So obviously their support is also limited. We should see from their point of view as well as from other point of view also. Because the pharma is a business houses. So they also see that what is the turnover of that investment, how much we can get from that. Like genetics, when it started, earlier days it was not. So genetic screening and the molecular technology, when they came, in the beginning this was also not very great market, and not many people they were in the business. But now slowly we know that everybody these days in genetics. So similarly, once there is a awareness, I am sure that the companies, they will also venture into the development of the newer drugs. Most of these drugs, which are very, very costly, they are being manufactured by the Western world. And even though there are some of the molecules which are so hugely priced, and it becomes sometimes very difficult, because I know some of the diseases, the patient or family or the advocacy works, groups, they will reach to the ministry. There are special provisions, they will get it approved, and then they will get it. So this should be, some system should be in place, rather than advocacy group they go. So that's what she was saying, that insurance or some resources, the CSR, cash funding is one. But I think rather than cash funding, the 50 lakhs, as I said in the beginning, that the policies should have included like PMJY or like RBSK, something like that. In RBSK, if they can have the policy that not only the after diagnosis, but also pre-diagnosis, how much, of course, all documentation has to be there. So they can reimburse it. So that will be, I think, more useful than the family. They can get motivated, and of course with the help of awareness and awareness groups, and so that they can go. Sometimes the child is having some treatable disease, not actually as per the definition of the rare disease, but if diagnosed, then obviously they should have support system for that, and tracking can be done. Number one. And then the policy, as she also very rightly said, that all stakeholders, they should be part of that. I am sure that they are there, but probably more pharma people, they are already, I think they are there. And so they representative from these companies, and they should also be part of advocacy groups. Many advocacy groups are already there in that the policy making documentation. So they should be there, and I think if it is included, the PMJY and the RBSK, two schemes Government of India they have. So if they can be included in the policy document, number one. Number two, I think more diseases, they need to be identified and listed. And number three, I would say that at least now the policy document was released or approved in 2021. Now it is more than 5 years, so now it is a time that we should have at least the prevalence document somewhere, or if not, the prevalence data is not there. Registry is already, I think ICMR has already started, and it is long back. So registry is there. Now if registry is there, then I think this is the time that we should have our data. India is not a small country, and we should have our say that, if you see the list, There are all countries, they are there, even our neighbor countries are there, but India is nowhere. So that we should have, it doesn't reflect nicely. So this, and I think the fourth aspect, I would say that, cost cutting, as I said already from the company point of view, I already said that they also have their constraint, but still, they should have some regulatory mechanism, so they cannot, charge anything or any amount. So they should have some CSR funding, and it should be for rare disease, because they have CSR funding, like, any company, they have 2% or 1%, whatsoever it is. But they should have a fraction of this CSR fund for rare diseases also. I think that will make a lot of difference. Thank you.
Thank you. Deep insights flowing from there. To me, the aha moment was when I spoke about existing government schemes such as RBSK. We know that the diagnostic odyssey for a rare disease can last up to a decade, 8 to 10 years easily, for a patient to have a confirmed diagnosis. But if you can really integrate diagnosis of rare diseases in the early childhood in the program like RBSK, we can really reduce that time significantly. These are existing established diagnosis programs. They already screen about 30 plus diseases. If I'm also taking this cue from what Deepak spoke in the morning, that some of you really provide DBS kits to the relevant stakeholder. I was just imagining when sir was saying that if in the RBSK nodal offices, if they had DBS kits and these physicians are trained to pick those early symptoms, we can really compress the diagnostic journey significantly. Another point we spoke about was it's not only the government which is going to come forward. We also have to look at the corporate sector, be it private, be it PSUs, to come and contribute. Third aspect was inclusion of many other rare diseases in the policy document today. We only have 60 plus, but I will just say that inclusion is one thing and real impact is another thing. We also have to look at the disease area which has already been included, what kind of action are happening over there, and what kind of tangible, real patient outcome are we seeing over there. Thank you very much. I'll very briefly touch upon an example. I'll draw a corollary from hemophilia. Hemophilia is relatively more mature in the country in terms of the journey of funding and care. And back then, about 15 years back, this is exactly where today RD space is. Fortunately, we have a policy for national, rare diseases. For hemophilia, even now there's no policy. But the contribution from the government in terms of funding has grown very, very high in leaps and bounds. So I'm just taking a cue from there. A pivotal movement for hemophilia came in 2014 when National Health Mission was also integrated into hemophilia care. And that was the day hemophilia funding soared. The NHM works very closely with the state. They are also kind of executioner. They have far more insight as to what's happening on the ground. And in our experience, we saw that that area really flew very well. Maybe something for us to pick some cues from that therapeutic area as well. I go to the next point over here. And before I go to that question, I'll just give one statistics. We all know that 50 lakh is the ceiling for any funding support for rare diseases. And look at the spectrum of diseases. We have so many diseases, and I'll give an example of hereditary angioedema. For hereditary angioedema, in 50 lakhs rupees, a patient can be easily on 6 to 7 years of on-demand treatment and 4 to 5 years of prophylactic treatment. On the other hand of the spectrum, we have ERTs for, say, Gaucher disease or MPS II, where in 50 lakhs rupees, a patient can probably be on treatment maybe 6 months to 1 year. How do we really bridge this kind of, if I may use the word disparity? Because painting all the disease with one brush may not be the appropriate solution. So, sir, this is a question again for you, because you help these academic institutions. How our institutions like, AIMS and other COEs can contribute to evidence generation, data generation, which can really help government to make those differentiated decisions which are far more practical and will lead to far better patient outcomes.
Thank you. So this is also very pertinent question. I think so far as per the policy document, so far there are 11, and now somebody said that 15 centers identified in the document by Ministry of Health. And if you see that in the North India, where maximum cases are from the UP, Bihar, Maharashtra, and these states. If you see the Bihar onward up to Delhi, out of these 11 centers, maybe only 3 days back updated information, maybe they have increased. So only 3 centers in Delhi, Maulana Azad, AIIMS, and Sanjay Gandhi. So North India, these 3 centers are covering. Now another thing is I think academia, people like Dr. I.C. Verma, Dr. Madhulika, and the colleagues, they have been generating the data. But this data generation has not been, for whatsoever reason, mainly because of the funding, to the private sector. For a short stint, I was also in a private medical college. And I see that, in private medical colleges or private centers, they are, hardly bothered about that. They try to avoid this kind of patient because they think that it will be their liability. So they think, so these are the only institutions they are doing. And to continue with that, so these institutes of high repute, they are doing. But again, I would say that, not every patient will be referred to Dr. Madhulika Kabra. Even in AIIMS, for example, forget about the primary center reaching to a suspected rare disease and reaching to, even within the AIIMS, sometimes you will take, multiple visits. So these institutions where, visit itself or appointment itself is a real problem. And therefore, even though ICMR has started registry, and I am sure that these 11 centers, or 15 maybe, but 11 definitely, these centers, they have the registry and they are reporting all diseases. So I think this data generation is very, very important, and this should be robust data. This is also sometimes, I am not, questioning any, data creator or data thing, but definitely most of these, the data, they are from the project mode. Because I have worked 3 decades in AIIMS, so I know most of the projects Dr. Madhulika did, they are on the project mode. But if you go outside the AIIMS doesn't have any provision for that specifically, or the government also doesn't have any provision for the diagnosing to treatment. So this should be inbuilt in that. So that is very, very important. So data, hardcore, robust data has to be created. And once this data, as I was saying in the previous answer of the previous question, if that data is available, then I think the listing, as we were discussing, that list should be updated. The more centers for excellence, they should be, created. That will be, I think, very important. And I would even go that, as I was saying in the RBSK scheme, the awareness and the fellowships or that kind of teaching to the primary health centers like, the IUs and manpower, whatsoever manpower, even why not nurses also. Nurses also, they should be trained at least to screen and at least to refer to the appropriate center for excellence. I was hearing Dr. Charan was saying that Haven spoke. So they are having, I think this is very good suggestion ministry is thinking, and that should be implemented as early as possible. So that will be very, very useful, so that, they know that, their patient where to refer. So they are aware, there is a protocol is there that what to do, what not to do, and how to refer, and so there is a networking. I think that will be most important.
Thank you. Dr. Monica, ICMR is at the forefront playing a key role in rare disease, be it policy inputs, be it data management, be it evidence generation. Talk to us through how can ICMR, other government bodies, industry can come together and do some innovation in the financing models. We keep hearing about should government pay for it all, should private sector come forward, is there adequate innovation happening from how we structure the pricing and the funding for these diseases? Any thoughts on this?
for making me part of this important dialogue today. Before I give answer to your current question, I just would like to elaborate what sir already said. Currently, all COEs, not only the part of the registry, they're also the part of the clinical trial unit. So that any drug, any therapy coming up in the near future, we are ready for that. We are ready for the clinical trials. Coming to the funding, lots funding is available. There are many opportunities, not from the ICMR, but from other funding agencies also. ICMR realized this need of more research and development in the area of rare diseases, I think 3 years back. And from there onwards, we included rare diseases in our priority listing of disorders. We try to have more and more projects for the funding for rare diseases. Not only So, not only from the perspective of discovery, but we are also venturing more in development. We are ready with the molecules which are discovered by our researchers. We are the academic researchers, I'm talking here, the academic researchers. So we would like to take those up because most of the academic researchers here in our country, they are basic researchers. They are not very much well versed with our regulatory things. So we try to develop a support system where we can support them in their regulatory journey. So that's how we came up with Medtech Mitra and Patent Mitra, which are now ready to take up all the trials, all the devices. Maybe it's a medical device, it's a rehabilitative device through our clinical trial unit, through our Medtech Mitra program, through our Patent Mitra program. We are also giving assistance to all the researchers for any of their therapies, molecules which they or the processes which they believe can be patented. We welcome them to just come to us. We will take up their case and we'll try to get them patented. And based on the further journey, we are here to take up their total development. This is what academic researchers are all about. Coming to the companies. Although we know that earlier companies were not coming in this field because of the rare, but most of us will now acknowledge that in the recent decade, we have seen number of drugs now coming to the markets for these diseases. So I believe the companies also knows market is there. So that's how they are coming up with the new things. So if they are coming up with the new things, in any drug development process, the maximum time and the maximum resources are required in the clinical trials phase. So that's how ICMR is now pitching in. Although ICMR is not going to fund any company as per our mandate, but we are ready to collaborate with the companies, any startup, any big shot. We are ready to collaborate. We will be ready to de-risk their clinical trials. We will be taking up the clinical trials and will be funding the sites directly, so that once it's de-risked, the companies can come up with good pricing for the nation. This is our only goal, so that those drugs, those therapies come to the patient at fast pace as well as at prices which are affordable. So this is what research system is coming up, not only within the ICMR, but also in dialogue, close dialogue with the Department of Pharmaceutical. They recently, many of you must be knowing that they recently came up with a PRIP scheme, and many of the companies must have given their applications also. Therein also, through dialogues, they came up with a priority list, and rare diseases is one of them. Among six priority list was there, and rare disease was one of them. So this shows that we are trying whatever way possible within our limits, within our scientific review system that makes these drugs, these therapies come to the country at the fast course.
Thank you. You covered it very well. I'm glad that ICMR is looking at not only the data and the evidence generation, but also playing tremendous role in bringing the paths, breakthrough technologies, therapies in the country in the real time. Since there is no panelist from the industry, maybe I represent industry, that although the question is asked that industry should lower the prices, very genuine, very respectable ask. Let me put forward that viewpoint. Industry is always for it. When industry innovates any molecule, unless there's a patient access, unless there are patients who are really availing the treatment and improving their lives, there's no point for industry to even manufacture those products. But there are various kind of contracting agreements which are under play. My request to the procurement agencies, the Government of India, is do not only look at the direct cost. That's one very myopic way of looking at things. There are different innovation in this field, including with the developed nations. They get into different sort of agreements, outcome-based agreements, risk-sharing agreements, cost caps. There are many methods available through which industry and the government can partner with the ultimate purpose to make our drugs more affordable to our patients. I am mindful of time. It was so nice to have distinguished panelists over here. We discussed array of topics, ultimately looking at how can funding become sustainable funding, not only episodic and once in a lifetime. Only when that happens will we do real justice to our patient. We are also acutely aware that governments also have conflicting priorities, and all the multiple stakeholders include PACs, scientists, researchers, physicians, industry are all working with the same intention of making a real impact on our patients' lives. With this, let me sign off. Thank you. Yeah. One last point.
Because he is from ICMR, I would just add, maybe you can, because you are making a point. So I think the ethics committee recommendations in ICMR, they were revised last in 2017. And the document was prepared, approved in 2021. I think this is the right time. You can take it up. And so ethics committee regulations also, they should include the rare diseases. Yeah.
So the dialogue is already started.
Thank you. We are in a good space. Thank you very much. Thank you.
I request our speakers to stay on stage for a minute more. We want to thank them for coming here and sharing their thoughts with the audience. I would request Nikki Gupta, founder, Teamwork Communication, to please come up on stage and present mementos to our speakers here. We want to thank them for coming here and sharing their views, their thoughts, their opinions with the audience. I request Nikki Gupta to please present a memento to Ms. Sri Lakshmi Nala, co-founder and trustee, Patient Advocacy, Cure SMA Foundation of India, Hyderabad. A memento for Professor Dr. Sarwan Singh, former Director and CEO, All India Institute of Medical Sciences, Bhopal, founder and director, Advanced Center for Chronic and Rare Diseases, Accord. A memento for Dr. Monica Pahuja, Scientist E, ICMR. And a memento for our moderator, Dr. Ankit Panthari, former Business Unit Head, Rare Diseases, Takeda. I request all of you to please gather for a group photograph. Please give a round of applause to our speakers on stage. Thank you so much for coming here and being part of the Rare Diseases Action Summit 2026. I request all of you to please take your seats off stage. We will go ahead with our next session, but we'll just take 2 minutes to set the stage. We will have about 5-6 speakers for this session. In the interim, I will introduce the session to you. And the third session is focusing on rare diseases with curative options, particularly highlighting the progress made in conditions such as spinal muscular atrophy, SMA. Scientific breakthroughs in generic therapies, precision diagnostics, and advanced treatment pathways are gradually transforming the rare disease landscape. However, ensuring that these innovations translate into accessible and sustainable care pathways remains a key priority. This session will explore how innovation, policy support, and patient community engagement can work together to bring curative therapies closer to patients. So please welcome on stage our speakers for this session. Please welcome Dr. Madhulika Kabra, Emeritus Scientist, ICMR. Please give a round of applause and welcome Dr. Kabra on stage. Dr. Bhavna Dhingra Bhan, Professor of Pediatrics, AIIMS Bhopal. Please welcome Ms. Alpana Sharma, Co-founder and Trustee, Cure SMA Foundation of India. Ms. Purva Mittal, Regional Coordinator, ORDI. Professor Shefali Gulati, Chief, Child Neurology Division, AIIMS. And please welcome on stage our moderator for this session, Mr. Srimanta Bhattacharya, Director, RS Associates. Please give a round of applause and welcome Mr. Bhattacharya on stage. And please give a round of applause to all our speakers who are with us now. I'll hand it over to Mr. Bhattacharya to take this session forward.
Good morning to all of you, and so I am Srimanta Bhattacharya. So I represent RS Associates, a healthcare market research company, and I thank Kamalji and entire team for organizing such a wonderful program. So congratulations to IHW Council as well. So we have a very, very distinguished panel, and so the topic of discussion for this session is rare diseases with curative options, changing the rare disease landscape, advances towards a care. And the focus area for this session would be SMA. So we all know SMA, it's spinal muscular atrophy, neuromuscular, degenerative, very, very progressive, fatal rare disease. And a lot of things have happened in recent times, in last 3-4 years in this space, as far as India is concerned. So we have possibly a curative option. We'll pick the brain of our eminent speakers here to talk about that. So there has been new product launches, there has been litigations, there have been major policy breakthroughs also at central government. Some of the state governments, they came up with their own policy framework to support access to SMA treatment. So lot has happened. And without much ado, I would straight away move to our distinguished panel here, and would like to learn from their view, because they are the ones who are. And we have a panel which comprises of scientists, policymakers, clinicians, patient advocacy. So it by and large covers the entire ecosystem of rare disease, so to speak. Now, my first question would be to Dr. Kabra to begin with. She's the one who has seen the entire journey of rare disease, someone who has been involved with rare disease landscaping in India for last probably over 3 decades now. So my first question, and the question would have 2 parts to it, ma'am. So part 1, I would request you to talk in general as someone, who has been involved with the genetic rare disease for such a long time, how the landscape of genomic or genetic rare disease has evolved in India over a period of time. And then specifically, if you bring your focus to SMA as a disease, and if you can throw some light into that.
Okay. Good morning, everyone. Thank you very much, and I would like to thank IHW Council for inviting me here for this important summit. Okay, so this is an important question, and I feel really happy about this, that over years, like I am working in the area of genetics for almost 35 years now, but the advances which have happened all over the world and now in India also are really tremendous. So this journey, what it has shown us is that the diagnostic facilities have improved over time tremendously. So to begin with, most labs would have cytogenetic facilities and some biochemical genetics facilities, and later on some molecular genetic facilities came up directed towards specific diseases, and SMA is one of them. So SMA came in a little later, whereas we did have hemoglobinopathies and Duchenne muscular dystrophy as a priority because being common, and those tests were available at that point in time. Presently, and then SMA came in later, and then presently what is happening is that these investigations and diagnostic facilities are available in the country, both in the public and private setup. In the public setup, it may be free at some places or at nominal prices. So diagnosis for these commoner disorders is not a major problem as of now, provided, as was being stated in the morning itself, they are suspected and referred within time, so that the diagnosis is made early and the treatment, whatever is possible, is given. As far as SMA is concerned, the test which is now available and recommended is relatively cheap and a very robust test which is available, and that is available at many places in the country. But again, as I said, particularly for SMA1, it is important that the diagnosis is made early, and then you refer the patient in time for treatment. As far as the accessibility to these diagnostic tests is concerned, it is primarily based on the referral system, and it was being said in the morning that a good diagnostic referral network has to be made so that these patients are suspected early and they are referred in time. And I do not have time to go in the details, but then there are many efforts going on to increase awareness and build in a process of referral system from the district hospitals through the medical colleges to bigger institutions and centers of excellence to make the diagnostics easy. As far as the other rare diseases are concerned, so now, we have been conventionally saying there are 7,000 rare diseases. Now with the advent of newer genomic technologies and identification of new genes, we probably have around 10,000 to 11,000 rare diseases, but in notification still we say about 7,000. So in India, there are genomic diagnostic facilities also available, both in the public and private sector, though the costs have come down tremendously. Some problem. So, and then apart from the, I must say that even in routine diagnostics, when we see these patients in the clinic, these genomic technologies are available and they are being used for making a diagnosis, for treating if possible, and counseling and offering prenatal testing. Apart from that, there are many undiagnosed disease programs going on in the country. One which was funded by the ICMR, led by Dr. Ratna from Gangaram Hospital, and that has closed, and then many new insights have come in. And another one which is going on still is a DBT funded program led by Dr. Thangaraj and Dr. Ashwin, where they are focusing on pediatric rare genetic disorders. So there they are trying to find out the undiagnosed cases, undiagnosed families, working on them through genomic technologies, identifying new variations and new genes, including the functional studies. So a huge study which is ongoing and is being funded as of now. Okay, so I think in the present scenario, what I feel is that the scenario is quite improved, but then we have to create a system so that no baby is missed. The second part of your question is related to the gene-based therapies. And when we talk of gene-based therapies, the one important one is gene therapy, and maybe I'll just finish off with that first. So gene therapies are available for many disorders now, and SMA is one of them, and this therapy seems to be very, very effective for SMA, but you all know that the cost is
in the tune of 14 to 16 crores. And it's a one-time treatment, but then for each patient, that kind of money, as of now, it's very difficult for the government to give. Though through the humanitarian initiative programs, as Dr. Salman Singh was saying that companies should give. So we do have many patients, and Shifali can tell how many we have now at AIIMS under the humanitarian initiative programs who have undergone gene therapy, and there are other patients also through crowdfunding and also through reimbursement who have undergone gene therapy. Other than that, there are many other diseases like Duchenne muscular dystrophy, hemophilia, thalassemia, sickle cell disease, and many others, including some of the lysosomal storage disorders for which gene therapy is available. The main problem is the cost, and that's why we have not been able to regularly give it to our patients. Having said that, as Monica was saying, a lot of work is going on in the area of therapeutics in India, including gene therapy, and people are working on gene therapy for SMA, for DMD, and you already know we have gene therapy from hemophilia, where the Vellore group has worked, and we have gene therapy. They are also working on, and IGIB is also working on gene therapy for sickle cell disease. So gene therapies are being worked on. Apart from gene therapies, there are other gene-based therapies like exon skipping therapies for Duchenne muscular dystrophy, and there are other SMA therapies which are, say, mRNA modified therapies like nusinersen and Zolgensma. And these are Zolgensma probably because now it's locally manufactured and it's much cheaper than what it was before. So now it is available, and we are trying our level best to bring it under the rare disease policy with reduced cost. But as of now, it is not funded. So these drugs are also being worked on, nusinersen and drugs for gene therapy for SMA and others are being worked on. And same is true for exon skipping therapy for Duchenne muscular dystrophy. Another important disorder, which is cystic fibrosis, and again the potentiators which are there for cystic fibrosis are highly expensive, and I am happy to inform you that there is already ongoing research, again funded through various research agencies where people are working on these potentiators also. So I think overall availability as of now is an issue, but we do have people in India, researchers in India who are working on it, and then they would eventually need industry partners to take this forward. So I think this is, on a happy note, I would like to end this answer. Thank you.
Thanks, ma'am. Ma'am, just out of curiosity, now this session is largely focused about SMA. So there is no, I understand there might not be any available published data on the epidemiology of SMA in India. But based on your reading, your understanding, what would be the estimated number of SMA patients or the patient burden in India?
So I think SMA is the next most common autosomal recessive disease in India after thalassemia. The carrier frequency of SMA, there are two studies available, one which was done under the guidance of Professor I.C. Verma at Gangaram Hospital, another by Dr. Shubha Phadke in NGPGI, and the frequency of carrier status is 1 in 40,
Okay.
right? Which gives us that about 1 in 10,000 would be the frequency for SMA, so very common. Thalassemia is something like 1 in 2,500. So it's quite common, though we do not have, Dr. Salman Singh was talking about the prevalence and incidence in India. The problem is that you can only, ICMR registry is giving you hospital-based data, and this is from limited number of hospitals. So it is not giving you the true number. It is just giving you the patients who are seeking care and coming to these centers.
Yeah, it's not a population-based registry.
It's not population-based. For population-based data, you need to have either community surveys, very difficult for rare diseases, they are so heterogeneous.
True.
Or you need to have some newborn screening data for rare diseases with which you can estimate the prevalence, incidence or prevalence of these rare diseases. We do not have newborn screening programs as of now. At least for rare diseases, we are not working. Very rare diseases. Some inborn errors of metabolism data we do have, and the incidence is very high, something like 1 in 8,000.
Okay.
The third and the most important thing is which we are working on now, that we do have the data on 10,000 genome projects from India. You know that data was declared last year, and from there we are trying, and Dr. Ashwin Dalal is working in that direction, that we calculate the carrier frequency for relatively common rare disorders based on that data, and with that carrier frequency we can calculate the prevalence or incidence indirectly.
Okay.
Because calculating prevalence or incidence by doing newborn screening or by doing community-based studies is extremely difficult for us. So this would be an indirect way, and it will give us the idea, at least for the ones which are treatable, for which treatment is available, and the government gets prepared that what kind of funds do we have for this particular.
Absolutely, because that's the starting point of all the financial estimation. So glad to know that some major work initiatives have already been taken on that. Ma'am, if I can come to you, Dr. Bhavna, on that. So because you are attached to AIMS Bhopal, so which is a center of excellence, one of the cardinal centers when it comes to rare disease management. Now, ma'am, again, I mean, not specific just to SMA, but as we all know that when we talk about rare disease patients, we are actually talking about infants, right? And in a country like India, which is so diversified socioeconomically, educationally, across the country, how difficult or what are the major challenges you come across as a pediatrician seeing these patients? Why there is so much of delay? Why patients don't turn up at the right time? And why the diagnosis is so delayed? And in last couple of years, if some improvement, some ray of hope you have seen, probably in terms of some level of acceleration, some early diagnosis, if you can share your perspective on that.
Sure. Thanks to the organizers first for inviting me and having me here and giving me this opportunity. Coming to your question, most of the rare disorders, when they present in infancy or childhood, they have non-specific symptoms which could be overlapping with many of the commoner disorders like hepatosplenomegaly, recurrent respiratory infections, ear discharge, failure to thrive, delayed milestones. So these are all symptoms or signs presenting which are encountered by the pediatricians commonly in other disorders as well. Secondly, non-availability of the eye doesn't see what the brain doesn't know. So non-availability of diagnostic tests in-house at most of the places, the cost of diagnostic tests which families are unable to afford, because the primary pediatrician is not able to diagnose and children are being referred here and there and are being managed either as pneumonia, recurrent pneumonia, or not even being managed. I mean, the past history is not sometimes even taken into account, and each episode is managed as an individual episode. So that probably information and awareness needs to be disseminated to the peripheries, and that knowledge base needs to increase. As ma'am said, the role of COEs as the referral centers only reflects patients who have reached till there. There are many who are just left in the community or they expire in the community without even reaching a diagnosis because the awareness is not there. And even if it is suspected, the facilities to get that diagnostic testing done in the facility are not available. So I'll just give you an example. Recently, I got a call from a government medical college in a faraway district that they had a child on ventilator and the child had had recurrent pneumonias, 6 episodes at the age of 6 months. And at present, the child was ventilated for the last 2 months. So they wanted that we take a transfer for the child, but they were not worried about what is the underlying investigation. So we said that taking a transfer for a child who's already been on ventilator for 2 months is not an easy job. Transferring also is difficult. So somehow the father got hold of our number and he spoke to us and he said that the mother was pregnant again. So we spoke to the clinician and we got a sample couriered from there, and when we tested, the child was positive for SMA. So we called the family and we counseled them, and the fetus also turned out to be SMA positive and they went ahead with an MTP. So increasing that awareness base in the peripheral pediatricians and general practitioners that rare diseases can present with symptoms which are common and overlapping with other disorders is very, very important. As you said, ray of hope, yes, there are various efforts being made like dissemination of awareness and CMEs. The ministry is also focusing that each COE goes out and performs these CME awareness sessions not only in the central hubs but out in the periphery in peripheral medical colleges so that more and more faculty members, more and more residents get trained and that snowball effect carries on and more people are aware that such diagnostic facilities are available. It is not necessary that the patient needs to travel all the way. Sometimes you can just collect a DBS sample or a plain EDTA sample and send it to the lab or center of excellence and you can get a diagnosis. Not only important for the individual affected child, but also for prenatal and genetic counseling for the affected families. Also important, another thing is for the COE to not only function as a central in a silo, as a center of excellence, but also capacity building of peripheral state medical colleges, district hospitals. So training of the CMHOs or faculty members from medical colleges is also extremely important, giving them hands-on experience and enabling them to follow up these patients also once they are started on treatment at their centers. So telemedicine facilities, telecommunication facilities, these are all being looked into and real advances are being made in that direction as well.
Terrific, very good. Good to hear all of that. Now just one quick question on what you talked about, awareness at two levels. One at the caregiver, family, parents level. The other, which I believe is as important as educating the parents, are educating the primary care physicians, because they are invariably the first contact point in most cases. So is there any structured program underway currently, and have you seen any improvement on that? Are they more sensitized to
Yes,
some of these rare disease symptoms?
Yeah, as I mentioned just now, that the centers of excellence under the aegis of the ministry are conducting peripheral sensitization and awareness CMEs. If we have 15 centers and each center is conducting 3 or 4 CMEs in a year, not only in their central hub, but also going out to the peripheries and creating these awareness sessions, observing days like Rare Disease Day, Duchenne's Muscular Day, Down Syndrome Day, or other days which are genetic or rare disorders, does create an awareness which percolates in the community. So the ministry is not only looking into capacity building of tertiary institutes as COEs, but also disseminate and percolate that information to the periphery, to the community, to the patients also, so that they are aware that diagnostic facilities are available, treatment facilities are available, early diagnosis is important, and prevention is all the more family, that they educate their extended family members, their relatives and friends, so that the word spreads and more awareness can be created. Having said that, we have created a state level rare disease working group. So we have one pediatrician from each medical college who again in turn have involved with the CMHOs of their district hospitals, wherein we create not only awareness CMEs or sessions online, but also we disseminate the IEC material to them. So like if we are observing, let us say, a muscular dystrophy day, so how to suspect, when to suspect, where to send the child, what to do for prenatal diagnosis, when not to plan a pregnancy and reach early for prenatal diagnosis. All these things in a spoke and hub model are being advocated by the ministry as well, and I think all COEs are taking it up at a great level.
Terrific. And especially in a low resource country like India, if screening, early diagnosis, that's the best help that we can do. So minimize put less burden on not just clinical capacity, as well in our financial capacity also to support these treatments. Thank you. Ma'am, if I can take the question to Dr. Shefali now, because you are working in one of the leading pediatric neurology units in the country. You're leading a pediatric neurology program, and we are talking about SMA, which is essentially a neuromuscular kind of a disorder. But at the same time, we must understand that here the symptoms are very conflicting. Like a SMA patient will have a lot of respiratory issues, so to speak. And the doctor might treat for the respiratory syndrome, not exactly diagnosing or going for a diagnosis of SMA. So considering all of that, if you can share your views on purely from a neuromuscular disease point of view and SMA perspective, how challenging it is to diagnose these kinds of neurological disorders in a country like India.
Thank you for a wonderful question, and thanks to the organizers for having me over. Basically, the symptomatology is many, as you mentioned, it will be non-specific. You may have a child having birth asphyxia, a child may have prematurity, any reason because of which the child needs a respiratory support, right? A child may have hypotonia. Hypotonia can be there in initial stage because of birth asphyxia per se, because increased tone comes later. So it is pretty non-specific. So I think it is empowering the professionals to understand what all can be and what all the presentations can be there, and because there are subtle findings which are there on examination, like if a newborn is having issues of respiratory support, they may have tongue fasciculations, but then the pediatrician and neonatologist have to know that they have to see that and send the specific test. And one thing what is happening is right now, people don't think about the diagnosis and they will send whole exome sequencing. So, we have to be very clear of what we are thinking, because always whole exome is not the answer to it. So like this is a simple test with MLPA which can be done, as Dr. Madhulika ma'am was telling. So that is why, and you need a high index of suspicion that you will have once you're aware. So that's why empowering of these pediatricians, and the neonatologists who are dealing, is very important to pick them up early, keeping the non-specific thing in mind. The other thing is, yes, we don't have a newborn screening program because ethically, see, as a clinician, I would love to have it. But when you go to the Central Committee of Rare Disease, when we are sitting, ma'am, me and many others, when we change the hat, we cannot talk about it, because once you do a newborn screening, you diagnose a person with an XYZ, you have to provide a definitive treatment for life. So till that time it is available, it won't be there. So in SMA, we can, as ma'am was mentioning, that you have a carrier frequency of 1 in 40. We may focus on a population-based carrier screening, which may be a simple thing to find out. And those who are at risk, when they are doing the, marriage counseling that time, these all things can be kept in mind, like it happened with thalassemia. So that one will be important. And the thing is that many pediatricians are now suspecting, but the tests are not very well available in the periphery. So there has to be a referral network for these genetic tests to be available. See, in Delhi and all, in major cities, and those COEs is not, but the referral network till the periphery of how the sample can be sent should be important, so as to be able to diagnose these people early.
Thank you. Now, Alpana ma'am, if I take my question to you, because, you are the co-founder of Cure SMA, you interact with patients, their families on a routine basis, and you also engage with government and support them in policy making. Now we all know that we have a curative option available for SMA. Our eminent doctors, they talked about it. Now that does make a big difference in not just from the clinical point of view, even it should make big difference in the psyche of the patients and their family members. Now the question is, we all know that especially for neuromuscular, this kind of genetic disorders, there is a kind of a denial also that exists with the family members, and there is a deep sense of guilt. कि मेरे बच्चे को ऐसा क्यों हुआ? Right. So you being someone representing a patient advocacy groups and having seen this on so many occasions, what are the steps that one can take to help the families to overcome those mental blocks and go for the treatment? Because now you have a treatment.
Thank you. Thanks a lot for this pertinent question, and I would like to thank IHW Council and the organizers for this wonderful opportunity. So I am a patient advocate and I'm also mother of now 13-year-old SMA boy. Your question has touched the raw spot, I would say. When my son Arav was diagnosed, there was nothing, no cure or no treatment, even no awareness in India. And all these questions that you are saying, that why me, why my child, I have gone through all these. The diagnosis initially itself is very difficult for the rare diseases, and 13 years back it was, it was not at all there. Thankfully, I come from family of doctors. My sister is a gynecologist and my brother-in-law is a neonatologist. So I would say I was still, placed in a better situation where the diagnosis happened, and then I got to know that there is some, treatment that is available in the US. But the moment, the diagnosis was handed to me, and today we have all the compassionate clinicians. But, when 13 years back, when there was no option, when we met many of the doctors, they told us, not just me, many of my colleagues, they were told that just go love your child, there's nothing much you can do. And it's so heartbreaking to, hear the news that your child has a terminal illness, for which you can't do anything. But yeah, and I remember, my pillows would be drenched thinking, why me, why my child, all that you are saying. But somewhere, my brother who lives in US told me about Cure SMA US. And that's what where I say, learn the power advocacy and power of the support system, patient support system. I visited in 2014 the US conference for the Cure SMA and learned that there were many treatments. More than that, there were children who were doing quite well. Despite not having treatment, SMA children are exceptionally bright. They do phenomenally well. Many of the Dr. Shivali Gulati, Madhulika Kabra ma'am, they both know, and many of the people here know that these, in fact, my colleague Shri Lakshmi, her son Pratyush, is working with Google. Archana, her daughter, is working with Mike. They are all SMA individual. We have Purva, who is herself has a SMA, and she is doing phenomenally well. Looking at them gives us hope that yes, if there is a proper quality of life, then it can be done. And similarly today, as you are saying, again, it's a double-edged sword for us. There is a treatment, but that treatment is sadly not affordable and accessible. So at Cure SMA India, we realized slowly that, through Cure SMA India, we have formed a platform that through where we have our internal stakeholders, which are the parents, patients, caregivers, and our external stakeholders, the healthcare professionals, clinicians, government, the policymaker, pharma companies, and society in general, whom we are trying to sensitize and got together to find the solution. Like when it comes to treatment and counseling the family, we navigating, through the treatment options is a big challenge today because very few handful of them, we have more than 2,000 patients registered with us, but hardly 300 or 400, patients have the access. And with now we have some drugs which are affordable, but the problem is lack of awareness, the cost-based and value-based model, because many a times with generic, the problem is that have they undergone the bioequivalence test. With generic condition, we don't know what will happen 5 year down the line. So, it's, as I said, I wear both the hats of a patient advocate and as a mother. It's very heartbreaking for us to counsel the family, to tell them that yes, there is a treatment and these are the way you can deal. But thankfully, recently we had a success story of Kerala where there is a win where the government has extended the treatment for till the age of 25, thanks to the phenomenal advocacy effort of our colleague Dr. Razina and all the stakeholders, the clinicians, the pharma company, the government mainly. Similarly, there are multidisciplinary care, as we are saying, how to the denial, the stage of denial is there. So we tell them that slowly, holding them, and then telling them the multidisciplinary aspects, like we have SMA clinic.
Yeah, ma'am, we have a separate question on that MDT approach for SMA. So if I take the same question forward to you, Purvaji, because you are also representing a patient advocacy groups and you are there for many years now. So you understand the landscape very well. Now, Alpanaji spoke about the patient and the caregiver part of education awareness. Now, an advocacy group also plays an important role in building awareness at the policymakers level with the government and sensitizing them, repeatedly going and coaxing them to do something about that, engaging with them more effectively. So if you can talk little on that aspect, that especially now with SMA having a curative drug, so how that whole effort has panned out over the years, in last couple of years, since the time we have the drug in place now. As an advocacy group, how you have been engaging with government and policymakers.
Thank you so much for your question. But firstly, I would like to thank IHW Council for putting together such beautiful conference and bringing together such genius minds. I would also like to thank Dr. Madhulika Kabra and Dr. Shivali Gulati, under whose care I have grown up, and I'm sitting here because of them. Now, quickly circling back to the question. So, the effective advocacy requires maturity and collaboration among all stakeholders across rare disease ecosystem. It is not a race for an individual. It is for the entire community. Today, SMA has a drug, but there are other disorders who are still struggling, and they are still at the stage where we were 10 years ago. Right. So patient groups, they play a very crucial role when we talk about it. They try to highlight and raise awareness for a specific disease through lived experiences and highlighting the unmet needs. But at the same time, it is essential for all those disease-specific groups to extend the support to an umbrella organization who is working for a rare disease policy at large, because when we are trying to bring a systematic change, it requires a unified voice and the vision. Today, advocacy has accelerated, and it is not a linear progression. We are working together, but in myriad ways. So there are certain groups who are working for research and development. Others are trying to create and generate patient repositories and registry, and also generating real world data, which is essential for the researchers and also policy planning. They are also working for support cares and patient support systems. When all of these things they come together, we are able to create a bridge between the patient communities and the government. Like you have already underscored, India is a country with lack of resources. And when we have to reach to the last mile, the person who is just sitting in the villages, who is not as privileged as me, who's living in Delhi, we need to work together. And these efforts in unison are definitely creating an influence. The first thing is national rare disease policy. It might not be perfect. It might need multiple recommendations, but we have it and we are moving in that direction. That can only happen when all of us work together without biases. When we are not just thinking about our own greed, that because I want the medicine for myself, that is not going to work when we are trying to create the policy on the larger level.
True.
And thankfully today we are able to do that, and it has created a greater planning and action for rare disease with a curative potential. Thank you.
Terrific. Yes, it's a big step forward, having a policy in first place. Now, Dr. Kabra, if I come back to you, because you represent the central institute in terms of research and setting the ball rolling, amongst the entire ecosystem of rare disease management in India. Now, when it comes to SMA or any similar disease where you have a curative drug available, then it becomes that much important to have a robust data management, data collection system in place. So purely from that research framework, its implementation, so if you can throw some light into that, what kind of work is going on?
So this is a very important question. So apart from networking and having a care pathway for implementation of rare disease policy for managing patients, diagnosing patients and treating them, it's also important that we go in a systematic way for the research also. So as you said, the most important thing is that we need to have a patient data set and with all the details which are available. And why this is important, that suppose within India or outside India some drug trials are probably planned. In that situation, if we have a data set saying that we have these number of patients and these are the patient characteristics, the researcher can decide that, okay, this can be my data, this can be my patient cohort who can be sort of taken in a drug trial or something like that. So here, I think for the robust data set, I think I would like to spend a little time, is extremely important to have a registry. And we talked about the ICMR registry. The ICMR registry will be completing 7 years in October. So it is not ICMR's mandate to continue a registry, a patient registry, and it was given in a project mode. Now, efforts are going on that how this can be sustained, because this is going to be extremely important, and there are many things being tried. A ministry has been approached, but they also have their own constraints to handle such a big data. So what we need to understand is that when we talk of rare diseases, we are not talking of one disease like SMA or DMD. We are talking of many diseases. Like in the rare disease registry, there are 7 groups of diseases which are included as of now. And handling that data, which is so heterogeneous, with so many variables, and keeping that data set for
It's difficult.
is difficult. So we are trying to find out a way that how ICMR can help and how ministry can help. The other important thing here is that when we are talking of implementing these research pathways, we have to work in parallel with the researchers, so basic scientists, and also with the industry. I think this has to be really built in. So now, as Monica was saying in the morning, ICMR is really trying hard that if suppose a drug discovery is being made or a repurposed drug is being planned to be tried, or like you said about gene-based therapy, we need to have so the basic scientists will be there who will be working on then produce the molecule. Then they need to have a partner who can produce that in bulk, because producing in bulk also has a lot of costs. So you need to have an industry partner who will ultimately market, and very importantly, they have to have clinical partners who can undertake that clinical trial. So this framework has to be kept in mind, not only for basic research in rare diseases, which would include identifying a new gene and maybe identifying a new variant or doing functional studies. And there also you need to have a collaboration between the clinical team and a basic science team. But I think more importantly, this research framework and implementation pathways through research for therapeutics is extremely important. So when we begin research in the therapeutic arena, which is the mandate, I must tell you, the mandate for rare disease research in India by the government and all the funding agencies, as Monica said in the morning, is working on therapeutics, all forms of therapeutics, be it gene-based, be it repurposing or any kind of drugs, and many things have happened also. So here, from the beginning itself, the implementation pathway and the framework has to be that from the beginning, all these 3 or 4 components should be in place. And this is being tried, though I must say it is difficult. I mean, from the beginning itself, our industry might not want to partner you because they may say, we don't know whether your product is going to work or not. But then maybe as a partner can join in second year or third year or something like that. So I think for research frameworks, it's absolutely important that we keep it in mind that how does
प्रॉब्लम ही यही है ना,
work and how do
उसको
we
माइक
build
पकड़ना
in
नहीं आता,
good research
अब 3 लोगों
frameworks
को
and
माइक पकड़ना नहीं
implementation
आता.
pathways for research.
Now I understand it's a Herculean task in a heterogeneous kind of a segment. It's a very difficult task. Dr. Shifali, if I come to you, I mean, one aspect Alpana ji also pointed out, that's the MDT approach of, SMA management, or maybe neuromuscular rare disease, genetic disorder management. Because as you also pointed out that the patient might have multiple different issues, maybe respiratory issue, cardiovascular issue, there could be orthopedic issues. Now, in your setup, in AIMS, how do you have a multidisciplinary team approach there? And if you can help everyone understand here, what are the essentials of having a proper MDT framework to manage these kinds of genetic, neurological disorders?
I think it is very, very important because what is happening is everybody is chasing the precision medicine drug and they are forgetting the multidisciplinary management, and without the multidisciplinary management there will be no good outcomes. I mean, the optimal outcomes will not happen. But just before proceeding with that, I just want to give you the experience which Dr. Madhulika had pointed out for us, like we have had given 24 gene therapies intravenous Zolgensma to patients, out of which 18 were from humanitarian access program of the Novartis, and 6 were either paid or by this crowdfunding or by the government agencies, the public sector organizations. And 2 of them are going to get gene therapy in the next 2 weeks. And the first gene therapy in India was done by us in 29th May 2020. So the child has followed up for nearly 6 years after that. So they all are doing very well, but the only thing is they have not been magical, because most of our patients were later on, like they were in the second half or the first year or the early part of the second year. So that was one thing. We've had experience in 47 nusinersen patients for the last 6 years because of humanitarian access program. The Global Direct Relief have given 1,230 patients, 230 patients across India, out of which 47 were our patients. We have given a lifelong commitment for nusinersen for these patients. They are also doing equally well. And they are also older than this also, this. And third one was the Risdiplam. Initially was humanitarian access. We are purchasing both. So that has been there, and we have a couple of patients, about 8, who are having mixed, combination therapies. But let me tell you, across all these, they have been doing similarly for us, but our patients we were not picking up in the earlier 6 weeks, because they say in all the 3 molecules, either the gene therapy Zolgensma, or you have the nusinersen ASO, or you do talk about the Risdiplam. If you give in the pre-symptomatic stage, they are going to achieve near normal motor milestones at 1 year. But we have that crucial thing about our doing newborn screening. For all of them, you need to prevent them, give them a supportive care in the form of physiotherapy and occupational therapy. The respiratory support has to be there. The nutrition has to be taken into account. The immunization, the orthopedics people have to see, and the psychologists have to see and provide. Also, the coping strategies for the families have to be there. So all of them have to be given together. And if you don't do that, it doesn't work, because their nutrition and everything has to go all in hand. And we have made our protocols and have everything in place. So I was just always, and because when we also have polysomnography, we keep doing it periodically, and they may need respiratory support. So now you have, so many of them are there on CPAP, and partial ventilations at home. So all this was not happening till about 5 years back. So that is why all this supportive care has to be kept in mind for them to move forward. And one thing is very important, that many times you have multiply effective SIPs. That is the failure of the medical fraternity. With this genetic testing and all available, genetic counseling has to take place. And as Dr. Bhavna had mentioned about the case in which they did the prenatal diagnosis, it is very important for us to emphasize and we should not have a similarly, any rare disease of similar kind in the same family. They should be prevented by genetic testing and prenatal diagnosis. That is one. And overall, it is still remaining an odyssey for the rare disease for our patients. But let me tell you, overall 6 to 8% of the population has a cumulative all the rare disease combined. So
Right.
it's not all that unknown.
Right. Now, Dr. Bhavna, if I take the same question to you, because you also handle the similar kind of setup as Dr. Shefali was pointing out. Now, typically what we understand based on our academic knowledge, that a multidisciplinary team would comprise of different specialities, pediatrician, geneticist, cardiologist, pulmonologist, neurologist, they all would be part of it. Now, in that kind of a setup, and you being someone representing a center of excellence, how the coordination works, which is an issue in many of these MDT approaches, and then purely from the long-term treatment point of view of these patients. Like, it's not a one-time kind of a solution. So considering all of that, if you can talk about the MDT approach in a setup like yours.
Yeah, definitely. So as ma'am pointed out, that while you are chasing the main drug, the precision medicine drug, for the child to remain fit till that drug is made available, multidisciplinary care is inevitable and extremely, extremely important. Because if you don't take care of the respiratory complications, the muscular complications, keeping the strength up, immunization, then the child may not remain fit to receive that precision medicine drug till that time that is made available. Now coming to our setup, as you know that in tertiary care hospitals, managing referral, sending from one department to other department, and the patient keeps shuttling from one place to other, sometimes from one building to another located far away, it's extremely difficult. So what we do is that for such patients, like for example, we have fixed one day when the SMA patients, since we don't have as much burden as AIMS Delhi right now, that AIMS SMA patients come for follow-up on a given particular day, and then we tie up with the pulmonary medicine department that they send their technician for SMA and DMD to perform their annual PFTs. So we requested our cardiology team, so they, although that is not their echo day, but they send somebody who can perform the routine annual echoes for patients who are coming back or for their follow-up. So making these coordination with different departments and different teams is extremely difficult. Somebody has to take it up personally so that things can be organized for such patients. Then again, communicating with the patients, that you need somebody who can be in regular touch with the patients and call them for regular follow-ups and advocate to them that this regular monitoring, this multidisciplinary care is important to improve the quality of care of life. So we have some patient volunteers also who take care of the patients. They escort them to the other departments, take care of them and bring them back so that the patient doesn't have to chase the reports. Then again, now with AI and other things, many apps are there, so most of the reports are available online. Even for phlebotomy, if these patients have to go for blood testings, what we have done is that we have arranged a phlebotomist who comes to the OPD and takes samples for all the patients with such children, and the sample is taken there and then the patient volunteers, goes with the patient and gets the billing done at a counter which has been made specially in the OPD area for such cases.
Sorry to interject, ma'am. We are running little out of time. So in the interest of time, my last question and same question I would ask to Alpana ji and Purva ji, to both of you. Now we know that we have drug options available for SMA. Purely from access point of view, Alpana ji, if you have to give your, kind of way forward suggestion, how one should engage with government, industry, and so that more and more SMA patients, they have access to the curative drug that is available. And same question I would take to you, Purva ji, if you can also comment once she's done.
Thank you. Thanks a lot for this question. And as Cure SMA India, we have worked for the treatment access. We have worked around 3 A's, which is availability, affordability, and access. Now, availability of the drugs are there. We have 3 drugs and 1 generic as well. The question comes around the affordability and the accessibility. For this, we have taken a multi-stakeholder engagement approach. We have always believed in working in close collaboration with all the stakeholders. And for this, we have had many programs, like every year we have Run for SMA. It was initiated in Hyderabad, but now it is happening in many other cities, so that all the stakeholders are aware. Because as previously also it was mentioned that as a parent it's heartbreaking, heart-wrenching to know that there is a treatment but it's not available. So we need to make it available and accessible. And I would like to end it with a quote from Helen Keller, that alone we can do so little, but together we can do much more. So it's my humble request to all the dignitaries present here, to all the policymakers, the clinicians, that let us come together and work together to make the available treatment affordable and accessible.
Terrific. Yeah, Purva ji, if you want to say something.
Okay, I would like to answer this question not as an ORDI representative, but as an individual. My approach to the cure has always been that I should be able to purchase it myself. I don't want to be a burden on the government or rely on the government or on some policy which might just be taken away or rolled back. So my idea is that, of course, once in a family, last in a family, it is important that a person and a family should be able to educate their external family so that we can curtail the patient registry then and there. If one person has been diagnosed with a disease, there should be no one else in the similar family, right? Because these are your spokesperson. We need to stand united for the policy, and the policy should not be curtailed to the disease, the cure. It should also include education and employment so the person can be self-sustainable, speak for themselves and get the medicines for them.
Thank you. Thank you very much. Thanks to the panel for your time and thanks for your patient hearing. Thanks a lot.
Please give a round of applause to all our speakers. We want to thank them for sharing their thoughts with the audience. I would request Kamal Narayan Omar, founder and CEO IHW Council, to please come up on stage and present our speakers with mementos. We want to thank them for coming here and sharing their thoughts with the audience. I request Kamal to please come up on stage and present mementos to our speakers. A memento for Ms. Purva Mittal, Regional Coordinator, ORDI. A memento for Dr. Madhulika Kabra, Emeritus Scientist, ICMR. A memento for Dr. Bhavna Dhingra Bhan, Professor Pediatrics, All India Institute of Medical Sciences, AIIMS, Bhopal. A memento for Ms. Alpana Sharma, co-founder and trustee, Cure SMA Foundation of India. A memento for Professor Shefali Gulati, Chief, Child Neurology Division, Coordinator, DM Pediatric Neurology Program, AIIMS. And a memento for our moderator, Mr. Srimanta Bhattacharya, Director, RS Associates. I request all of you to gather for a group photograph. Please give them a huge round of applause. I request our speakers to take their places off the stage. Next, we have an important session coming up on neurofibromatosis type 1 or NF1. But before we start with our discussion on this important topic, I would like to introduce to all of you our guest of honor who has joined us here. I request all of you to please give a round of applause to our guest of honor, Dr. Anil Sukhdev Rao Bonde, the Honorable Member of Parliament and Chairperson, Indian Medical Parliamentarians Forum. Please give a round of applause. He's joining us in the front table. Dr. Bonde is a distinguished public leader and medical professional who has consistently advocated for strengthening India's healthcare systems and medical policy framework. As the chairperson of the Indian Medical Parliamentarians Forum, he has actively worked to bridge policy, governance, and healthcare priorities to improve access and outcomes for patients across the country. I request Dr. Anil Sukhdev Rao Bonde to please come up on stage for his special address to the audience. Please give him a huge round of applause and welcome him on stage. I request Kamal Narayan Ober to please come up on stage to present the Honorable Member of Parliament, Dr. Bonde, with a bouquet. We want to thank him for coming here, and we are looking forward to his thoughts on this important issue of rare diseases. Right. Please give a round of applause to Dr. Anil Sukhdev Rao Bonde. He will now give us the keynote address.
Thank you very much. Bharat Mata ki. Yes. So today I am very much glad to remain here, and I do appreciate this summit which you have arranged by the Integrated Health and Welfare Council. Now, today the panel discussion is going to have, and the many eminent person under the moderator of the Dr. Ratna Devi. You will have to listen to them. Dr. Sandeep Arora, who is Country Medical Director of the AstraZeneca. Only thing is that because of the short of time, I am not able to attend this panel discussion. But I congratulate you to have this platform which is focused on the rare diseases. And you have brought all the clinicians, scientists, patient group, industry and policymakers to address this complex healthcare issue. India, after 2023, it has taken an important step through the national policy for the rare diseases. And we know that up to the 50 lakh rupees is given for the patients with the rare diseases,
maybe the lysosomal storage disorder or other storage disorders, mostly genetic one. Now, before this, the identification of this disease, diagnosis of disease and treatment was not possible, especially for the remote area, especially for the poor families. Now, due to this policy, the implementation of the treatment, awareness and access to the treatment is definitely increased. As a chairperson of the Indian Medical Parliamentary Forum, I have seen that the infectious diseases, rather, they are declining because of the better water availability, because of the vaccination, and now mostly non-communicable health diseases or genetic disorders, they are more prevalent, becoming more prevalent. And each and every life is very much important. And so for the children with the rare diseases, they do have the right to live. They do have the right to live the significant life. They should get the employment, they should have the positive life, and that family which is suffering from the grief of the children, that should be solved, that is the purpose. So there should be always dialogue between the medical experts, lawmakers, patient group and doctors. I am of the opinion that rare diseases, the problem of the rare diseases cannot be solved only by the government. So it has to be the combined effort, the constant collaboration should be there, the government, medical institutions, patient advisory groups, pharmaceutical and biotech innovators, diagnostic and genomic ecosystem. Till today also, many rare diseases remain undiagnosed or misdiagnosed for the years together. So there is need to strengthen the genetic diagnostic, newborn screening, awareness among the physician, that is very much important. Obviously, the Niti Aayog also has taken the good step, and it is also encouraging the Indian Research Institute biotech innovators to work on the rare diseases. So obviously, India as a Vikasit Bharat 2047, which is the vision of our Prime Minister, Mr. Narendra Ji Modi. So in this Vikasit Bharat 2047, we must build a strong genomic and research capability. At the same time, nothing is important than the compassionate and inclusive healthcare system. Families which are dealing with the rare diseases, they definitely need medical, financial, emotional and social support. So this summit, which IHW Council has arranged, will obviously give answer to this. And this is the continuous process. In this process, I can say that I got the opportunity to mention the neurofibromatosis type 1 in the special mention, which is the opportunity for the Member of Parliament. Because I have seen as a medical personnel that neurofibromatosis 1 or the generalized neurofibromatosis, they do have the disfigurement of the face. They, most of the time, even they cannot mix up with the society. Young girls, I have seen with the generalized neurofibromatosis. Though the life is not in danger in those cases, but obviously they cannot have the normal life. So I mentioned there in the special mention that this neurofibromatosis type 1, that should also be considered as a rare disease, and the treatment should be given, treatment should be made available to this person. Or certain neurofibromatosis, we know that they are at such a juncture that those may be painful, those may be compressing the cord, those may be compressing the vital part of the brain, and that can give the neurological symptoms, that can give the various pain in the life of that person. And in such cases, when it is not operable, when it is inoperable, so we must give the thought, we must think regarding that, whether we can medically elevate the pain of that person, we can have, whether we can have the answer for the disfigurement, whether he can have the social life, good social life, whether he can live the productive life. So for the neurofibromatosis also, I have urged the government that it should be considered as a rare disease, and rupees 50 lakh package they should also get. In the last 0 hour also, I have mentioned that this, it is good that our Prime Minister and our Health Minister, Prime Minister Narendra Ji Modi and our Health Minister J.P. Nadda Ji, they have designed the policy and rupees 50 lakhs is given for the treatment of the rare diseases. But what happens that if the rupees 50 lakhs are given, is allotted to that patient, and after 2-3 cycles or after 2-3 years, if the fund is exhausted and the continuation of the treatment is necessary, if the fund is exhausted and if the family or the physician family is not affording for that, then obviously that grown-up child is having chances of dying. The death will occur in the later age. But I think for the rare diseases, if the treatment is started, that should be the continuous process, and he should have the normal life expectancy. So for that, I have also urged the Health Minister that once we start the treatment, obviously it can be through the crowdfunding, combined crowdfunding, government help, industry, and some philanthropists, or we can say, or some donors, we can say, they should make a plan that we should give the continuous treatment, especially if it is for the LSD or any other storage disorder, that their life should not get disturbed. Once you have started the treatment, it is your duty to continue the treatment, to have the normal life expectancy to this patient of the rare diseases. So I think the discussion should occur on this also. And many persons, many donors who are donating, maybe CSR of the many companies, though the total, we can say the fund should be made available. Combined fund should be there. And that combined fund should be utilized for the normal life expectancy of the rare disease person. So I sincerely thank you that you have given the platform to speak on this topic. And definitely, as an IMPF chairperson, definitely I am working on this. I am working on the non-communicable diseases also. And I wish that you all should support for this great cause. And I wish you the success for your summit. Thank you very much. Thank you. Okay.
Thank you so much, sir. Thank you so much, Dr. Bonde, and I really would like to express our heartfelt appreciation and gratitude for you for being, one of the most vocal, most authentic, and most active voice for health for all within the Parliament, and especially from the ruling dispensation. And not only that, while you have been very actively pursuing the agenda of rare diseases, and I can, refer to your speech day before yesterday in the Parliament on NF1, but at the same time, you have been very actively involved in building a strong advocacy or policy pathways for the various health issues, and including the one area which you are, I think, the recent program you hosted or you were part of, instrumental in that in Mumbai on stroke. And that is an area where IHW Council has been working for nearly 7 years now, building India's first stroke summit and also trying to create a stroke-ready India. So while Dr. Bonde is here, I would request the other panelists to also come, they are going to speak about NF1. They are going to talk about and discuss about the areas on that. So let me invite Dr. Professor Sefali Gulati, Chief Child Neurology Division Coordinator of DM Pediatric Neurology Program at AIMS. Thank you so much, ma'am. Please join us here. Dr. Hemlata Vadwani Bhatia, the Vice President of Genomics and Agilus Diagnostics. Dr. Jyoti Bajpayee, Lead Medical and Precision Oncology at Apollo Hospital. Dr. Amit Talwar, Associate Secretary General for Indian Pharmaceutical Alliance, IPA, and also Dr. Sandeep Arora, the Country Medical Director for AstraZeneca. And this session to be moderated by another major voice for the patient's right, Dr. Ratna Devi, CEO of Dakshayani and Amravati Health and Education. Thank you so much, Dr. Ratna, for being here, and all of you for being here with us. And Dr. Bonde, while I believe Dr. Bonde needs to go to the parliament back, I would request all of you to have a maybe group photograph with Dr. Bonde, and then we continue with our conversation under the moderatorship of Dr. Ratna.
Excuse me, this is Dr. Jyoti. I'm not able to, on my video, it is said the host is disabled. They are not listening also.
Please give them a huge round of applause. I request our speakers to take their seats, and I would request Kamal to please present a memento to Dr. Bonde. We are very, very grateful to him for coming here and for sharing his vision with the audience.
Good afternoon, everyone. While the formalities are being completed, I just wanted to add a quick word of thanks to our Honorable Member of Parliament, Dr. Anil Bondeji, who, as he mentioned, raised the topic of NF1 not once but twice. Day before yesterday, not only in the special mention but also in the 0 hour. Sir, you also helped us publish an article in the IMPF newsletter and have been a vocal advocate of rare diseases in general. So thank you for supporting us, and we remain indebted to you. We look forward to your guidance in the future as well. Thank you so much. So we quickly move forward to our current session, which is NF1 Care, Access Early Diagnosis and Long-Term Support Beyond Symptoms. Building a continuum of care for NF1 at the Rare Disease Action Summit, which is today. So thank you to the organizers for organizing this and bringing the topic of something like NF1, which I myself as a clinician had never heard of in my entire career till I started working in rare diseases. So that tells you how much of awareness is actually needed, not only amongst patients, community, caregivers, and families, but also clinicians themselves, because many of these rare diseases are something which none of us have heard. Unless you are in direct clinical practice treating those patients, many of us have not even heard about these rare conditions. We have 5 eminent panelists today. One of us is joining online. I think Dr. Jyoti Bajpayee is joining online. If I can have a quick confirmation if she is already there online.
Hello, yeah, I'm there. Can you hear me?
Thank you. Thank you. I will not be introducing the panelists, and my request is that as I ask the first question, please say a quick word about your work, and then you can move on to the question. So my first question, and since we are talking of awareness and how do we arrive at a conclusion of who has this particular condition and what kind of treatment is required for them. So my first question is to Dr. Hemlata Bhatia, who is a clinical genetist and is a vice president genomics at Agilis Diagnostics. And there are several ways that patients are referred to a diagnostic center. One is they go to a clinician or a physician, and then the clinician asks them to have a diagnostic test. And some are, because of social media and because of general awareness, direct walk-ins. So in your practice, what is the general trend for NF1? How do they come to your clinic, and what is the diagnostic pathway? And in the context of our country, do we have diagnostic protocols that are followed by clinicians? And if these protocols are there, how do we establish that these protocols are followed, and between private sector, public sector, and the diagnostic labs that are conducting these tests?
Right. Thank you, Dr. Ratna. So as a clinician, if I'm sitting at my clinic or in my OPD, I think the most referrals come from pediatricians, right? And most of these cases actually, are identified in, we need to pick up these cases in the preclinical stage, in the sense when the symptoms have not started appearing yet, which is where the awareness programs really come into play, because we need to have certain awareness sensitization happening all over our country to tell people that what to look for, what are the red flags, when to refer to a clinical geneticist. So all these things. So diagnostic criteria are very much in place as of now. The only thing is that, we need to kind of sensitize the pediatricians and neurologists and the pediatric neurologists, which Dr. Shefali has been doing quite well all throughout. So, once we start kind of sensitizing people about the diagnostic criteria, that what like simple thing like cafe au lait spots, or maybe just a head-to-toe physical examination, I think that is where we need to emphasize on. So, if you ask me, in metros, it is already being done quite well. What we really need to emphasize on is towards the peripheries, the tier 2 and tier 3 cities, where I feel that we need to kind of hold more workshops, more maybe one-to-one meetings, maybe more RTMs, more CMEs, where we need to integrate multi-specialities. And it's not only pediatrician, it's suppose a child comes to an ophthalmologist, or maybe, just some CNS findings are picked up on routine MRI imaging. So these are very subtle things, these are things which are actually can be picked up very easily before the actual manifestations start. And this is where the whole journey starts, right? Now the second aspect is the diagnosis. So once the diagnosis, once you have a high index of suspicion for any child or any person, then the diagnostic industry itself is like, it's huge in India, but when it comes down to the actual testing, I think it is still, I would say, untapped. I would put it this way, because most of us have, dealt with genetic testing day in and day out. But again, we are only talking about the metros. We are not talking about the peripheries, where the actual number of undiagnosed patients are still there, right? So yes, so I think this is where the gap lies, and this is what we really need to fill in.
Yes, so just a quick follow-up question to that. And you mentioned that most of the diagnosis happens in metros and not in tier 2, tier 3 cities. What would be the gaps for that? And how do you think, both from the access part of it as well as the affordability part of it, we can cover, so that if patients like ourselves, patient advisory groups, work on awareness generation for communities and families, they are able to then get the access to the diagnosis and are able to afford it?
Right. So one is, of course, as I said, that we can have more CMEs and more awareness campaigns. But I think we have still not tapped another potential, which is, I think, telemedicine consultations. I think once we really boil down to that, I think we can kind of really reach out to the far peripheries. So, a little thing like, awareness, just a very little sign, everyone has WhatsApp, everyone is on internet these days, so just a little hint here and there, and maybe, if we can kind of make a network where these patients are referred to the centers of excellence, or maybe, the tertiary care centers through telemedicine consultation. So once that formal consultation has happened, that is when, the clinicians sitting at the tertiary centers, they can kind of guide them, that how to go about it, what all tests need to be done, and then of course genetic testing it's very simple. I mean, if it really boils down, it's just blood sample, no? So we can easily ask them that, you can give us 2 to 3 ml of blood sample, at any nearby collection center, which is where actually, a company like Agilus can really come into play, because we have more than 9,000, sample collection points. We have more than 410 lab good networks all over India, and in fact even in the international markets. So once the diagnosis has been made through telemedicine consultation, then we can ask the patient to submit their sample anywhere near their home, so that they don't even have to travel far off. And then of course followed by a post-test counseling, and then we can direct them to a multidisciplinary team, so for further management and everything, right? And that will also help us so once the genetic diagnosis has been made, they can also be directed towards the therapy part also. So then we can direct them to the pharmaceuticals. We can also help them with the drug development. So all that part. So that comes later, but at least from the patient point of view, I think this is where we can kind of collaborate.
Thank you, Dr. Bhatia. And you alluded to several specialities. So my next question is to Professor Gulati. And you run a Center of Excellence for Pediatric Neurology in AIIMS. And you also see, patients across the spectrum. But the first point of contact for a patient could be any specialty, whether it's dermatology, pediatrics, medical genetics, or pediatric neurology, etc. How do we create a strong referral pathway, and so that patients know where exactly to go? Because one of the questions that most patients and families ask us is, which specialty should we go to first? And who is the one who is going to channelize all these specialties into the treatment pathway, so that they don't have to make multiple visits but are able to come under one umbrella or one roof, and are able then guided by a team? So how do you think this is made possible in AIIMS, and what is it that we are doing for the clinic that you are now establishing in AIIMS?
Thanks, Dr. Ratna. I think that I have to answer this question in two parts. Part A has been partly already Dr. Hemlata has alluded to. First is you have to do the screening, and second is the final diagnosis and follow-up. So in the screening, I feel most commonly the people who are going to be, we have to target is the pediatrician and the dermatologist. Why is because the caphylous spots are seen in the infancy. The freckling starts in the school, in this childhood years, and your neurofibromas come around puberty. And we have to understand that we have to empower to all professionals, but especially focused on pediatricians and the dermatologists, because these lesions will go to them, right? And when they come to know there is genetic, they may go to genetics. So they are the three people who will end up seeing: a neurologist, a dermatologist, and the genetics will be getting it, because predominantly the obvious one is the skin lesions, right? That is one thing. But then you have to understand that NF1 has multi-systemic thing, and it is going to evolve over the entire life. So you have to, after the screening thing, after you have empowered, and very rightly Dr. Hemlata said, even I had wanted to keep a point that you have to have telemedicine, because you need to see those images, so it's doing on WhatsApp and all is fine one-on-one, but I think telemedicine formally being done can help us doing it and empowering them. And only in certain selected cases you actually need genetic testing. In those asymptomatics and initial ones, you have the early ones that is there. But then when you have all these centers who are saying, like, we have our established protocol. So we know that when you're screening, we are going to see all these systems. So you have to see the eyes. You have to see the eyes. You will have to have an ophthalmic evaluation every year. So then in the ophthalmic evaluation, you will have to see the fundus every year. You will have to see the vision every year. You may need certain ophthalmologic coherence tomographies and all that may be as and when available, but then you have to follow them every year. And then also for your, the child to be seeing head to toe, because NF1 is a neuroectodermatosis, so the manifestation, that's why we are picking up from the screening outside. Then you may have ortho problems depending on the place where you are having the lesions. You may have hypertension coming up, and then most of them have the predisposition to develop various tumors, which may both non-malignant and malignant. So that is why they'll have to have an annual periodic follow-up, especially when they are going to transition from the childhood to the adulthood. So you have to have your protocols in place and follow up these patients. And yes, they have specific treatments. For some skin things, they do laser. For the bigger ones, they are doing also surgical things. For the eye one, when you have those optic gliomas, they are also giving chemotherapies, but they generally avoid radiotherapy in NF1 because you have a predisposition of secondary malignancies in them. So you need to know that in the evolution and follow them up closely. And yes, for the plexiform neurofibromas, you have this MEC inhibitors, you have selumetinib more than equal to 2 years of age, it's been approved. So that is there for those who are refractory to the surgery or recurring after surgery, or they are in areas where you can't do a surgery, because it will depend on where they are. So I mean, it's a complex thing. So you have to understand the condition and understand that things evolve and systemic involvements may change. So you need to know and preempt and pick them up before you end up having a complication because of that.
Thank you, ma'am. What you just described is perhaps, the natural history or the patient journey. If you look at it from the perspective of the patient, how do they go through various steps of their life? And not all neurofibromas are life-threatening, as Dr. Bonde mentioned. Some can live for life without any complication. It's only certain, plexiform and other large tumors that then endanger the life of the patient, especially if they are in places which could be life-threatening. So my next question is to Dr. Sandeep Arora. And since Dr. Gulati mentioned, about the complexity of the course of the disease and the challenges in identifying who is eligible for therapies and who needs lifelong counseling, follow-up, etc. Do you have any best practices as a global pharma company that you can bring to the country here and to the clinicians and other policymakers that we can then follow in terms of, say, natural history or creating patient registries, creating data and evidence that can then help us understand what the burden of disease is and who is really eligible for this treatment?
Thank you, Dr. Ratna. So I think from the best practice, I can think of first understanding the pain points. In India, the pain points might be different, as Dr. Shefali just mentioned, right? And Dr. Hemrata also alluded to. Awareness is a challenge, diagnosis is a challenge, patient hops from one place to another. So the best practice can be fit in only when the pain points are very similar. So I can bring in from a developing country like China, for example. So first we have to understand that not all plexiforms require medical treatment. Most of them can be corrected surgically also. So for the medical inoperable PNs, we need to have a medical solution, which we have now, fortunately, in our country. The only gap which is left is the inclusion in the NPRD policy, which Honorable Minister has raised. That's a good way for the patients. Now, how to increase the adaptability of that treatment is based on the pain points. Now, from China, I can share an example. So there is a center, by the way, I don't know whether that will be equitable to the country like India, but definitely, very near to India, is they have almost 3,000 patients in one center of neurofibromatosis 1. And out of that, almost 700 to 800 are PNs, and they are treated medically, right? So how they have gathered these patients is they have created this whole concept of what I think Dr. Shefali is also trying, MDT clinic, right? Which is multidisciplinary team clinic, which is on one aspect you have plastic surgeons, dermats, peds, of course pediatric neurologists, and then you decide on the patients, which type of patient need what kind of treatment. And in this, when you identify inoperable PNs, then you get into medical, then most of the patients get into surgery, but 30 to 40% do land up in medical treatment. So one example I can share is the MDT. How did they build the MDT? They created this hub and spoke, what Dr. Hemrata was alluding to. Telemedicine is a great example. So they have these referral networks where the patients are directly sent to these centers and they are being managed. Every month they have a clinic, and that's how they do it. In fact, one of the centers I visited in Bangalore, Center for Human Genetics, Dr. Meenakshi Bhatt, she's running that, and we have now very recently collaborated with them, right? So it's not that the collaboration can't be possible, it is possible. It's just the people have to come together, they need to know each other and what we can also do and support. So MDT clinic is one. Now what has happened with that MDT clinic in China is that they have started publishing evidence now because they have a huge patient data. And now they are influencing the policymakers with that data, right? And that's how we need to start. We need to start somewhere. And I think MTT Clinic with the right set of patient identification and then generating evidence on those patients to further continue the treatment, because the pressure has to be on the government to continue the treatment. And if we share the data with them, that the patients are now really progressing well, and that's how you need to continue the treatment, that really shapes the story. That's the key thing.
Thank you. And you talked about collaboration, and of course, working with AIMS, working with Dr. Meenakshi Bhatt at Bangalore, working with SAT in Kerala, all these are opportunities for collaboration. But then not many people know about this collaboration. So what can be done to make this more, visible so that anybody who wants to explore and take it up as an example and set it up in their own center of excellence can do it as well?
Okay, that's a very big question. So I can break it down into two. First, let's say on awareness. Let's focus on awareness. Telemedicine is the root, but how can we approach telemedicine is one way, but the other way is the CME. So for example, IAP has local chapters, right? And many of us are part of IAP, right? So we can increase the awareness of NF1 in those local chapters, which they do every month. So every month there is a CME in IAP local chapter can be partnered with IAP to increase the awareness around NF1 so that the referrals are being sent to the right experts, right? The second one is on the awareness around COE is something which we can create a group of experts which are dealing with NF1 like Dr. Shefali, Dr. Meenakshi, there are many experts who are dealing there, and then they form the kind of an expert group and they decide what needs to be done for the patients, and we are happy to partner, like myself from AstraZeneca, Dr. Hemlata from Gillis. I think we can all partner together and create that forum, a voice of experts so that more and more patients get into the treatment funnel.
Thank you. And on that topic of experts, I would like to move on to Dr. Jyoti Vajpayee. And Dr. Gulati mentioned about the various complications that happen, including, cancers. So, ma'am, NF1 patients often face complications that require long-term clinical as well as surgical support. And what do you think are the key challenges in managing this support? And how do you think NF1 can be managed for lifelong when they have problems almost every year?
I think excellent question, I would say, and thank you all the panelists for this very live and very vital discussion, very, very meaningful. Essentially, I believe, such diseases, such rare diseases, and, when there is a propensity to develop rare cancers also, even ultra rare, I would say, because as such, these diseases are rare, and when they develop MPNST kind of cancers or optic glioma kind of things, they become even ultra rare. So it becomes extremely, extremely challenging. And we really, as it is said that, you really need entire village to raise a child. These are the diseases which really need an adoption by multiple stakeholders. And I'm glad that, you brought this topic, and here there are multiple stakeholders which are present from different fields. And I truly believe that, because these are so heterogeneous disease, and as you rightly pointed out, that every year there is a new thing which is coming up. In the early childhood, there are learning disabilities, skeletal deformities, etc., Caffioli, macules, and later there is a frackling, then there is even an adolescent adult, there is a risk for developing MPNST, which is a malignant peripheral nerve sheath tumor. And it is a kind of sarcoma, which is pretty aggressive and poor prognosis, in comparison to other sarcoma of similar type, and they are NF1 associated. And there is almost 10 to 15% chances of developing these kind of cancers. So one has to be really vigilant. And then there are, many, many other things, and, big neurofibromas, plexiform neurofibromatous, etc., kind of pressing, compromising other vital structures, which keep on happening, and one has to be really vigilant. Surgical resections are possible. So whenever there are possibility, we must do that. But many times it is not possible also. And complete resection. So that also poses a lot of challenge. So first big challenge is heterogeneity and the constant development of newer things. So it is not an event, it is a spectrum. So one has to be entire time, vigilant, and kind of there should be a hand holding by different stakeholders, I believe, which can take through a person in this very difficult journey. This is one of the very, very important cancer predisposition syndrome, and lifetime this risk kind of continuing. So that is the biggest challenge, I would say. And then, because many times these are not surgically completely resectable, many times advanced diseases. So till the time of this precision medicine, algorithms really started working here, and with the genomics, and when we are knowing things, and also there is actionability now that we have this RAS, RAF, MAP kinase pathway which is active and we know it, and there is a drug also, now which is available, and the salumetinib or some other MEK inhibitors like tomatinib. So salumetinib is an approved drug, and it can really work very good in these patients. So I think one has to has that kind of knowledge, and that's where it is important that patient and families should reach to right people right in time, so that the lot of morbidity and mortality can be avoided, and we can manage them well. So I think these are the pain points, these are the challenges, and I truly believe that we really need to create a task force. The people who are passionate for treating rare diseases, rare cancers, they should all come together. So I'm very glad that these people are here who all are having with an equal vision and mission. So why not to create a task force, so that people know that where to find guidance. Then there can be a website, there can be some information, because many times these rare diseases and rare cancers, they become very challenging because level 1 evidence is not there. Very few people only know how to treat, and then people are reaching to them very late in the course. So I think these are the dots which we need to connect by some proper mechanism, and that's how we can improve the reach and prognosis.
Thank you, ma'am. And we all know that NF is a chronic, lifelong, complicated, progressive disease, and that there are several aspects of the condition that need to be treated, and especially if you have to look at the human as a whole, because even if the person may be alive without a life-threatening situation, there is deformity and other issues that need to be taken care of. So my next question is to Dr. Amit Talwar, and given that this is such a complicated, lifelong, progressive condition, what do you think are the opportunities for the Indian pharmaceutical industry to come up with innovative therapeutics that can help ease the pain of patients with NF?
So first of all, thank you for inviting me to this panel discussion, and just to give a brief introduction of what IPA is. Indian Pharmaceutical Alliance is an alliance of 23 leading Indian pharma companies, and we account for 65% of the Indian revenue and 85% of the Indian R&D. So yes, we do a lot of R&D with regards to the generics that we have done, and that's why we've called the pharmacy of the world, exporting to 200 countries. Coming back to the genetic disorders, I think the vision is there to move into this space, but there are a few challenges that we come across. I think it's first important to acknowledge those challenges and then to move around with the opportunities. So I think firstly, as mentioned by many of the groups, many of the panelists also, there is lack of data that is available in the form of the fragmented registries. So we don't have a collated data which can be helpful for our clinical research, and this research is required for further development of the drugs. So I think that is one thing, and this stems from a diagnosis that is delayed. I think I was just reading some numbers there, probably a couple of years dated. There was some 70 million population that had some form of genetic disorders, and there was only 1.5 to 2 million genetic testing that had happened in that year. So we can see the huge difference that is there with regards to diagnosis, and I think that is one of the major problems when we say that we need to collect data. Yes, everything is happening in the tier 1 and metros, and the government is doing a lot, but there's still a lot of things need to be done. Second one, I think there's a challenge with regards, since the population that we're talking about is very small, the economies of drug development, and I will bring the industry perspective here. The economies of drug development do play a role here because the population is very small, and if you see, for a normal drug to be to discover a normal drug, there is around 1.5 to $2 billion that we are talking about with a very low success rate. And this, we are not talking about any complex molecules. These are normal molecules that we are talking about. So as an industry, everyone thinks about the returns that they will get. So I think, one, we need to discuss on innovative financing models that need to come up and an ecosystem that supports these innovations. Like, for example, if we take some global examples, there is an Orphan Drug Act that has been there in US, and which gives some innovators certain market access priorities, certain tax benefits that help them do these type of innovations. And the number are staggering because from that act, around 600 orphan drugs have been discovered in US since the time that act has come up in place. So I think these are some of the things that we need to do in order to, and this will again lead to affordability concerns, because if more and more drugs come into the place, I think the market competition itself makes the drug more affordable. So I think these are the challenges that we see once we have acknowledged and we work towards these. Will give us an immense opportunities to discover new drugs, to have those collaborations in place, to have those centers of excellence, and have those medicines in hand of our fantastic clinicians who can then treat the disease as required.
Can I just add what Dr. Amit has built? In fact, we can look at our neighbor China. They were like 5 years back. Their regulatory and the policy reforms were not very conducive to innovation. And they really changed the tide, and now they are leading innovation with respect to even beating US. And that's where the cost-effective innovation is happening in China. Most of the innovation I am aware about is definitely in oncology space. They take just 30 days to get the application approved, reviewed, approved, 30 days, versus what we take in India, right? So that's the kind of policy hurdles what I can really relate on. And the second thing is the drug developers, they partner with the government on the innovative funding part, and they really get the access, the ROI, which we call as access and ROI to the company back. And that what fuels the innovation. Now you see most of the pharma news around the globe, many of the multinationals have tied up with Chinese biotech players, including our Indian pharma players as well. I have seen news from Sun, Lupin, Glenmark. They're all tied up with Chinese biotech players. The reason is simple. The innovation is happening there, and it's at a very cost-effective and a very speedy rate. And that's what they want to bring in India. But I think we have to also start looking up with respect to the best practices which are adapted just across the land, right?
There's another thing probably I'll add. So see, if you think a decade back, this situation was the same even in diagnostics. Diagnostics was also unaffordable for most of the patients, right? It used to cost them around 1 lakh plus at that time. And now look at the cost. So within a decade, the cost has come down drastically. Now, why did that happen? It happened because of the innovation model, I think innovative model that came up in India itself. So see, earlier we were relying on buying the machines from Illumina or Thermo Fisher, and the sequencers were very costly. But then there was this innovative approach which came up that you don't pay us for the machines, we will buy the machines on reagent rental model. So what happens is that the machines are put for free, you pay us for the reagents. So, that whole financial burden shifted, so it kind of dissipated that whole one-time investment to over the years. So it became a closed system though, but at least it was something that we were able to achieve within a decade, that the cost came down from 1 lakh to 10,000 rupees. So something on similar lines we'll probably need to work out even for the pharmaceutical industry.
I just want to add here, the very good discussion which is happening, and, very, very important points made by my other colleagues, panelists, that, especially the example from the neighborhood. Yes, I completely, echo this, that, we need those innovative strategies, and we need to move fast and forward in this direction, because, patients and diseases do not wait till very long. So we need to provide solution well within time and real time, I would say, and that's how academia, industry, everybody should join hands and, for the betterment of our patients and innovations. That's the way forward, and especially in the rare disease segment, because again, the path is even more slow and complex. We need to be really very innovative. We need to have some unique solutions, our problem, our solutions kind of a strategy, and early drug development, definitely we need it. So I, being an oncologist in tertiary care center in Apollo, and my prior experience to almost 2 decades to Tata Memorial, wherein I was treating a lot of rare cancer patients, we have lots and lots of patients who are in need. Even with a common cancer, after 2, 3 lines, there is really a challenging situations. This becomes challenging that point. So we need that drug development facilities and trial units put together. I think all of our efforts cohesively will be very much required.
Just to add, sorry, I'm a bit more, this is a very important topic to discuss. I'm very passionate about these research and innovation. Is that we are doing a lot of trials in India, but just count how many rare disease trials are happening, right? So that tells the story. Like myself, I mean from AstraZeneca, we are doing almost close to 90 or global trials, multiple sites, right? And if you look at rare disease, hardly anything. So I think we need to have that kind of mindset amongst the regulators and the policymakers that if you want to bring innovative rare diseases in India, we need to have that kind of policy mindset as well to bring innovation, to bring clinical trials.
I think it is pretty conducive right now. Over the last decade, there is a lot of change in the regulatory authorities, and we have been part of various rare disease multinational trials, and not AstraZeneca, but Novartis and Sarepta, and Riddle and Neuron. So we've been part of rare disease trials. So it is there, and I think it is very much changed. And they've also started, trying to have a pre-submission guidance, which is a paid one, so that they guide, you waste the time. I think they're trying to do their best for expediting. Yeah, much more has to be done, I understand, but they're fast-tracking. And as Monica was mentioning, even I'm in one of the co-chairs for one of their things on rare disease research and neuromuscle. They are really proactively doing. We have had so many calls for those specific conditions, and they are really encouraging, both for the research and for the regulators to are doing it really fast track, much more which was then 10 years back. And now I think there is a change, but they can be even more change and more faster, but I think there has been a lot of change in the last decade. Yeah, it is shifting.
Thank you. Having said that, the representation of Asia, not just India, is just 2% of global trials. So we still are a long way back in terms of innovative molecules, and I think our regulatory environment does not allow certain phases of the trials in India. We can't do phase 1. There needs to be still more work that goes into it. But coming back to NF1, since we already have a molecule that has such promising results, how can we strengthen the health ecosystem? And we talked about all the pain points, the challenges, etc. So one question to all the panelists, if there has to be one quick win, what would that one quick win be, given that you have a timeline of, say, 1 year? So we could start with Dr. Arora and then move forward.
One quick win, in fact, I will say 2. One is let the drug be in the policy, which Minister has raised. And the second should be that how we can collaborate with the government to maintain the sustainability of the treatment.
Thank you.
So I think I would again say 2 things. One is the public-private partnership, which is something I really feel is very important. I think more for data, Dr. Amit mentioned about data. I think the focus is totally on the government institutes as of now, whereas I think even private laboratories, private hospitals, they have a lot of patients, they have a lot of samples. Like I can talk about IHW cities. We have thousands of genetic samples being processed every year. I'm sure there are a lot of patients of NF1 there. So once we start feeding in, so many labs all over India, if we start feeding in all that data to the central system, so the government system also feeds in that data, we also feed in that data, so that integrated data will become the voice of rare disease patients, number one thing, and that will actually highlight the burden of disease in India, one thing. Second thing is that data will also be used for drug development and research. So that is one aspect. Second is, I think, more of AI-enabled tools. I think that is going to kind of cut short our lot of processes. So it will be in diagnostics. If you ask me in diagnostics, yes, the process will be faster, innovative pipelines, in-house pipelines that will bring down the cost further. But at the same time, if we start integrating AI models, that also reduces our timelines in a lot of ways. It also saves us a lot of money also. So either way, yeah.
Thank you. Yeah, I think I wanted twofold. One is the collaboration between various clinicians and specialists who will be required in the pathway, because people forget sometimes you may have invisible problems like autism and learning disabilities and ADHD coming up and not the others. So I think that is one thing that all the professionals to get together, and I really like the idea you floated that we should have a task force at a national level so that you can have a socio-cultural, economically sensitive protocol which can be there, so so that you have to streamline. And I suggest that you should have a post-marketing surveillance in place, because that will generate the data for understanding what's happening. And it's not only public private. I think every stakeholder should move to inch forward together, and it includes the parents, the parent support groups and all the NGOs, in addition to obviously pharma and pharma association and government, everybody. I mean, yeah, public private comes in picture, but that's the basic thing. But all the stakeholders actually should come on a platform, and everybody moves a step ahead together in the journey, because in silos nothing works actually. So that is one. Thank you.
I think it's a collaborative approach as has come up in the panel, right from the government, the policies that need to come up for genetic diseases and neurofibromatosis, to the clinicians that we already have, to pharma industry, to the advocacy groups. I think everybody has to have it. Is not, as ma'am said, one particular thing inside who would not help, and there could not be a quick wins, but we'll have to work collaboratively to achieve the bigger, larger picture.
I agree.
So I think, as a early win, what you said, I believe that, we need to create a forum, a nationwide forum wherein, we can, right from the early diagnosis to structured surveillance throughout these years to treatment, the guideline, dependent, and compliant treatment. And maybe we can generate our own guidelines with that task force. That would be probably very, very vital, because right now the care is very unstructured, and everybody is doing what they feel is fine. So if there is a task force, if there is a guideline, national guidelines, and perhaps the things will become streamlined much more easily. That's what I feel. And there has to be a generation of national database in this regard, and then access to drugs. So then, ultimately, we need to reach to the masses. So those all put together, connecting dots, I would be, I would feel will be a most important low-hanging fruit.
Thank you, Dr. One thing. I was just saying regarding, like I was the president of Association of Child Neurology India. So for last 4-5 years, we've been doing always NF. I think that should be encouraged. Only one thing, there should be some way, there should be some way that, the CSR funding can be streamlined to one source, and I don't know from there how to be given to patients, but there should be something developed centrally rather than, various parent support group going on asking. So there should be some framework which the government will have to facilitate for the CSR funding to reach to the rare diseases, because everything cannot be from the government funding, as you understand, so everywhere. So like we keep talking about that, but there should be some channel we can request the government to make a task force or something in which a framework can be developed, a pathway in which the CSR initiatives can be directed towards rare diseases, and then obviously they can also decide that whether the person who's donating can decide on which disease. I don't know. I mean, that will have to be protocolized. Something will have to be thought of. Just a thought. I agree.
So this is just a thought echo, Dr. Shafali. I would say that very strong support to what you just said. We require, there can be a lot of talks, but we need to execute, and for that, this is the fundamental thing which we need to have. And, with this, we can really channelize the resource distribution appropriately. So I think this is a need of the hour. Rare disease and rare cancers put together, I think there is a lot which can be done by such measures.
Thank you. And I think the three words that really popped up are innovation, partnerships, and collaboration. And if this is there, then all the problems that we have been discussing over the past 1 hour, there would be solutions that come up that each stakeholder can then, contribute to and make the journey for NF1 more easy. So last question. I'm not sure how much time the organizers have for me. So, okay, 2 minutes. In 2 minutes, which is 30 seconds for each one of you, because I represent the patient voice and the patient advocacy group, as a stakeholder, what would be your advice to us as to how we can make our contribution more meaningful to make all that was discussed now, more successful? So we can start with you, Dr. Amit.
Together we can, and I think you should help, break the maze for the families. I think that's very important. They should not feel lost here. I think the together we can is the motto I feel.
Thank you. Dr. Amit?
I think it's important to collect the information from various sources because one person cannot have all the information, and to make sure that the patient has access to all the sources, all the resources that are available, which can be of benefit to the patient.
Thank you.
Yes, I think I would say social media. I think we underestimate the power of social media with the current generation. So I think we should really kind of make those that information accessible on various social media platforms, be the voice on social media as well. Yes.
Very pertinent.
I had a very similar comment. PR, social media, whatever the channels you have, do that. That creates a lot of impact.
I would simply add to that maybe we need some kind of sensitization to journalists as well, so that they are able to cover some of these stories, because patient stories are very vibrant and very powerful.
So I echo that actually, we need social media support and also some appealing people, influencing people, maybe even celebrity quotient, because that increased the awareness substantially in genetic cancer like breast cancer. Angelina Jolie has increased the BRCA mutated cancers awareness to the level that no amount of national program could do. So I really feel that we should use all these means for betterment of our patients, and that's how we can move in the space fast.
Thank you so much. Thank you to all the panelists. We are right on time, and I'm sure all of you are very hungry and waiting for this panel to conclude. So thank you to the organizers. I think we had a very good discussion. I have myself noted down a lot of points, and back to the organizers. Thank you so much once again.
Thank you very much.
Sorry.
Thank you to our speakers for sharing their thoughts and speaking their hearts out on this important issue. I would now request Mr. Uttar Kumar, Senior Consultant at IHW Council, to please come up on stage and present our speakers with mementos. We want to thank them for coming here and sharing their knowledge with the audience. I request you to please present memento to Mr. Sandeep Arora, Country Medical Director, AstraZeneca. A memento for Professor Shefali Gulati, Chief, Child Neurology Division, Coordinator, DM Pediatric Neurology Program, AIMS. A memento for Dr. Hemlata Badwani Bhatia, Vice President, Genomics, Agilus Diagnostics. A memento for Dr. Amit Talwar, Associate Secretary General, India Pharmaceuticals Alliance. And a memento for our moderator, Dr. Ratna Devi, CEO, Dakshyani and Amravati Health and Education. I request all of you to please gather for a group photograph.
इन्होंने 3 से स्ट्रिपिंग की हुई है ना अपने से की हुई है ना तो वही रही है क्या सर्वर पे कमाया अरे अंदर अंदर सर्वर कहाँ पे वहीं पे सर्वर से कर रहे हैं ना बेसिकली
We wanted to thank Dr. Jyoti Vajpayee. She was joining us virtually. So if the console can put her image on, so we'll have her in the group photograph.
Hello, I'm there, but yeah.
Thank you so much, ma'am, for joining us today and sharing your thoughts with the audience.
Thank you very much. Sorry for some sick patients I couldn't join in person, but I enjoyed the discussions.
Thank you to all our speakers for joining us, and thank you to Jyoti ma'am for joining us virtually. We will take a lunch break now for about 45 minutes. You will have to, the lunch is being served one floor from above on the first floor. So request all of you to please take the stairs one flight up where the lunch is being served, and request all of you to please be back in your seats another 45 minutes.
सूरज वहाँ ऊपर जा पहले माइक चेक कर अच्छी बात है इनको जाने दे फिर चेक करियो ठीक वो तो हम देखेंगे तो वहाँ पे ओनली श्योर रखियो है इसमें म्यूजिक देखो चला दो चला रहे टोटल 20 लगी 20 लाइट क्यों सारी स्टैंडीज को लेके 6 और 8 एक चाचा एक ये वाली देना 12 और 8 ओ चाचा यूट्यूब पे दिखा किसने बोला ये चाचा चला दिया म्यूजिक आता हुआ था ना ऐड है अरे ब्रेव डाउनलोड कर लो उसमें चला लो चाचा अच्छा सुनो अभी मेरे को एक चीज समझाओ जैसे वो 6 ऊपर लाइट लगे हैं उनमें से कम कर सकते हैं उसको क्या कहते हैं उनको बोमाइट भी बोलते हैं आरजीबी बोलते हैं सकते हैं वो आरजीबी भी में आता है वॉर्म भी आता है वो फोकस करता है स्टेज पर स्टेज ठीक है अब जो मुझे मान लीजिए पोडियम पे फोकस करना है उसकी लाइट कौन सी है ये नहीं वाइट वाली ये वाइट लाइट उसको क्या कहते हैं ब्लेंडर हाँ ब्लेंडर लाइट कहते हैं जी ओके इसके अलावा प्रोफाइल भी होती है प्रोफाइल लाइट हाँ पता है प्रोफाइल मना करती है आप प्रोफाइल लाइट क्यों मना की गई ऐसा क्या था मतलब प्रोफाइल लाइट में क्या डिफरेंस वो एक्चुअली सिर्फ उस पोडियम पे फोकस करती है ये सब में कर ये पूरे पे राइट करती है और उसमें भी आ ही रहा है ऐसी बात नहीं है कम करो कम बस बस ठीक अच्छा और दूसरी एक चीज मुझे बताओ ये हमने कितनी लाइट लगाई है 2 2 4 2 6 सर आपकी 6 6 12 12 लाइट ये 8 की चाहिए यूजुअली ये 6 ही लगती है ना हमारी हाँ ठीक है 6 12 12 और एक 6 आपने इसमें उसको कितना काउंट करूं मैं आप स्प्लिटर को ब्लेंडर को एक और दो हैवी होते हैं ना ये 4 है टोटल 4 है वो 2 और 2 4 4 6 6 12 12 4 16 और ये भी 4 अच्छा 16 17 18 19 20 21 22 23 और 23 है नहीं उसको काउंट कर लिया वो चल अभी ऑन नहीं है ना अभी हो जाएगी वही मैं कह रहा था ना क्योंकि हमने आपको बोल रखा था हर एक स्टैंडी पे हमारी सर देखिए वो ऑन की थी अब चलते प्रोग्राम में कुछ हो गया होगा, कोई बड़ी बात नहीं है, वो भी होना चाहिए। उधर वाला तो हटा देता हूँ, उधर वाला मत गिनना आगे, उसको हटा देता हूँ, मत गिनना। तो
हमारे यूज में नहीं आया ना।
कोई बात नहीं।
एक्चुअली क्या होता है ना, जब मेरे बॉस बैठे रहते हैं ना तो एक एक काउंट करते हैं।
अच्छा,
क्या था,
वेरी
क्या
स्मार्ट।
क्योंकि हमारे साथ चलता है, हमने किया
नवीन को बोला है मैंने, वो करने गया देखो।
वो वही काउंट करेंगे। यहाँ पे अगर एक भी गलती हुई सीधा मेरे को बोलेंगे आगे से।
आपकी बात ठीक है, कोई बात नहीं, वी आर एग्री, आप 400 काट लेना मेरे। देखिए अब किसके पूरे पैसे लगाए मैंने, ये देखो आईटी का पोस्टर के पैसे क्या लगाया मैंने, उधर नजर नहीं आएगा। आप खाना खा लो ऊपर आगे, ऊपर फंस लो, ये ऐसे चलने से चलो चलो।
भैया इसे बंद कैसे करते हैं? बाबुल का है।
Hello, 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 check, check, one, check, hello, 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 check, 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 one, check, hello, check, hello, 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 check, 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 one, check, hello, 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 hello. Hale, check, check, check one, hale, check one, check. Hale, 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 hale. Hale, check, check one, check, check, check one, check, check one, check one, check, check, test one, hale.
कर देते थे स्क्रीन पे, हाँ तो वो भी फिक्स कर लो। क्या रहे ये जो वीडियो चल रहा है वही चलता रहे, ठीक है। लेफ्ट साइड में, लेफ्ट में और राइट में, लेफ्ट राइट में डाल, ठीक है। ऐसा हो जाता है कि कट जाए सर जी, वैसा भी हो जाएगा। एक में ऑडियंस आ रही है, नहीं आएंगे सीधी, जैसा लैपटॉप पे आएगा वैसे ही आएगा। ऐसा कोई नहीं तो दोनों साइड, तो दोनों साइड, ठीक है। ऐसे में ऐसा नहीं रहेगा कि बंदे को ही दिख रहा है, उधर वाले बंदे को भी दिखेगा, उधर वाले बंदे को भी दिखेगा। बस एक डिसेंट अमाउंट है, नॉट जस्ट की बहुत छोटा मतलब। हाँ हाँ ठीक है। क्या डालना है? वीआईपी डायरेक्ट डालना है उसमें। हाँ यही इनका वही HDMI तुमसे काट देता हूँ दोनों साइड, वीआईपी काट भाई 1-2 का बस खत्म हो गया। कैमरा बंद कर दे। हाँ जी हाँ जी, ये नीचे कर देना, करना हो। हाँ हाँ ये सही है सर, सेट है या कुछ और करना एक साइड? नहीं ये नहीं है, लोगो नहीं लग रहा था, लोगो नहीं लग रहा, ठीक है। अभी सब और एक ऐसा कर सकते हैं क्या, एक डिफॉल्ट वाला, लाइक जो ऑलरेडी बड़ी स्क्रीन पे आ रहा था वो वाला डिफॉल्ट में रख सकते हैं। हाँ वो है, हाँ तो वो रख लेंगे, वो रख लेंगे, थोड़ा बड़ा नहीं दिख रहा है तो कैसा होता है, हमारे पास बैकअप होना चाहिए। वो है उसकी, हाँ ऐसे कर लेंगे। मैं एक बार एक चीज देखता हूँ फिर बैटरी है ना अच्छी खासी। मैं ना ऊपर से 2 चम्मच ग्रेवी खा के आई हूँ। कोई इशू नहीं, तो पूरा नहीं नहीं अभी हो जाएगा खत्म, मतलब खत्म। अरे अभी हो जाएगा यार, सॉरी वो हो जाएगा, अभी तो हम लोग नहीं तो आया नहीं मिलेगा। मेरे को ऐसा हो गया कि मैं टच करके आ गई हूँ टेस्टिंग करके आई हूँ एक्चुअली फूड दैट। ये उनका
उधर वाला छोटा है क्या? तो अंदर जाता है। अच्छा मुझे, मैं यहाँ से देख रहा हूँ चल। हेलो हेलो, यहाँ से बंद करो, यहाँ से बंद है, सारे बंद है, सारे बंद है। कोई पैनल से पहले तो बोल देना। साढ़े चार। हाँ। उसका यहाँ पे नहीं है। ये आपका फुल ऑप्शन है। आरिश फुल ऑप्शन है, ठीक है तुम नहीं जाते। अच्छा ठीक है ना। ऐसे वो नहीं है, अगर लाइव वाइज हो तो करते हैं तो देख लो तुम। आप शायद देखो और देख वो तो देते हो खाना वैसा है ना, पार्टनरशिप टेक ऐसा तो हाँ मुझे ऐसा रख रहे हैं। मतलब वैसा वैसा है, ऐसा नहीं कि सारा पूरा पार्टनरशिप है। मेन तो उनका है ही, इतना सारा चल रहा है। हाँ वो ये है कि ऐसा सिटिंग अभी हो गया सर। हाँ सर, नहीं भोजन अभी का होगा, पहले गेस्ट का होगा फिर हम करेंगे। खाली हो गया था बस। अभी हो रहा है, अभी कर देना। गेस्ट खाना खाते हैं उसके बाद होस्ट खाना खाते हैं। अब हम लोग क्या है ना, इवेंट साल होता है। हाँ आप ये दिल्ली से बात कर रहे हैं? दिल्ली से ही हैं। अच्छा दिल्ली से। हाँ आपको क्या लगा महाराष्ट्र है? ना 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 ना। किया था ये और भारत मोदी का चला था 3 दिन का ताज में। अच्छा और पूरी की कंपनी है लोग कौन सी एप्पल हो। अगर आपने स्विचर मंगाया ना सर, तो अगर दो होते क्या बोलते हैं उसका आइडिया केवल, तो इनको सर को बढ़िया फ्री मिलता है। 2 कैमरे करते हैं सर। आपने जो आपको जिसने हायर किया ना, हाँ जी, उसको बताया था ये सब चीज। बताओ वही है ना, रात शाम में चीज हुई, फाइनल डिसीजन तो उन्होंने ही लिया ना। मुझे पता क्या कहना, कुछ नहीं है, पोडियम बना देना है, पीपीटी चलेगी, हो गया, कुछ नहीं होना है। मैंने कहा यार ऐसा कैसे हो, ऐसा थोड़ी होता है, मुझे खाली पीपीटी के लिए फाइनल डिस्कशन। सर लाइव है ना, हम खुद ही कर लेते हैं। हाँ नहीं वो तो ठीक है। एक्चुअली क्या होता है, हमारे पास टीम नहीं होती है अभी उस मोमेंट पे, क्योंकि हम जो करते हैं ना, लाइक मैं कर लेता हूँ और एक जो सौरभ है वो करता है। अब दोनों ही बिजी होते हैं तो इसीलिए हम किसी थर्ड पर्सन को हायर करते हैं ताकि हम अपना दूसरा काम कर सकें। अभी इस मोमेंट पे हम एक मैंने बहुत बड़ा ब्लंडर हुआ था, वो 2025 लिख किया था वहाँ पे। अरे बाप सोचो इतने बड़े ब्लंडर हुआ है। फिर जाके अब उसको बैठ के यहाँ फिक्स करो। अब इसमें क्या है, इसमें लाइव चल रहा है। अब लाइव चलने पे सिस्टम को सोचो, सिस्टम कब कब आ रहा था कि भैया रेंडर नहीं चला रहे हो तुम और आफ्टर इफेक्ट की फाइल है वो।
तो 2025 लिखा था उसमें।
हाँ
ये चीज है तो मैं चेक करने वाले डेट हो
हाँ, तो
गई।
ये बड़ी वाली गड़बड़ कर
हाँ,
दी,
ये
इतनी
बहुत
ये किसने गड़बड़ की पता आपको? मैंने खुद।
नहीं रहा ना। अच्छा जी।
तो अभी फिर जाके एडिट करके उनको दिए।
ये तो सुन लो
ये
साल का इवेंट नहीं था।
हाँ, तो मिस्टेक कोई भी कर सकता है। छोटी नहीं, ये
छोटी
बहुत
नहीं है,
बड़ी
ये तो
गलती है।
पूरा साल का
हाँ,
टारगेट है।
ये बहुत बड़ी गलती है।
ध्यान
तो भी एक फाइल में नहीं,
सब सारी
सब में। तभी तो बैठ के मैं इनको एक, क्योंकि मेरा क्या होता है, इनको मैंने फाइल ऐसे अरेंज करके दिया था, उसका मुझे उनको पास आने की जरूरत नहीं है, इनको एजेंडा के साथ से फॉलो कर सकते थे बहुत ही इजीली। बहुत थोड़ा बहुत अगर चेंज होता है, ऐसा बहुत कुछ चेंज ही नहीं हुआ इस बार, तो मुझे आने की जरूरत नहीं थी। सोचो सुबह मैं इसलिए तो चला गया था। अब जब मेरे को पता है, मैंने भाई यार शिट, अब बैठो पूरे टाइम।
लेकिन थोड़ा ये लो, जैसे आप लोग इंडस्ट्री ले रहे हो बाहर, आपका प्रॉपर वो तो एम्बियंस
एक्चुअली प्रॉपर माइक है आपके कैमरे में, XLR5 वो लगता है वायर।
हाँ,
अब नॉर्मल जो हम कैमरामैन बुलाते हैं उसके में नॉर्मल लग जाता है, ये जो उसके पास हाँ लगता है। वो हर जितने भी कैमरे आज तक हमने मंगवाए सब में लगता
तो
है।
वो DSLR मंगाए होंगे
हाँ
आपने।
हाँ, तो ये भाई साहब लेके आए हैं ये, तो अब हमें कैसे पता चलेगा? उनको ही मैंने बोला कि ऑडियो के भी आप लेके आओ, अब वो लेके आए वो। अब हमसे पूछ रहे हैं, पर हम क्या है कि ये सारे जितने लोग गलती करेंगे उसका हम एक बैकअप हम खुद भी लेके चलते हैं। वो जो माइक है वो हम खुद इन हाउस है हमारा।
अच्छा,
ठीक है, हाँ, तो माइक हम खुद ही रखते हैं, इवन पॉडकास्ट माइक ये सब खुद ही रखते हैं,
अच्छा,
खुद भी करते हैं। तो वो माइक उसी का देता है, ऑडियो उसमें बहुत अच्छा आ रहा है। अब उसकी मतलब एम्बियंस हट जाता है, वो एम्बियंस जो साउंड आ रहा है ना आपको, अब हट जाता है। अभी एआई इतना स्ट्रांग हो गया कि छट से हटा देता है। हाँ, तो ऐसा कि बस आवाज ना क्लियर होनी चाहिए। अगर आवाज क्लियर है तो एआई बहुत अच्छा वर्क करेगा। अगर आवाज में थोड़ा, तो आवाज फिर पतली कर देता है एआई, ऐसे थोड़ा सा लगेगा कुछ और कोई और ही बोल रहा है साउंड, पर उसमें अच्छा सही आवाज आ रहा है अभी तक तो। बाकी क्वालिटी अच्छी है, तो बस जो मैंने आपको बताया था कि हम रील्स वॉक के लिए यूज़ करेंगे। ब्रदर इस वाले सेशन में नहीं होगा कोई वर्चुअल, अभी तक जो बताया मेरे को। इसके आगे वाले में 2 लोग आएंगे। हाँ, अब यार वो 2 लोग बहुत छोटे दिखे।
लास्ट वाले में 2 लोग आएंगे,
हाँ
तो उसमें इक्वली डिस्ट्रीब्यूट हो जाएगा।
हाँ हाँ, अरे वहाँ पे छोटे दिखते हैं ना, वरना फिर मुझे फुल स्क्रीन पे देना पड़ेगा। फुल स्क्रीन पे दूंगा तो ब्लैक दिखता है साइड ऊपर पर, अभी जो हुआ था वैसा।
वो तो 2 लोग थे ना, 3 में तो वो वाला ऊपर का भी थोड़ा यूज हो जाएगा, साइड साइड में ब्लैक
देखते हैं, एक साइड तो ब्लैक जाएगा या नहीं जाएगा,
दोनों
नीचे
साइड
जाएगा।
थोड़ा थोड़ा।
तो ये बोल तो हूँ आगे
ये तो क्लियर क्या और 8 बजे कंफर्म किया मेरी दिन चल रही थी कि भैया क्या किया जाए ऐसे ना
Welcome back. We are going to start with our post-lunch session, another 5 minutes. I request all of you to settle down and request all of you to come to the front seats. Those seated at the back are requested to come up closer to the stage so that you have a better viewing experience. Please turn your phones on silent. We'll be starting another 5 minutes.
ये तो पता नहीं इन्होंने क्यों बोला कि एक ही माइक है, मेरे साथ 2 माइक होती है। ठीक है, वर्चुअल नहीं आ रहा देखा, वर्चुअल कोई नहीं हुआ, इस तरह से नहीं
ठीक है कैमरा तो लाना होगा कैमरे का तो फीड ऑन करना है
कैमरे का फीड तो आपके पास है, स्क्रीन पे नहीं है,
स्क्रीन पे नहीं
यार लिंक्डइन का चेंज करना पड़ेगा, व्हाट्सएप खुला है ना, वो 4 घंटे हो गए, लो करो भाई, 2 मिनट लगे, क्या है ये ऑन करो, ये तो जूम है, कैमरा टीम
फोन नहीं है
इमरान बोलो
ऑन कर दो आ नहीं रहा
नहीं आ
केबल निकाल के एसडी ले ली एसडी मैं जो एसडी में ले रही है हेलो
एक वो सिंगल जल्दी जल्दी करके दिखाएंगे आगे आ ठीक है, जल्दी जल्दी मेरे ठीक हुआ थोड़ी सी जल्दी ठीक है, देन उसके बाद जो मैंने 5 में सेशन दिया था ना आपको बना के, और इस मल्टी वाला वो लगा दी बीच बीच में, और सेशन मल्टी सब सेशन में तो ठीक करके दे दिया अंदर 36 वोट वाला नहीं कर सकता वो बहुत बड़ा पगला गया दीपक को यार, क्या हो गया रिप्लाई कर दो मतलब बड़ी बात छूट यार, छोड़ क्या लिख रहा क्यों आए, छोड़ रहा नेटिंग की अभी कुछ काम कर रहे थे, अरे वो भेजे तो मैं करूँ यार, बोल लिंक भेज रहा है
डेली स्टेटस लग रहा है ऐसे नहीं होता वो मुझसे भी करना सब ऐसे हो जाएंगे हमारा
भाई क्या हो गया वो खा रहे हैं ओके लेट लगी थी ये दीपक का 70 में 80 घट्टा बढ़वा दी इसने 100 करवा दी तो आप कहाँ
मैं यहाँ पे थी दिन में मुझे पता चल रहा है, अबे मुझे भी नहीं पता कि आरएस पहुंचा कि नहीं पहुंचा। फिर याद आ गया
तो
कि
ये दीपक कब से हैंडल कर रहा
अरे
है इस चीज
मैंने
को?
अरे यार ऐसे ही फिर चर्चा आ लिया तो मैं
अरे यार तो भाई एक बात बताओ, लंच के लिए आप मेरे को खुद आके बता रहे हो चीजें क्यों नहीं?
मैंने एक एक बंदा गिना तो बताया था ना कितने बंदे हैं। 50-60 बंदे यहाँ बैठे, 20-80 तक जाएगा। अब कहाँ से 150 हो रहा है मुझे तो 150 वो तो हो गया ना। और सभी लोगों ने प्लेटें नहीं उठाई, लोग नहीं दिख रहे हैं मुझे कहाँ है, कैसे पता चला। मुझे तो इतने
नीचे से आके बैठ के खा के चले गए क्या?
अरे सब इतने तो टाइम लगाए तो
फिर भी हम मान लेते हैं कितना खा रहे हो, 20 खा रहे होंगे बाहर के।
अरे लोग प्लेट लेके खाने में खाना नहीं मिला है हमको। दिक्कत यहाँ भी हो गई ना।
ऑर्डर भी उसी हिसाब से किया था ना।
हम तू जानता है मैं होटल में कैसे बढ़वाता हूँ, 5 फिर 5 फिर 5 करके बढ़वाता हूँ। ये भाई साहब पता नहीं, इसको तो पता नहीं था, इसने 30 बढ़ा दी तब तक वहाँ खाने ही नहीं। पगला आदमी है ये। अरे बोल रहे थे यार अभी अभी तक तो शांति चल रहा था, जो इसके लिए ही सुन लिया मैंने।
भी सुनूंगा भी दोस्त के।
भाई बन गई, इवेंट बना है, दोबारा बना रहा हूँ। अच्छा
पहली बार मैं गलत बोला था उसको, अब करेक्ट कर रहा हूँ।
स्टार्ट कर दो यार।
म्यूजिक
नहीं
अच्छा
म्यूजिक नहीं, वैसे
तो कभी थोड़े बढ़ तो जाए।
हाईवे स्टार्ट करना। अब लेट लगा रहे हो
अरे
अब आपकी
आप
तरफ से लेट है आप बचेगा लेट।
नहीं पता।
चैट चैट व्हाट्सएप कर दोगे? ठीक है सर, मुझे पता है क्या बोल रही।
फेसबुक का क्यों बना रहा है?
लिंक्डइन, लिंक्डइन का बोल रहा है।
देखना आ गया।
थोड़ी देर में आएगा, रुको। अरे भाई म्यूजिक ही चला दो
यार
दोस्त।
ए फोन उठाइए यार,
सॉफ्ट म्यूजिक चला दो
भाई फोन उठा, एक सॉफ्ट म्यूजिक ही चला रहा हूँ।
कोई बहुत धीमी आवाज में चला दो। आ गया फिर डाल।
हेलो सर, पेमेंट का बता दीजिए, वो वेंडर मेरे को ना बार बार मैसेज कर रहा है।
वो हमारी तरफ से तो लग गई है सर, वो अप्रूवल पे पेंडिंग है।
तो आप मुझे स्लिप भेज दीजिए ना, मैं उसको भेज दूं, क्योंकि वो मेरे जान की आफत में ना पड़ा है।
स्लिप सर वो अप्रूव नहीं हुई है ना अभी।
कैसे भेजते हैं पेमेंट आप कैसे भेजते हैं? नहीं नहीं, आप भेजते कैसे हैं आप ये बताइए।
नए अकाउंट में लगा दी है पेमेंट।
अकाउंट में कैसे लगाते हैं, मैं वही पूछ रहा हूँ, अकाउंट में कैसे लगाते हैं?
आपका बैंक ट्रांसफर कर दिया है ना सर।
तो बैंक ट्रांसफर करते होंगे तो कोई तो रिसिप्ट आती होगी ना आपके पास, मैं वही रिसिप्ट तो मांग रहा हूँ।
अच्छा मतलब वो सिर्फ रिसिप्ट भेज दो कि जो हमने लगाया
हाँ तो उसको ये तसल्ली हो जाए ना कि हाँ भेज चुके हैं। अब वो कल आए परसों आए उसके मेरे को दिक्कत नहीं है, मेरे साइड से चला जाए ये भी, क्योंकि बार बार मैसेज कर करके ना परेशान कर दिया उसने मेरे को।
अच्छा अच्छा अच्छा
तो मैं तो हाँ मतलब मैं उसको हाँ कुछ भी डिटेल दे दीजिए तो कम से कम, हाँ बस बस वही वही उसको उतना ही थोड़ा सा।
एक चीज मेरे को बताइए सर, अप्रूव जब करते हो नीचे लगता है ना सर।
अमित सर क्या मैंने नहीं नहीं मैंने अमित सर को सीसी में रखा है, अमित सर को बता रखा है ये चीज।
अच्छा अच्छा
हाँ
चलो ठीक है, मैं एक बार आपको भेज देता हूँ क्योंकि मेरी तरफ से भी लग गई है सर वो पेमेंट।
ठीक
ओके।
नहीं अरे पानी हमें एक और करना पड़ेगा। अरे 2 करो यार। ठीक है ठीक है 3 करो, जो करने करो। भाई लिंक्डइन आया? गुड।
Welcome back. We're ready to start with our afternoon sessions on the Rare Disease Action Summit 2026. Now, we've heard a lot of speakers speak during the day, and one thing that a lot of people agree upon is that rare disease requires strong collaboration between clinicians, policymakers, patient advocacy groups, and research institutions. This session will explore how community leadership and multi-stakeholder partnership can strengthen diagnosis pathways, improve care continuity, and support patients through their treatment journey. So this session is titled Collaborative Models for Rare Disease Support, Voices that Shape Change, Aligning Policy, Care Systems, and Community Leadership. Please welcome our speakers for this session on stage. Please give a round of applause and welcome on stage Dr. Swasti Pal, Associate Consultant, Sir Gangaram Hospital. Please welcome on stage Dr. Seema Kapoor, Head of Genetic Lab, Maulana Azad Medical College. Please welcome on stage Mr. Ramchandran Bhaskaran, Chief Scientific Officer, Nucleome Informatics. And please welcome on stage our moderator for this session, Dr. Milan Choksi, Transplant Medical Lead, Sanofi. I'll request Dr. Choksi to start the conversation and take it ahead. You can take a seat there also.
So good afternoon, dear faculty. First of all, heartfelt gratitude to the IHW Council for making this Congress present and also a good success. Now we have been discussing a lot since morning regarding collaboration, regarding support, regarding the need to partner, to have teamwork. And this session is dedicated for that particular reason. So we have with us Dr. Swasti Pal, who is the Associate Consultant at Sir Gangaram Hospital. We have Dr. Seema Kapoor, who is the Head of Genetics at MAMC, has been one of the leading academic institutes in the country. And Mr. Bhaskaran, who is the Chief Scientific Officer at Nucleome Diagnostics. So, Dr. Swasti, considering very inconspicuous signs and symptoms in clinical presentation of various genetic disorders, low birth weight, delays in developmental milestones, which can be attributed to various common conditions as well. What do you think, how can we improve the speed of diagnosis? And is that a major challenge that you foresee?
Thank you. Yes, I think that is the foremost challenge, that first the disorder has to be, or the person has to recognize that this could be genetic. Only then will we reach the next set of challenges, which is finding the ability to diagnose or treat it. And as it is for anything else, the most important is awareness. It is got two limbs, awareness of the patients and awareness of the primary physicians or the first point of contact for the patients. So if the family is approaching somebody who's not in a tertiary center and their first point of contact does not appreciate that the subtle signs and symptoms could be a genetic disorder, they're never going to make it to a diagnosis, right? Few families can be proactive if they have a recurrence and so on. They may seek a higher center for further testing. But the core is that the primary care physician has to be sensitized, has to be made aware that genetic disorders don't need to run in families, don't need to be stigmatized, don't have to be considered a last option in diagnosis. So many such things starts probably from our education, that right at the base curriculum level, there has to be more information and more inclusion of genetics. followed by more meetings for the practicing physicians, although I think this has really increased in recent times. There are webinars and so on. But yeah, we have not made it all the way into the secondary, tertiary levels, which primary and secondary levels, which still needs to be done. Yeah.
Done. No, sure, ma'am. Thanks for those insights. I mean, yes, for awareness, the primary care physicians, the physicians who are in first point of contact with the patient are extremely critical, and they need to be made aware and educated on various genetic disorders. Dr. Kapoor, would you like to throw some light on this?
I thank you all for calling me here, and I would like to say something a little different from what everybody feels. I first feel there's nothing called rare in India. That's the first misnomer, because the number of the population that we have, just Delhi alone equals Australia in population. So I don't know what's rare, outside will be rare, right? Now coming to the challenges, since this is an industry partnership program, we can overcome these challenges by very, very simple methods. One, lab-grown methods. Two, curriculum-based methods. Three, collaboration-based methods. So first I'll talk about the industry model, right? The industry model is crucial because we have reached the height in IT. In fact, all of Bellevue, if you see, you would hardly see two houses without an Indian. And same is going to be the situation for genomics. So India can actually lead the AI as well as the bioinformatic part of the entire country. Now what has to be done, the collaboration is starting simple tests, which we commonly call as GLAC, G for glucose, E for electrolytes, easily available, lactate, not easily available in peripheral center, acid base, and ketones. So if an industry just picks up point of care testing to be done for ammonia and lactate as a challenge today, there's so many industry people here, you can pass this message on and give it to a primary care physician and tell him, when something which comes to you looks a little abnormal, there is a family history, do these common tests. That's one very, very basic thing. Second thing that we need all our people to understand, that diagnosis of genetics, which now is 90 disorders, included in the RUSP panel, recommended universal screening panel of US, contains SMA, LSDs, all primary immunodeficiencies are now called as inborn errors of immunity, all DNA-based diagnosis, all fatty acids, endocrinopathies, all of these together, 90 disorders. The cost of one disorder is less than $50, and the cost of 50 disorders is currently less than what India is spending in Mission Indradhanush. 7 vaccines given up to 5 years of age, cold chain maintenance. If India can spend this much for Mission Indradhanush, now we see communicable diseases have really gone down, and the non-communicable diseases and genetic diseases are coming up. So newborn screening for rare and common disorders should start in India as a primary target. Why it's important? Because the enzyme replacement or the drug replacement, if it occurs before the symptoms are in place and the blood-brain barrier is not too bad, they will go and help, even in utero. Now we have ERTs available, right? So this was the AMBET part. I'll just hurry up two more parts. Another very good thing which the undergraduate medical curriculum has started in the competency-based education is the UG elective. Undergraduate for 1 month can choose an elective. He can go to a skill lab, he can go to an anatomy dissection hall, or he can come to genetics. Believe me, the last 2 years, we've had astounding reports from the electives posted in genetics, which made them interested in doing PhD in genetics after doing MBBS. A carrier very less.
So, ma'am, just to make one comment here, when I was doing my MBBS, honestly, I didn't have any option of genetics. So, this is a very, very healthy development. Thanks for this, and thanks for sharing.
Second thing is, in the curriculum for nurses, you would be surprised, 30% of it is genetics. So if you only add 3 months of observership in genetic counseling,
It goes a long way.
a long way. So we have many things in place, we just have to move.
Sure. Mr. Bhaskaran, your thoughts. Ma'am mentioned about point of care test, also various advances in genetics as well as bioinformatics. First of all, if you can share some light on what are these advances, also on the point of care test, if they are available and what they are. And the critical piece is how can we collaborate and take it to the mass?
Okay. Point of care in genetic testing is not as widespread or not even possible as it is with any analytical tests so far. Having said that, the reach of genetic testing, so I come from a genomics company offering genetic testing. So I can speak on those and around those. Genetic testing over the last several years, the reach has really, it won't be at the point of care kind of scenario, but a lot has improved where, like a hub and spoke, there is a spoke, there is the samples coming in, you can establish in tier 1 cities labs, and then it has reached a great level of acceptance. With respect to genetic testing, the technology is evolving. So the access to technology is one aspect. The access to the technology, there are multiple kinds of technologies in genetic testing. So one kind of a short read based technology, it has reached a lot. So it has, the companies have done a lot of education and awareness programs. So it has reached a lot. But the advances in genetic testing are, especially with respect to rare diseases, it is going to be the long read whole genome sequencing. So the targeted sequencing, the exome sequencing, they have actually served the purpose. With respect to rare diseases, oncology, it has been helping a lot. But the long read whole genome sequencing is going to be, it has a lot of advantages over the short read sequencing, and people have been experiencing that. Actually, I think Dr. Ashwin Dalal is going to be there in the next panel. So we did a long read whole genome sequencing for a undiagnosed hackathon at CDFD last month. So the long read sequencing helped a lot. So the diagnostic yield improved a lot with respect to undiagnosed diseases, for rare diseases especially. So that is going to be the future, probably even for oncology, but definitely for rare diseases. So the advances is mainly in long read whole genome sequencing, because it is not just the single nucleotide variant. There are huge structural variations, copy number variations, inversions, deletions, and epigenetic modifications. So there are so many things happening with disease background and causative, that long read whole genome sequencing is probably going to be the future, and I think especially for rare diseases that is. So that access with respect to long read is going to be nowhere close to point of care, definitely not in the near future, because it requires a lot more sophistication with respect to not only the sequencing, with respect to the bioinformatics, the analysis, the interpretation, the annotation, and presenting actionables to the clinicians. So it is going through that evolution as of now. So point of care, I wouldn't even go near that for genetic testing at this point of time. But the reach has been definitely there, so we know how to take it to the tier 2 and tier 3 cities. It's just a matter of crossing a little bit of skepticism. So we cross that with short read sequencing. So we need to cross that with the long read sequencing as well to see how to present actionables to the clinicians.
Sure.
And bring down the affordability. So increase the affordability.
But Mr. Bhaskar, how do we work closely with clinicians and the healthcare ecosystem to make it more accessible and more available, right?
Yeah, so that brings to the affordability, which I was going to say that the affordability is a kind of a catch-22, where the higher the scale, the affordability is going to be better because the cost is going to come down. So, and to get the affordability, the scalability has to be linked.
Sure.
So we are actually collaborating with a lot of hospitals. So we have partnerships with several clinics and hospitals and medical educational institutions.
Sure.
So we are partnering with them. We are trying to see how to take this long read whole genome sequencing. So by the way, we are technology agnostic. So whichever the objectives of, so we do short read, we do anything. So we are collaborating, we are building partnership with hospitals.
Sure. So my next question is, to Dr. Kapoor. Genetic testing is critical for confirmative diagnosis, right? Again, how easily it is available, how do we explain to the patient, is there education, awareness required, coordination between different specialties, if you can throw some light on this.
So first I would like to make a little correction.
Sure.
The point of care testing was for ammonia and
Ammonia,
lactate,
yes.
not for
Genetic
not for
mutation
genetic
or,
testing.
yeah.
But the filter paper that you collect on newborn screening gives you good 20 nanogram of DNA. And I have a lab which has both the short read as well as the long read sequencing. And we know advantages of one over the other, right? So if not point of care, not at the bedside, but still the turnaround time is less than 7 days now for whole genome with long read sequencing by multiple companies. And we now know that the biggest evolution this is done is in the 3 fields. One is inborn errors of metabolism, second is neuromuscular disorders, and third is disorders of immune regulation. So long read sequencing has really gone a big way and at a reasonable cost and scale. So we are not discussing here which technology is better than the other, but these are actually kind of point of care tests where before they become symptomatic, you check them. You obviously have to decide on what to be delivered to the patient and what to be kept away from the patient, which is actionable, non-actionable, and the autonomy, privacy, and everything which comes with as and as technology evolves. Right? But this has to be told to general public in the language that they understand, without the stigma. So what we really need is to build up a good network of the industry and of people in the policy making who will support the course in genetic counseling, the courses for information in regional languages, the incentivization of the basic healthcare workers and the grassroots workers, which will communicate that this is not a stigma. And just tell that each and every individual is born with one or four deleterious, right? So it's just by chance that your spouse doesn't have any of them. Right? So a communication in a language that they understand. Communication to the masses and evolving technologies in the undergraduate, postgraduate, and now super specialty programs. So we fortunately are moving towards more and more institutions studying DM in medical genetics. So that will actually build up, I don't say hub and spoke, I prefer to use the word centers of excellence and centers of competence.
So ma'am, one comment here, the inclusion into the curriculum, that is for future healthcare professionals. What about the current one? How do we percolate this message to current one? Your thoughts as well as Dr. Swasti's thoughts on this.
So in the UG curriculum, I was involved in 2022, and at least 7 topics, common topics of genetics are now mandatory. They have to have a tutorial on newborn screening. They need to know all the movement and neuromuscular disorders, especially DMT, SMA, which they commonly see, and this is already included. And cases of these, every medical college does have 1 or 2 cases as long cases. So now most of the undergraduates and postgraduates are moving away from the label of cerebral palsy. For those who are medicos here, it's a very common label. That is like fever. Fever could be because of infection, because of inflammation, because of cancer. Similarly, they moved from a phenotype-based diagnosis to a genotype based. That has already occurred. We just now need to strengthen the next curriculum committee as an offshoot of this meeting. Please write to the PGMR board of National Medical Council to include rare diseases and genetics as at least 20% of that.
Ma'am, your thoughts?
So, thank you, ma'am. I think that was way beyond what I can say. I think for the current already practicing clinicians to be able to increase their acceptance and sense of understanding for genetics, we are all trying our best for many years to educate as many of the pediatricians, the obstetricians, even the general medicine, and any other specialty who would be interested in what are the advances, what all is now readily available. There has to be a little back and forth that we are willing to teach, but there has to be awareness from the other side who want to listen. And to increase that awareness, there has been a lot of government initiatives. There are centers of excellence that Matt was saying. They are opening up all over the country. The awareness is being put out there, but the acceptance still in the smaller cities and all is still a little bit poorer than it is in a city like Delhi. Here, people are much quicker and much more aware, and they catch and refer as and when. For the others, the tests are slowly becoming available. What they used to think is not there, and that knowledge is being put out. The newer generation will definitely help because they are learning this right from their educational level.
Yeah.
So the younger generation is, of course, a lot more aware of the current scenario. The slightly senior, the ones who have not been there to witness this happening in the larger cities, I think just attending the meetings, attending the webinars, being a part of all these group meetings like we are having now, where we bring so many stakeholders together to understand that this is now a part of the curriculum and this is a part of their daily diagnosis as well. They are also going to be seeing patients of genetic disorders. They can't ignore it anymore. They cannot just say that this is outside their domain and nothing can be done. They have to accept that it is there. They have to acknowledge it. They have to get it tested or refer whatever is possible. The COEs of the state play a large role in this. I think that they are available for the use and for the referrals, just that the people have to be ready to send.
Ma'am, one selfish question from my end, right? I mean, you mentioned about a lot of efforts done by, in terms of curriculum or in terms of clinicians teaching other clinicians, right? As industry, we tend to be only organizing these meetings and seminars and forums. What else can, as an industry, we do to generate a lot more awareness and education on rare disorders, genetic testing, and the various treatment options available and the sources of funds available? What more can we do as an industry?
I think the different societies that have the state chapters, rather than just the larger meetings, the state chapters that cater to the smaller cities, like in every state, like pediatrics has state chapters, which has a much better outreach as compared to them attending the national annual meeting, because not everybody from the smaller cities is going to come to the big meetings where everybody's talking about these things. So the smaller meetings or their local chapters are probably going to play a bigger part if we want this information to percolate down to the core. And we need to identify that who are the key, players who are willing to move their cities, move their chapters forward. There are a lot of visionaries out there who are really taking the time and the efforts to educate themselves, but probably they are not able to pass around that information. If we are able to reach them, and I think including the companies and the industries, if we are able to reach the smaller cities, their local meetings, their local chapters, it's going to be really good to educate the doctors at that level to start with. Once the awareness starts in the smaller cities, who will really pick up the diagnosis.
Sure. Dr. Kapoor, your thoughts on this particular aspect, and then maybe we can allow.
I think I'll actually, because I have another meeting. So, the ISIEM, which is Indian Society for Inborn Errors of Metabolism, and SIEMG, which is Society of Indian Medical Geneticists. You believe that last time we had an online course on alternate Saturdays last year, followed by a 3-day capsule offline course. I think we could accommodate 60, and to the best of my knowledge, there were 320 applications, right? So this time we are going to start again this month, and this will create a ripple and cascade. And similarly, this will go down to, because this is online, anybody can access it today, right?
Sure.
So I think this is going to reach the masses by, and if the state chapter, as Swasti has said, give some points of credit, like they do for conferences, for these online meetings, they will get an added advantage that apart from knowledge, they're also enhancing continuous medical education, which is required by the state. So you must actually contact the state chapters as well as the bigger bodies to mix and mingle to reach to the uniform platform, right?
Thanks, ma'am.
And
Thanks.
with this, I'm just sorry that I have to leave.
Yeah.
I have another presentation somewhere.
Sure. Sure.
And thank you for inviting
No, thanks
me.
for your thoughts, ma'am. It was lovely talking to you. We would love to hear more insights and thoughts from you, but maybe some other time. But again, thanks for your contribution and thanks for your
I have a
participation.
small request to make to all the people who are present. We are organizing the Asia Conference on Inherited Metabolic Diseases from 24th March to 27th March 2027. And we expect 250 to 300 international delegates. So the industry and all the fraternity may please help us make this not only a traditionally, ethically, but a scientifically very encouraging program. So just about that, small words. I did not have but I will share the conference brochure and maybe all of us can get together again. Thank you.
Thank you, ma'am. Please be seated.
I request our session chair, our moderator, Dr. Milan Choksi, to please present Dr. Seema Kapoor with a memento. We are very grateful to her for coming here and sharing the wealth of her knowledge with the audience. Please give her a round of applause. Thank you, ma'am. And I request Dr. Milan Choksi to resume the discussion.
Mr. Bhaskaran, another selfish question, but for you now this time. You being the diagnostic solution provider and us being the treatment solution provider, how can we collaborate along with clinicians, the healthcare ecosystem, as well as patient bodies to make all the treatments accessible?
So the kind of collaborations that we are doing, we are working with several hospitals and partners. So there are some cases where they want to, this is more like undiagnosed, or they are actually tried already some tests and they are stuck, they are not getting an actionable output. So then we work with them and then try to see whether any, the long range, the long read whole genome sequencing can help them. So we have already done that for a few cases. And some cases it has been particularly for huge structural variation in the case of AML gene fusions, which, you need to do it with both at the genome level as well as at the transcript level. So these are actually, we are finding the long read sequencing, particularly using especially the PacBio platform that we have. It has been very useful for us. So we, let us say in the case of precision medicine, in the case of treatment, whether if you want a pharmacogenomics input, so that also we have worked with some people. So we do that and then try to identify those markers. So we are already working with them, and to catch on to taking it to the next level, we also do CMEs. So CMEs we do on focused aspects of, let us say, either oncology or rare diseases or technology-based workshops to take it to the clinicians. So we regularly conduct those workshops as well. So it is usually done in big cities, so we could do it in the tier 2 and tier 3 cities as well. So I think the awareness, crossing the skepticism part on, at the end, actually, you all want to find the patient treated and happy and then healthy. So how to do that? So it's a lot of it is, it's not just sequencing. The expertise is in interpretation and presenting an actionable solution to the clinician. So that is where all the development is, and that is where the awareness has to be built. Because I think most of the clinicians we interact is what next. So sometimes even the knowledge is not enough. So our rare disease foray was with respect to inherited retinal diseases. I think some of them are even that also considered as rare. But in India, again, it is actually a very high proportion of occurrence. So majority of the times the question is what next? What do I do with this information and so on? So those things, that barrier we have to cross, because it is not just about knowing that person, there is a carrier a problem involved. The disease management, better disease management, early on you detect and so on. So all these exposure to the rare diseases and diagnosis and genetic testing came to us through this IRD work that we actually developed a panel ourselves, which has been patented now. So that is actually in collaboration with LV Prasad Eye Institute. So we work already with hospitals, we work with clinics and so on.
So Dr. Swasti, most of these genetic disorders tends to be multi-system disorders, right? And because of that, patient might end up with orthopedics or with GI because of hepatosplenomegaly or due to developmental disorders. So it has to have a multicentric and multi-specialty approach. Is it so easy to have that, or are there challenges, and any thoughts on that?
I think that's a really great point that you have brought up, because everybody thinks that it's linear, that you have a presentation to the clinician, you make the diagnosis, you get treatment, and it's straightforward. But in genetics, it's not. Because like you said, majority of the conditions are going to require a multidisciplinary approach. And it is not easy. It is not easily available, it is not easily accepted, and it is not easy to coordinate. So it is not easily available, that's the first problem, that we don't have specialists available in the smaller cities for so many conditions. That is something that obviously is going to take time to sort out, and the medical colleges, the tertiary clinics are going to have to be the hubs for those, where they can probably, the patients from a certain area will have to maybe find out, or maybe there can be a collection of patients who identify a center, and word spreads through parent groups and so on. In the larger cities, medical colleges, the tertiary hospitals and so on, now they have the required specialists. But here comes the problem that not everybody is trained to handle the genetic disorders. These are chronic conditions. They don't move the same way as an acute problem. So an orthopedician who is handling patients on a daily basis of acute conditions, of different disorders, needs to be made aware of what are the problems of a genetic disorder. It's not going to be a one-time visit, it's going to be a lifelong visit. So how are we going to approach these? I'm happy to say that, of course, things are improving, and now we have so many specialists across the country who are looking after our children with chronic diseases, thanks to treatment Many of them are now living beyond the known years. Many of them are surviving. Many of them are, in fact, coming up with new problems that we didn't know existed for these conditions because patients never survived or came to clinical attention. But the last and most important is to convince the patients that this is important. That's one of the biggest challenges because it is difficult to accept that there is no permanent cure, but all of these are required. There is survival, but there is also longevity, and then there is quality of life, which doesn't really get talked about in India very often because we are struggling with the basics. But for a family, these are really important. And if we're able to emphasize this from the beginning, that while the child with disorder may not have a cure, or the cure that you're giving is great to treat the primary condition, it's not going to look after all the aspects. It's very important to educate the family from the beginning that it is going to be required that from time to time you have to keep visiting, maybe not one but 5 doctors, and they have to be made to realize that it's something which is going to eventually benefit that child or that patient in the long term. It is challenging, but like all the other challenges in genetic disorders, those are being overcome. This is also going to be overcome.
Yes.
We've come a long way with diagnosis, we've come a long way with treatment, so this is the next step.
So, just closing this session on certain closing thoughts. First of all, thanks Dr. Swasti and Mr. Bhaskaran for your valuable inputs and insights and sharing your experiences. Collaboration is the key word here. Be it awareness, diagnosis, treatment, or continuum of care. Whatever we do, collaboration is a must. What I feel, I started working in rare disorders about from 2020 onwards. Already we have really progressed leaps and bounds. But are we there yet? The answer is no. But are we progressing? The answer is yes. And it is only because different stakeholders, be it patient groups, be it clinicians, be it industry, be it the government bodies, everybody is trying to collaborate, trying to work together, right? And I think we should keep doing it. We will reach at that stage where there is a treatment for each and every rare and genetic disorder, and every person who is suffering from this disorder can have an option or an opportunity of healthy life. Thank you. Thanks, Victor. I will just felicitate with you with memento.
I would request Senior Consultant from IHW Council, Uttaraji, to please come up on stage and present our speakers with mementos. We are grateful to them for coming here and sharing their knowledge with the audience. I request you to please present a memento to Dr. Swasti Pal, Associate Consultant, Gangaram Hospital. A memento for Mr. Ramachandran Bhaskaran, Chief Scientific Officer, Nucleome Informatics. And a memento for our moderator, Dr. Milan Choksi, Transplant Medical Lead, Sanofi. I request all of you to gather for a group photograph. Thank you to all our speakers. We'll now move on to the last session. This is the last session for the day, and it's supported by AstraZeneca. And in this final knowledge session, we'll talk about strengthening centers of excellence for AHAS and Fabry disease. including, and we will talk about the gaps in genetic diagnostics, delay in accurate clinical differentiation, viability in preparedness of centers of excellence, and financing constraints for treatment access. To discuss this topic, please welcome on stage our speakers for this session. Please welcome on stage Dr. Professor Arvind Bagga, Director Pediatrics and Senior Pediatric Nephrologist, Indraprasth Apollo Hospitals. Please welcome on stage Dr. Ashwin Dalal, Head Diagnostic Division, Center for DNA Fingerprinting and Diagnostics. So please give a round of applause and welcome Dr. Ashwin Dalal on stage. Okay, Dr. Ashwin Dalal is actually joining us virtually. We also have Dr. Priyanshu Mathur joining us virtually. He is Associate Professor of Pediatric Medicine, J.K. Lone Hospital, SMS Medical College. Please welcome on stage Mr. Saurabh Singh, Co-founder and Director, Rare Disease India Foundation. Please give him a round of applause and welcome him on stage. And please welcome Mr. Arjun Gupta, Founder and CEO, Genetico Research and Diagnostics. And our moderator for this session, Ms. Oshin Santoshi, Patient Advocacy Manager, AstraZeneca. I request our moderator, Ms. Santoshi, to please take this discussion forward.
Do we have Dr. Priyanshu and Dr. Ashwin Dalal virtually joining in? Oh yeah, great. Dr. Dalal, any idea? Okay, can you take this? Okay, great. So yeah, good afternoon, everyone. Last session for the day, but a very important one. We'll be talking about strengthening the centers of excellences with a focus on AHUS and Fabry disease. I think over the day, we've heard a lot from different, panelists, different speakers, and we know that there are, 15 centers of excellences in the country who are doing, a great work when it comes to whether it's awareness, whether it's diagnostics, the treatment aspect. So there's a very strong infrastructure in place. But again, when it comes to further strengthening them, there's a lot that can be done, and it requires a lot of partnerships, a lot of ecosystem strengthening. So really, honored to be able to kind of moderate the panelists today with a lot of, esteemed speakers in the room. So I'll start by, I'll probably have two sections in this, discussion. The first one would be more to kind of touch upon what are the challenges that exist. And then the second part would be how do we kind of work on it, any recommendations from the panelists here, how do we strengthen the whole ecosystem, right? So I'll start with Dr. Bagga. So, being an expert when it comes to, pediatric nephrologists, and you're dealing with a lot of different rare kidney disease patients, right? So what are some of the key complexities that, physicians face when it comes to diagnosing diseases like AHUS? So anything that you can share on that?
Thank you so much for this opportunity to be here today. I think when we're talking about rare diseases like AHUS, Fabry's, and other rare kidney diseases, it's very often, the concerns that we often encounter are, number one, lack of recognition of the condition in time. So many of these diseases may have been there for a while before they're really diagnosed. For some conditions like AHUS, it may really mean a lot, because if you diagnose them late and there is kidney failure that's kind of permanent, then it's something that's not going to be recoverable. For something like Fabry's, its diagnosis is even more difficult because it cannot be picked up. And one would often pick up Fabry if one does genetics or one does a kidney biopsy or something. Because the symptoms could be much more subtle in the form of chronic kidney disease, some neurological features, and so on. Talking about AHUS first, I think the recognition over the years has improved. But even today, we would have kids across the country who would present with the anemia, with acute kidney injury, where the condition is not thought of. So I think that we do need to reach out to physicians pediatricians, adult nephrologists, and so on, that the condition is suspected. And the current terminology for HUS is now evolving towards more of TMA-based classification, so thrombotic microangiopathy. And in our country, obviously AHUS is far more commoner than the infection-associated HUS. We don't have so much shigellosis, so we don't really have a lot of infection-associated. So AHUS is an important clinical problem. It's the commonest cause of kidney failure resulting in dialysis in children, acute kidney failure causing dialysis in children. Fabry's, we don't see too often, but I think there's an underdiagnosis of Fabry's, chiefly because it's missed, nobody thinks about it, genetics is often not done, and so on.
Yeah, no, thank you for highlighting the challenges, associated with these conditions. And, if we move on to the diagnostics bit, right, accurate and timely diagnostics is very important. So, Dr. Dalal, I think if you can share a bit more on how is genetic testing being done for these conditions in India, and what are some of the gaps that you're seeing when it comes to the whole, genetic infrastructure that exists in the country, or, even from a diagnostics point of view. Yeah.
Yeah, so as Dr. Bagga told, both these conditions, unless you suspect and investigate them, you will not be able to diagnose them. So, especially Fabry disease has very few patients will have symptoms of neuropathy when they may get diagnosed. Otherwise, most of them get diagnosed only when they have end-stage renal failure or some cerebrovascular accident. So, it is difficult, but once it is suspected, we usually do an enzyme assay for Fabry disease, or if an exome is done, then you may detect it. And similarly for AHUS also, in addition to multiple genes being involved, problem is that there are some patients where we don't find a mutation, but they are still HUS. And so these atypical HUS is actually one of the disorders for which in the National Rare Disease Policy, we are going ahead with therapy in absence of mutation. Otherwise, for all other diseases, we go ahead with treatment only with a mutation present. But AHUS is the only disease for which we are giving therapy even in absence of a mutation if it satisfies the other criteria. So there are challenges, and many of these need either a exome sequencing kind of a thing to detect. As more and more labs start doing it, and now the Ministry of Health is also supporting the Center of Excellence for doing many of these tests. So now the time is that the clinicians have to suspect and pick these patients and refer to relevant centers so that you get timely diagnosis.
Thank you, Dr. Dalal. I think you picked up a point about, how for AHUS, we're trying to kind of deal with it in a way that, genetic testing is not the only factor. So anything that you can share in terms of, one of the topics here is COE preparedness. So how can we kind of bring it to the other COEs as well? And, what is it that can be done to kind of have this unified approach to it as well? Any, thoughts on that would also be helpful.
AHUS has been included by Ministry of Health in the 63 disease list wherein therapy is given. And in our centers itself, about 4 patients are already receiving. The problem is of the 50 lakh cap that is there. So if they exhaust this 50 lakh rupees in one cycle of therapy, they would not be eligible to receive treatment in the second cycle. So that is the challenge, which at present we don't have any solution. But at least since it is included, so one cycle of therapy for the extra weight people should be manageable in this 50 lakh rupees that is available. But beyond that, we really can't do much.
No, thank you, Dr. Dalal. And I think sort of, you're working as a patient organization, and Dr. Dalal did bring up the whole, funding bit as well. So, as a patient organization, what sort of challenges are you hearing from the patients, whether it's, AHUS or Fabry disease? So if you could share a bit more on, how are you, what sort of challenges do you hear from them on a regular basis? I think that will be another thing to bring in. Yeah.
Yeah, thank you organizers for
calling me for this important program here. This is the second time when I am participating in IHW Council's program, because the first time when I participated, my son was admitted on the ventilator, and when I returned back, he had a cardiac arrest and he passed away due to one of the rare diseases, Hunter syndrome. And this is the second time when I am participating here. So whatever I will tell today is a lived experience. I am also a parent of a child. He is no more now, and I lost him 6 months back. What happens in remote area? Still date, my son was diagnosed in the year 2000, it was 2014 in CMC Vellore. Because in remote areas still, what happens, the doctors misdiagnose. They do only the symptomatic treatment. Means the first hospital where the patient goes, the doctor confused with some other diseases and do the symptomatic treatment. And after one visit to another, one doctor to another, one hospital to another, one city to another city, in this process, there's lots of time is wasted and the disease progresses in the meantime. And when the doctor will tell that you go for this genetic test, the test cost itself is very huge, which a normal family cannot afford. Yesterday night, one of the patients called me that, sir, I am a farmer and my son was advised for a test and it costs 18,000 rupees. I can't afford it. So how many people can afford? So this is the one challenge. Another, once it is diagnosed, the cost of the treatment is huge. So for getting the diagnosis, a patient has to go from one city to another, because we don't have center of excellence everywhere in all the states. All the hospitals are not very well equipped to diagnose the disease. So the center of excellence is very limited, and there the child can be diagnosed that he is suffering from this disease, and the cost is this much. And the cost comes in crores of rupees no family can afford, which we all know. For that, we need a national policy. I'm telling about my story, from an ordinary person working in a multinational company, became a full-time advocate in High Court, and I lost my son 6 months back fighting for national rare disease policy. Till date, the policy is not foolproof. This policy is categorized in 3 parts. Part 1, Group A, Group B, and Group C. Group A and B can be treated, but if you talk about Group 3, in which there are diseases comes like AHUS, Fabry, Hunter syndrome, DMD, SMA, so many diseases are already there, but we don't get any funding support, no treatment available, whereas most of the diseases already there in the National Rare Disease Policy. So what happens, in last 10 years, we have not reached to the solution. When a child takes birth, in 10 years, the child learned everything. They walk properly, they can talk properly, they can discuss anything, they can be the first in their class. But our government did not understand what is the need of the time. So I'm telling you, because from my heart, because I feel it very personally, I have lost many things in my life. I spoiled my career after doing education from the multinational companies, education from the best institution of India, and still doing advocacy, became a lawyer. Anyway, now still the case is pending before the Supreme Court on 17th of March, this month only, for the final decision. So what we need, there are many diseases which needs to be included in National Rare Disease Policy. What we are facing in the Center of Excellence, the challenges which the government has already made the policy, is there should be a crowdfunding portal, because the population of the country is huge, and alone government cannot give treatment to all the patients. So I can agree, we all agree. The population is huge, government cannot give treatment to all the patients. But the system should be proper. The national crowdfunding portal has, from last 5 years, it is only generated 4 lakh something rupees in 5 years. It means there is some intent issue, because it needs to be framed properly, because we cannot think that government has is not aware, because in each and every court cases, it is notified to the government that this case is filed for National Rare Disease Policy. When Dr. Bonde, who was the honorable, member of Parliament, he has already raised a question in the Parliament for inclusion NF1 in the National Rare Disease Policy. Definitely this question will go to the Prime Minister of India, also all the decision maker and the policy maker. So now I'm talking about the COE, challenges in COEs. So people think that the numbers are very less, but I don't believe that. The numbers are huge because we are not able to diagnose it. Even in remote areas, till date, doctors are not aware what these diseases are. If we'll go to the district level hospital, the doctor call other colleagues that come, I have find out one rare disease patient, we have read in the book, but it is the first time when they have seen a patient like that. So it means they have not seen it, they have not treated it. That is why the misdiagnosis it happens every time. So awareness is very much important in remote areas as well, because the multinational, metropolitan cities, awareness is already at least at par, but not in the remote areas. Again, I'm telling you about the registration of these patients in National Rare Disease portal, because the registration in COEs is not being properly done, because patients are still fighting to get registered so that the government can know how many patients are there in India, what is the actual financial burden is there in the country. So the patient registry is also a part of the COE, and the ICMR is also doing the same thing. But I believe the patient advocacy group has the lots of data. If the government wants to get it, they will definitely, all the patient group will help them, because once the patient is diagnosed with a rare disease, they do some search in the Google and they find out the patient advocacy group's contact details, and they share their feelings very frequently whenever they feel required.
Yeah, so Saurabh, I think you touched upon the sustainability bit, when it comes to crowdfunding. And then you've also talked about the awareness that needs to be done in remote areas. And then the whole delay in, I believe, the NPRD, enrollment, etc. So I think these are very, big challenges that you've highlighted. Anything else you'd like to highlight on that front?
No, these are a very important thing. I also highlighted that there are few more diseases which need to be included in National Rare Disease Policy, because there are so many rare diseases in the country as well.
Sure. No, I think the fact that you brought up the whole awareness bit in remote settings and how, that needs to be done. So I think, Dr. Priyanshu Mathur, from your end, I think, being in the pediatric setting, I think you are the first point of contact when it comes to, rare disease patients. So really, if you could share a bit more in terms of the strategies that can be adopted to improve the early, suspicion that is happening, and really strengthen the referral pathways to COEs. I think it'll be great if you can share on that, and anything that from a Rajasthan point of view, any resources that are available which can really strengthen the COE aspect here. Yeah.
Thank you very much, Oshin. So first of all, I would like to tell you that currently I'm a professor in Department of Medical Genetics at SMS Medical College, Jaipur.
Dr. Mathur,
So
we cannot hear you. Just give us 1 minute. We'll just...
Yeah. Hello? Hello?
Yeah, please, Dr.
Okay, okay. Hello.
Yeah.
I hope now my voice is audible now.
Yes, yes, it's fine.
Okay, so thank you, Oshin, for the question. So first of all, I would like to tell you about that currently I'm working as professor in Department of Medical Genetics at SMS Medical College, Jaipur, and the department was started in April 2025. So before that, we were running rare disease clinic since 2014 at Jekyll Hospital under Department of Pediatric Medicine. So the most important point is the first point of contact is basically for majority of rare disease is primary care physicians, general pediatrician or internal medicine people. So because diseases like atypical HUS and Fabry disease often mimic with more common clinical problems or more common diseases, so the strategy should be shift from a looking for a common disease to better to suspect for a possibility of rare disease if we are seeing something unusual in patients. So I would like to tell you about that we should have more focus on suspecting rare diseases whenever the clinical condition is having something unusual. Okay, that can be done by uh, training them or making them aware with the red flags. So red flags are very important whenever a clinician is seeing a patient with microangiopathic hemolytic anemia, thrombocytopenia, acute kidney injury, and especially triggered with the common infection. They should have a high index of suspicion for possibility of atypical hemolytic uremic syndrome, and they should evaluate these patients for the possibility of AHUS. Similarly, for Fabry disease, whenever they are finding a patient with unexplained left ventricular hypertrophy, early onset stroke, or chronic burning pain in hands and feet, that is also known as acroparesthesia, they should think for a possibility of Fabry disease. Second important point is we can implement digital decision support. I think Arjun will tell more about it. So that can also help in identifying the red flags, and that can trigger the further evaluation for possibility of some underlying rare genetic disorders, especially those disorders which are now treatable. Third point is we should streamline the referral pathway. That is very, very important. In Rajasthan, what we did, so I am a state nodal officer for rare disease for state of Rajasthan. We are having 24 medical colleges across the Rajasthan. So we have identified 24, total 23 more nodal officer across these all medical colleges. So we are having 24 nodal officers in 24 medical colleges. So they are the point of contact. So whenever any peripheral center want to refer a patient, they can refer to the nearest medical college. Okay, the nodal officer of rare disease at that medical college, they can evaluate and if needed, they can refer it to us, so that we can cater large number of patients. Otherwise, single one or two center across the state is not able to cater all the load of these patients. So that we are doing. Again, Rajasthan is again working for the treatment part also. So government of Rajasthan, they started Mukhyamantri Ayushman Bal Sambal Yojana. In that Yojana, government has two components. They started with two components. One is for treatment support. Second is monthly financial assistance. So that monthly financial assistance is basically is a small amount. It's not a huge amount. It's 5,000 rupees per patient. That is helping them in meeting expenses, other expenses like physiotherapy cost, occupational therapy or other therapies, and transportation cost for these patients.
Yeah, no, that's good to know, and it'll be, I mean, as we kind of go forward with the discussion, it'll be good to hear from you how, states and, the COEs can work together better, so definitely. But yeah, we do have a technology entrepreneur in the room as well, so would love to hear from you in terms of, what are some of the innovations that exist, and how are you working with the different centers of excellences as well? Yeah.
Thanks for the question, and thanks to the organizers for having me here. So I feel that technology is a fairly underutilized aspect in the entire rare disease ecosystem. Today, the best technology that we use, I mean, in genetic testing, we've made a lot of progress. In diagnostics, of course, specific tests, we've made progress. But digitalization is really missing from this entire piece. And these centers of excellence or rare diseases in general, they have a very, very unique protocol for diagnosis. And if you look at centers of excellence, they are actually, the clinicians have so much burden even of the administrative processes. So you look at them that, a patient comes in, they have to, of course, consult the patient, fill the OPD cards. Then there's a national, registry, which is far more elaborate, where they have to put in the data. Then the ministry also requests periodic reporting from them. That's another data. When they have suspected a condition, they have to diagnose again TRFs, the same data gets put into paper again. Now the patient is diagnosed and then they have to secure funding for that patient, and then the treatment starts, and then there is an entire whole process and protocol. So there is so much redundancy for all these clinicians. So what we have been doing for the past 7 years is building an AI-powered clinical genetics platform tailor-made for centers of excellence, which eliminates this redundancy, also eases in the data entry part for them, because that is also a big challenge. How much time they give to each patient, and do they sit and do this on the computer? So we have deployed our systems at AIMSTELI. CDFD is in the process of deployment. So for the national mission project, where the 18 centers will use the software. So how we are working with them is making their lives easier in getting this data in a digital form. And then Dr. Priyanshu Mathur mentioned that, the clinical decision support. Now, there are all these young residents who are also seeing the patients. So the eye does not see what the mind does not know, right? I learned from another clinician, this was a fantastic line I felt. So this is what we try to bridge. We train our models that the moment some of these symptoms are captured, we give them a differential diagnosis. And that differential diagnosis is not a black box output that, okay, this is what it is. It actually gives you reasoning why a certain differential is presented. And then it also allows you to compare between overlapping conditions, which is again a very big challenge in rare diseases. So that entire interface can actually help them in do better diagnosis. And then even after the diagnosis have been achieved, even if they are on treatment, then this is not an episodic, situation. It's a long-term follow-up is needed. So when the patient comes with long-term follow-ups, again they bring routine, investigations which may have 10, 20 parameters. And being in India, everything right now is on paper. So what do you do with that? Again, you go, if you're on paper, you will go back to the old 20 files and see what summary you've made, and then you will look at that in the context. What we have done to solve that even an attendant outside can start clicking pictures of all these reports. And our AI OCR will extract the data. AI will understand what diagnostic report it is, what routine report is it, and it will put that data in a table for the clinician ready to view. So this actually automates so much of the part. This is not the sexy part of the AI where we are predicting things, which is also there in the system. But this is actually making a lot of difference. That now suddenly you have a system for all patients where all this long-term longitudinal data with decision support, family history, pedigrees you can draw, and it is there and it can be edited over a period of time. So this is how we are helping with them. And I think a very big piece is now reporting to the ministry. So right now, if they have to calculate that how many of these particular kind of patients we have seen, they will sit and tally that. Many creative centers of excellence have come with a codification system to spend less time on it, but it is still very cumbersome, error prone. But once you have followed this, you can just extract a report in whichever format. We've made them elaborate, analytical dashboards which can give you that insight. So that is how we are working with this.
That's great to know, and I think efficiency and reducing these delays is something that technology will play a big role. And I'll get back into the whole solutioning bit. What can be done, right? So Dr. Bagga, I know we kind of talked about how with conditions like AHUS, it can be acute. sometimes, the rare diseases are kind of called chronic, but, this is a condition which can be very acute and it requires urgent intervention. And sometimes, genetic tests may be ordered, but it'll take time to kind of get the results, and it kind of leads to, delayed treatment. So any, suggestions as to how centers of excellence can really, work on this, and what sort of solutions would you propose? I think that would be good to know.
I think it's a very valid question, and of the many rare diseases we talk about, HUS is an acute illness. It hits you suddenly. You got a child who's totally normal, gets sick. And the current standard of care is that if you get HUS or atypical HUS, therapy must be initiated within 7 days, maybe even earlier, 3 days. So clearly you can't go to a committee with this in this 3-day window. So that when we kind of try to find solutions, there has to be some kind of a buffer stock available to hospitals. These could even be hospitals that are centers of excellence, wherein, these patients could be referred so that they get prompt treatment. And when I'm saying prompt, I really mean prompt, Delaying therapy beyond 7 days can cause irreparable injury to the kidneys and so on. That's one. The second point, which again you alluded to, is the need for a genetic diagnosis. Now, as was said by one of my earlier colleagues here, almost 40%, and in our country about 50% of the times, you may not find a genetic cause. So relying that you would have to have a genetic cause before a patient does fall within the ambit of the rare disease is again not fair. Again, these patients need to we need to kind of, modify our policies in such a way, and clearly, even for the non-genetic, or where you can't find a genetic cause, these patients do respond to complement inhibitors. Previously, we were relying chiefly on plasma exchanges, but the outcomes on plasma exchanges versus complement inhibitors are clearly different, and we've got lots of experience with both the kind of agents. So clearly, while genetics is important, it may not be positive in about 50%. The third important, so you really can't, say just to genetics, we would be giving the medication. The third thing that's important again in the domain of AHUS is that AHUS can be caused by a number of genetic disorders. And fortunately, in almost half of them, you can stop therapy by 6 months. There would be a risk of relapse, but it's been shown that if they relapse, you can clearly, restart therapy again within a period of a week or 10 days, and the kidney outcomes stay well. But in a very significant majority, I would not say large majority, but almost 50-60% patients can go off therapy. So it's not like, say, some of the other, more tougher chronic diseases like Fabry's, or maybe what Sir was mentioning regarding Hunter's, where you require therapy for lifelong. Here the therapy may at times be acute. So we will have to be cognizant of all these realities, while making policies. Patients who have HUS, where you find a variant of uncertain significance on genetics, can go off therapy. There's a very low risk of relapse. So clearly, these things have to be built in. I'm sure they will be gradually built into our system as we go along.
Yeah.
For a condition like Fabry, obviously you need to continue therapy, whether it's enzyme therapy or whether it's one of the other novel drugs. They have to be given lifelong because it's a chronic kidney disease. But I think the equity is really the major thing that sets apart AHUS from other chronic diseases.
Yeah. Oh, definitely. Thank you for sharing, Dr. Bagga. Dr. Dalal, would you like to add anything to what Dr. Bagga just shared? Yeah.
Yeah. So I agree with what Dr. Bagga said. But what I said before also, that if there is a relapse or something, or if there is a relapse after maybe 1 month or 1 year, whatever, problem is this amount of 50 lakhs. So one course we are able to treat within this 50 lakh. But for a second course, there may be an issue. So from therapy point, that is the problem. However, keeping in mind the problem of finding a VUS or a no mutation, AHUS has been included as a disease where you can treat without mutation. So that is a very important thing, because for many other diseases, like even hereditary angioedema, we have patients who don't have mutation and we are not able to treat them as of now. But AHUS, that advantage is there. But then again, we will be able to give only one course within the budget available. For Fabry disease, because the cost is too high and 50 lakh will not be even for even 1 year or little more of therapy, Fabry is not yet undertaken in the rare disease policy for treatment. But diagnosis for these disorders surely can be done through the COEs under the rare disease policy.
No, thank you, Dr. Dalal. Points that were highlighted, whether it's having like some sort of an emergency pool or kind of looking at the sustainability bit when it comes to Fabry or AHUS disease. So any points, from your end, keeping the state in mind as well, how can we, think about such mechanisms? That would be great. Yeah.
Yeah, yes. Yes, so for state government, I will give example of Rajasthan state government. So Rajasthan state government is having a very good healthcare schemes. So government is, apart from Ayushman Bal Sambal Yojana, government is having one other scheme that is Mukhyamantri Ayushman Arogya Yojana. So in that is known as a Yojana, Mukhyamantri Ayushman Arogya Yojana. Under that scheme, what the state government has done, they had insured each and every person of the state. Okay, so those who are affordable, they are paying their premium, and those who are not affordable, those who are below poverty line, so for them, government is paying the yearly premium. So all the 13 crore families, all the 8.5 crore population of Rajasthan is covered under that particular scheme. Okay, and they had capped that scheme at 25 lakh rupees per year. Okay, and the corpus fund which was generated, so government had given to a private insurance company to manage the scheme. Okay, so private insurance companies managing the scheme, and they got a huge funds, and they can cover up to 25 lakh rupees per person per year under that scheme. So that is a very good scheme. So we have suggested to include rare diseases, rare genetic diseases, and cancers also under that scheme. So, and they can increase the premium if needed to 100 or 200 rupees per person or per family. So that can be a sustainable solution for long term, because in that case we need not to look for budget again and again. Okay. And for few diseases, when the cost of therapy is more than 25 lakh rupees, we suggested that by the expert group recommendation or a panel of doctor recommendation, they can increase the capping for these patients up to 50 or 80 lakhs. Okay, so this is the only solution which can help rare disease patients in long term, because it will be annual budget, the annual amount the family will get or patient will get, and that's the only solution which can help us in long term.
No, thank you for sharing. And hearing from everyone, I think about the funding solutions that exist, the complexity bit of it, the genetic testing, all of those discussions. I'm sure, sort of with you would have been getting these queries from patients, right, from across different diseases, right? So how are you kind of helping these patients as a patient advocacy group, when it comes to the whole urgency to get treated or the sustainability bit? So anything that you'd like to share, spotlighting these two diseases? Yeah.
Yes. It's very good news from Rajasthan, what Dr. Priyanshu Mathur has told. Rajasthan is already having lots of patient load of rare diseases, and the schemes which Rajasthan government is floating for these diseases are exceptionally well. Additionally, 50 lakhs rupees support from, I have heard, it's there. I'm right, Dr. Priyanshu?
Yes, so under one scheme, that is Mukhyamantri Ayushman Bal Sambal Yojana,
yes,
each and every patient who is suffering from rare genetic disease and less than 18 years of age are getting treatment up to 50 lakh rupees per patient.
Yes, so it's very good plan of Rajasthan government, and additionally 5,000 caregiver support is also launched by Rajasthan government. It is already distribution of the funds is already started. So this is very good scheme, And in this particular situation, because if the patient is having lots of issues, they are not getting covered under any insurance company does not cover rare diseases. So in the meantime, they can utilize these funds. Other funds are also available if they need, the patient needs, like the Prime Minister Relief Fund is there, the Chief Minister Relief Fund is there, the President Relief Fund is there. So these small funds can be raised can be asked from them. And for emergency situation, these funds can be utilized. Additionally, the Ayushman Bharat Yojana is 5 lakhs rupees is given for the BPL patients. It is not extended to the APL patient even in the rare diseases. So we are advocating ministries to include all the APL patients of rare diseases in Ayushman Bharat, because in the emergency case, patient has to get admitted in any nearest hospital, and there they don't have any insurance coverage. The poor patient cannot afford. A poor patient can get it, but the APL patient cannot get any funding system. So these are the things which a patient must understand, which I every time in the advocacy events I educate the patients. Other thing, we are collaborating with the multiple stakeholders, including the ministry, including the doctors, COEs, and the pharma companies and the industries as well, to strengthening this community, how to give support, because so many other companies are giving started charitable access program for the patients, and it has been seen that the outcome is very good. If I talk about the Gaucher disease, the charitable program is also there, started long back. Even in Hunter syndrome, the charitable access program is there. So by collaborating with these pharma companies, we are trying to push the patients to get facilitated due to this. And other thing, the clinical trials are going on. So recently the Niemann-Pick disease clinical trial was there. So there are lots of patients was enrolled. Even Dr. Priyanshu has enrolled so many patients. I have also given. And also, we have a lots of data, patient data, which government does not have. The patient advocacy group has a data. Government should realize that we can be the part of that patient registry mechanism, because we can assist the ICMR to get this registry completed, because there are so many other patient advocacy groups. They are already doing good job in their areas. The government should collaborate with these patient advocacy groups for getting the exact registry data.
That's why I think the collaborations with COEs.
Collaboration with COE is also important, because, you know, I'm telling you, 2 days back, one patient called me that the person is respiratory failure and he needs ventilator support. There is no ventilator. There is no support from the RIMS Hospital, Ranchi. I called the HOD, but there was no support. I called the superintendent, then I rushed to the hospital, because that day I was there, and I met with the director also, and the patient was supported. Because the support system by the PAG group has to be like that. Means end-to-end solution should be there. Every time we cannot reach the hospital, but the collaboration can work like this.
Yeah. No, thank you. Arjun, I think, to kind of talk about the partnership bit again, with COEs, whether it's the diagnostic companies, research institutions, how can you kind of, as a, technology entrepreneur, how can you really play a role in expanding the whole access? How can it be more faster? I know you already talked about it, but any kind of takeaways, any examples?
Sure. I'll speak about something that I didn't speak about earlier. One is, when you're dealing with centers of excellence, which has a certain level of capability, but the other panelist spoke about how, the signs are missed, it's not picked up, and also the referral pathways. So today, the state of affair is that anybody who's trying to build these referral pathways rely on training other people, which of course is needed. But there is the digital aspect of it can really play a massive role. So what we are doing in towards that end, so there are various level of complex goals that we have picked up. So one which we are already pursuing is that if we integrate our algorithms with a larger hospital information management system, where for a patient there is an initial chief complaint, a set of issues that a pediatrician might have seen, along with the investigation data of various tests that might have happened within the same hospital. So can we flag these conditions? So that's one aspect where we are seeing that how can we digitally triage these patients which have not gotten referrals, but can we really send this patient to the right clinician, or even just show the case to the clinician that is this something that requires a referral. So I think there is a phenomenal opportunity there because a lot of time these very key data points are missed, which are a 20-page investigation report and the correlations and who sees it at the time and so on. So that is one area where we are actively trying to collaborate with the COE. The other aspect is there are many primary level programs that government is running. RBSK is one such program, Rashtra Bal Swasthya Karyakram. In that program, they are capturing, at the primary level, they are capturing a lot of data at the grassroots level, which is already happening. So we are even trying to collaborate with the NHM folks that, you don't add any additional data point and we can support you within the same data framework to flag cases from that point, connect that with the district hospital, and then see how district and tertiary care can, work together, where telemedicine can help. The patient may not necessarily have to travel between the cities. So it's we are trying to do that one step at a time. But I think that's the long-term solution for it, that you triage them early, identify them early, get them to the nearest district hospital, get support for conditions that can be managed in collaboration with the COEs, and the more complex conditions can then be, physically be evaluated at COEs. And a very important point, last point, is that of prevention. How do we prevent this, right? These are preventable conditions in the sense that, of course, early identification is one aspect, but using such tools, the softwares, my pitch to the government is that with a click of a button, you can see the pan-India scope of, what all prenatal cases are at risk and can be offered genetic counseling, and if opted for, then prenatal diagnostics. So I think that will have a massive impact. So this is what the technology can really enable. And a lot of stakeholders have to come into the play. The ministry has to come into the play. The clinicians have to come to board because it's intense. Getting a software into a clinic is a very, very intense process. They already have a system that works. So shifting from that is something. So it is an effort for everybody, but I think it's a step forward. The last 1 year has been quite progressive for us. We've been doing this for 7 years. But we are quite encouraged by what we have achieved in the last 1 year. So hopefully it will go, better from here.
Thank you. I think very relevant and interesting points when it comes to strengthening the rare disease ecosystem. And I think when we're concluding, I think I'd like to kind of, if each one of you can just speak about, one area that you feel that you could recommend to the centers of excellence that could really further strengthen, and they can truly, function with the right stakeholders and really be more, I would say, effective or, efficient in their ways of working. Yeah.
So again, given the acute nature of the disease, I think we have already discussed that, so I will not repeat that again. But this has to be emphasized, and I think the Centers of Excellence, in association with the industry, will have to find some mechanisms to deal with the equity and the need for prompt therapy. The other concern, that physicians often have seen is that because the drugs are initiated, and then it's so expensive, that this has been discussed by all of us here, patients stop therapy early. Or they would increase the frequency between doses. Now again, physicians have to be counseled through the COEs or individually or through whatever systems we can find, so the therapies are not stopped early. The third problem with complement inhibitors in particular is the risk of infections. There's almost a 600 times increase of severe infections, particularly bacterial infections, when we are using complement inhibitors. And there are drugs available now in the country. There are going to be drugs available in the future as well. So again, this has to be this has to be underlined, and patients have to be on long-term antimicrobial prophylaxis, the vaccinations. So ensuring prompt therapy, ensuring consistency in therapy under antibiotic prophylaxis is things, that as clinicians we are concerned, we'll be looking out for.
Can I add? Hello.
यहाँ का नहीं चल रहा है पोडियम माइक पोडियम माइक पोडियम माइक क्या है
Yeah, Dr. Priyanshu, can you hear us?
Yes, yes.
Yeah.
So I want to add something. So the most important thing which I feel is required the strengthening of manpower at center of excellences, because the majority of center of excellences is having, they are really having very less manpower, and that is much needed, because we are not still center of excellence as per NPRD 2021, but we are nodal center for rare disease by government of Rajasthan. We are a state nodal center for rare diseases. We are feeling that we are having very less manpower, and that is really compromising patient care. So we need to have a more manpower. And second important thing which is required is standardized resource directories. So for example, like if any patient want to contact our center, so all of them directly calls to me, and that lead to lot of wastage of time. Okay, so only for appointment system, or only for just for small information, they are directly contacting us. So if we can have standardized resource directories, so that can really help, so that we can save the quality time, and we can do better.
No, very important points. I think the whole idea of having that, centralized repository, I think that's really great. And the manpower aspect as well, I think it would be applicable to a lot of different, COEs, different states as well. So, Dr. Dalal, if you'd also want to add in, any
They
recommendation.
asked me to verify I did everything. Nothing specific. The same problem is faced by multiple different centers. Mainly, even the existing centers of excellence, the same thing, that there is no manpower. So we have to do it ourselves, many of these things. And you can imagine we have almost 400 patients registered, and every day 2-3 patients come, and then they have different types of treatments, and we need to keep a record of that. So it becomes difficult as patients go on increasing. So some long-term solution we hope the ministry will find for future centers of excellence to keep them going as the number of patients increase. And the funding will always remain an issue, but we'll have to also focus on diagnosis and prevention rather than only on therapy. And there has been a great impetus from Government of India towards developing the drugs in India itself, or manufacturing them in India. That also maybe will add to having low-cost drugs, so that this 50 lakh is used in a judicious manner. Many things need to be done, but we have to see in our present situation what can be undertaken.
And I think that's where Mr. Saurabh and Mr. Arjun would be the right people to kind of, share more in terms of, what is that one action point from your end.
Yes. Yes, I am completely agree with Dr. Priyanshu and Dr. Ashwin Dalal sir. The Center of Excellence is already overloaded with their routine work, and there are lots of other work they have to do. So if there will less manpower, they cannot perform their duty on time, they cannot deliver their outcomes. So the manpower requirement is very much essential that ministry must understand. And I'm telling you, on behalf of all the PHs, patient advocacy groups, we are ready to collaborate with Center of Excellence, with the ministry, with the ICMR as a support partner. If you need us, we will always be there, and we can assist you every time, because we also have so many data and we can assist you as a support partner. Thank you.
Yeah, so I think a lot of points covered, almost everything. One pipe dream that I have, and I think it might not just be mine, is what can be unleashed with data which is of high quality collected across centers of excellence and all the laboratories and so on, is that India is a powerhouse of small molecule pharma, right? We struggle a little bit in biologics, not at par in US and all, but when it comes to small molecule, we are quite powerful. I feel there are opportunities that should be looked at with drug repurposing. And also, so pharma through, I think, PIP grants have come there where they are, where rare disease is an action area, and they have come up with 700 plus crore rupee fund to see how that kind of can be channelized. But I think for rare diseases to have the pharma companies join the party is, number one, we need to know what patient load is there. So that also is a data problem, that what are the lucrative areas for them, not just lucrative, operationally feasible because of the clinical trials and so on. What opportunities are there that they can go and then get an approval in the US, and then to do the biomarker discovery, all this clinical data, biobanking, and the existing data that exists, there are ways to use artificial intelligence, supplement with animal data. There's a lot of animal data research that has happened that correlates a lot with what we have discovered, and along with the routine investigations. So I think if this data is brought together systematically, there are opportunities that can be unlocked for the Indian pharmaceutical industry, which is the only way for the ministry to offset the costs that we are looking at for importing therapies by exporting good quality therapies, which are areas of unmet medical need. So I think that is one point that I feel requires strong consideration by the government. And we need to start building this. It might take 5 to 10 years, but at some point we can get it.
Yeah. No, I think thank you to all the panelists for really, sharing all the valuable insights. I think Dr. Bagga, you really kind of highlighted the nuances that often, we miss. The uniqueness of every rare disease kind of needs to be addressed and how it is tackled. So really, thank you for highlighting it. And Dr. Dalal, again, your inputs on the whole genetic testing bit, the diagnostic infrastructure was really, enlightening for everyone. And Dr. Priyanshu Mathur, I think bringing in the Rajasthan perspective, and I think that there's a lot to take when it comes to different centers of excellence is working. And the whole, being the frontline physician, being the pediatrician, a lot of education needs to be done, the whole triaging bit that was highlighted. And of course, Mr. Saurabh, the role of patient organizations is very important, to empower the patients. And again, the technology cannot be left behind. It needs to go hand in hand. So thank you, everyone, for this very, interactive panel discussion. Yeah, thank you.
Thank you for that discussion. I would request Mr. Kamal Narayan Omar, founder and CEO, IHW Council, to please come up on stage and present our speakers with mementos. We want to thank them for coming here and for sharing their knowledge with the audience. I request you to present a memento to Professor Dr. Arvind Bagga, Director Pediatric, Senior Pediatric Nephrologist, Indraprasth Apollo Hospitals. A memento for Dr. Ashwin Dalal, Head, Diagnostics Division, Center for DNA Fingerprinting. A memento for Mr. Saurabh Singh, Co-founder and Director, Rare Diseases, India Foundation. A memento for Mr. Arjun Gupta, founder and CEO of Genetico Research and Diagnostics. And a memento for our moderator, Ms. Oshin Santoshi, Patient Advocacy Manager, AstraZeneca. We would also like to thank two of our speakers who have joined us virtually. Big thank you to Dr. Ashwin Dalal, Head Diagnostics Division, Center for DNA Fingerprinting and Diagnostics, and Dr. Priyanshu Mathur, Associate Professor of Pediatric Medicine, J.K. Lone Hospital, SMS Medical College. So, big thank you to all our speakers who joined us virtually, and I request everybody to gather for a group photograph. Thank you. Yes. Thank you to all our distinguished speakers, partners, and participants for contributing to today's discussions. Your insights and commitments are essential in building a more inclusive, responsive, and patient-centric rare disease ecosystem in India. Thank you all for joining us, and please do join us for networking tea.
रिकॉर्डिंग हो गई ना कंप्लीट? हाँ, एंड कर।
Recording stopped.